During the 20th century, there was nothing for renal cell carcinoma. Then there was the anti-angiogenic agents, and now there is immunotherapy. And even more than immunotherapy, when you have a medical oncologist, what he's going to do, you give him a drug, he puts another drug. So he will do a combo of immunotherapy to deal with the advanced or metastatic renal cell carcinoma. And Laurence will explain you how you select the patient, on which criteria, what is the first line, what is the second line. And one of the issues that we have when it comes to renal cell carcinoma is how we doing a partial nephrectomy, because I would say 50 years ago, you had a kidney cancer, you take the kidney out. That was simple equation. This is not the case anymore. So do you do a biopsy? Do you take out the tumor? Can you leave the remnant kidney on site? This is the question, so technical issue. And is it a metastatic cancer? It's very important because once again, the urologists, they didn't think, oh, there is a kidney tumor, I take out the kidney. And that was have you heard about the Carmena trial, which was released 2 years ago already by my good friend Arnaud Méjean. He's a young urologist working in HEGP. And he promoted this trial at the ASCO, at a time where ASCO was not virtual. So in front of 30,000 people. It's a big room for concert. Thing that you have to keep in mind is not only the size of the tumor, is the location, and I would say the anatomic structure of the tumor and whether or not it is next to the vessels. Because the tricky part is that it can be next to the vessels, so you can have a 2 centimeters tumor. It seems very easy on the paper, but it's very difficult to remove it because it is next to the renal ileum. So you have to discuss the location of the tumor within the kidney. And of course, if you are dealing with a young patient, you have to raise the point if the patient is likely to belong to an hereditary spectrum, such as VHL, for instance, because you know that he will maybe, during his life, face multiple tumors. So you don't want to take out the kidney in a patient who is likely to recur and who is likely to have another tumor on the other side or once again in the same kidney. So it's very important to have this. So you have stage 1, stage 2, stage 3, stage 4. It's very classical. The TNM, you have that in mind. You have the EAU guidelines. And you look at the incidence versus mortality of renal cell carcinoma in Europe. And you can see that, for instance, it's not good in Europe to live in Czech Republic. If you don't want to face kidney cancer, look at the mortality and the incidence. It's very different to what happened in Italy. So I don't know if it's the beer or the food, or I don't know what happened in Czech Republic, but obviously there is a huge incidence of kidney cancer. But as a urologist, it's a good country to target if you want to perform a lot of kidney cancer surgery. So what we have seen is that in the last years, after I would say with the advent of all the imaging, especially in the field of medicine, most of the renal cell carcinoma which were diagnosed before were diagnosed because of gross hematuria, pain, symptoms, and so on, which is not the case anymore for the simple reason that we are doing a lot of ultrasound, we are doing a lot of CT for another reason. So one patient is coming to your office for GP complaining about, I don't know, pain in the abdomen. Then you perform a CT, and I would say by luck or fortuitously, you will diagnose a renal cell carcinoma. And most of the cases that we have in our office are coming from this pathway of diagnosis, meaning, I would say, random discovery of renal cell carcinoma. This explains the stage migration, because a few years ago, we were diagnosing more and more, I would say, advanced cases, which is not the case anymore. Of course, if you work as a medical oncologist in a high-volume centers, you have a vision which is totally biased by the fact that you will attract as a reference center many cases. And Laurence Elbiges is a good example of this situation because she believes that there are only metastatic kidney cancer. But it is not true. She lives in a world where there are a lot of metastatic kidney cancer because she's very well known in that field. So she attracts, I would say, all the metastatic kidney cancer of the area. But the reality of the practice, as a urologist, you will not see that much metastatic kidney cancer. There is also the problem of cystic lesion. And you have to be aware about that all tumors in kidney cancer are not solid tumor. So there are cystic lesions. And cystic lesion comes with a classification which is called the classification of Bosniak. Are you aware of that? So the Bosniak classification were there to depict whether or not a cyst, which is quite frequent, I would say, in a kidney, is likely to be a cyst in relationship with a tumor. So you have the aspect of the cyst, you have the existence of some septa, calcification. There, I would say, many radiological criteria that will make the cyst a good candidate for a surgery. If you discuss sometimes the biopsy in your department, you say, oh, I don't know if it's a bladder tumor, kidney tumor, really, I will do a biopsy and so on. You will never discuss in a situation of a cyst, of course, because it's like a tumor with some liquid inside, so you should be afraid of the dissemination, potential dissemination, so you will never biopsy a cyst, okay? Very important for you to have that in mind. So the biopsy can be discussed, and who is doing biopsy in his department of kidney cancer? Nobody? Okay, you take out. This is the case also in my department because we rely on the assessment of a very good radiologist. And it's absolutely important. Anyway, I'm saying that she's, because it's a woman, Professor Renard-Pénin, a very good radiologist, but we look back at the pathological assessment over like 500 cases of kidney tumor that we removed, and up to 12% of these tumors were benign tumor. So it's okay because we didn't take out the kidney. But anyway, I'm just saying that sometimes the radiologist is good. She has a good, I would say, predictive value. But sometimes, if you have a patient who is an elderly patient and you hesitate and there are severe comorbidities and the anesthesiologist is reluctant and so on, you can discuss the biopsy. This is why came out the concept of active surveillance that you know from prostate cancer, comes out also in kidney cancer, in very old patient with a small exophytic tumor, slow growing process, and you say, okay, he is not or she is not as a patient in a perfect condition, suitable for surgery, I could wait. You are going to tell me, okay, but in 6 months or 2 years, she will be even older. So my point is just to tell you that in some patients, it's better to consider that she or he will die with his kidney cancer, but not from his kidney cancer. So you have to accept that. And when you do CT, you will discover a lot of diseases. So I told you, with the development of imaging, there are a lot of patients coming to your office because of they had no symptoms and the discovery of fortuitous, I would say, disease. So I'm not saying no to the biopsy, and you have to be open-minded as a physician. It's not because you are in a team where there is no performance of biopsy that you say, we should never do that. Sometimes, from time to time, there are, I would say, windows of opportunity to do biopsy. But I would say that in daily practice is not very, as far as I know, extremely meaningful. One point is that for metastatic renal cell carcinoma, it's very important, of course, to have a biopsy. Because as a urologist, you say, okay, he has several locations outside the kidney. I'm not going to deal with this patient. Goodbye. Go and see the medical oncologist. Please, if you want to take care, I would say, adequately about the patient, you need to refer the patient or at least to organize the biopsy because it will influence the treatment of the medical oncologist. And you have to know that most of the trials, and I think Laurence will emphasize this point, most of the trials that are available in the literature are dealing with renal cell carcinoma, clear cell carcinoma. This is a big issue because as urologists, we face a lot of tubulopapillary which is another category of histological variant. And for this patient, metastatic or locally advanced, we have not that many options. So it can be tricky, and it's absolutely important to assess the subtype, histological subtypes of renal cell carcinoma you are facing. So the biopsy is perfectly indicated in case of locally advanced disease, where you will discuss, I would say, the medical treatment first, and eventually, if the patient is young, good profile, good performance status, and good responder to the medical treatment, as a second step, the surgery, but it's quite rare. So renal mass, this is the flow chart that you could use, for instance, and you have also some systemic disease such as lymphoma, abscess. So there are situations where, from time to time, it's never a good situation when you remove a kidney. You say, you had a big tumor, and the diagnosis come back, you say, it was a lymphoma. You look a bit ridiculous. It happens. So be careful if there is any atypical imaging, you have to go for the biopsy. And if you deal with an advanced disease and you will treat the patient together with a medical oncologist, you have to go with for a biopsy. So that has to be clear. But in the vast majority of cases, you will not perform a biopsy. Okay? Well. So, as I told you, on the paper, it's very simple. You have a tumor. It's exophytic. You can see it. You remove the tumor. And you go to drink a coffee. Okay, that's okay. But this is an organ like the liver, which is the kidney, which is extremely vascularized. And meaning that you can have a huge bleeding, and you have to be aware of some tips and tricks that makes the situation more comfortable for the patient and for you as well. Okay? So meaning that, of course, you can discuss partial nephrectomy, but it is something that in daily practice is quite complicated. So I'm not, as I told you yesterday, going to go into too much details about surgery, because it's not the purpose of this course. We want, during the 2.5 days, to go through all the medical aspects of all the spectrum of uro-oncological cancer. But anyway, you have to understand that when it comes to kidney cancer, surgery has an important part. So you will discuss also the surgical approach, and we are living in a world where it's complicated, because 50 years ago, you would have been a doctor, you would have said to the patient, this is the way I will make the surgery. Now the patient are coming to your office and say, this is the way I want you to make surgery on me. You perform a robot, you use the laser, it's the Star Wars generation, you know. If they have laser, robot, and so on, the patient, yes, do surgery on me, I love you. But if you say, no, I'm a good old school surgeon, I will old-fashioned, I will remove the kidney, I will do it very well, the patient will be reluctant, say, no, you are not a modern surgeon. They don't care about your data, if you are a fool manipulating a tool, or they don't know. They just want to be operated on with a robot. So it's totally irrational, and you cannot, especially in France, I don't know how it goes in your country, but in France, any patient is likely to choose his doctor. It's not the case in England, for instance. You go to the doctor you have been referred to, and there is no other option. In France, you are not happy. Last time I was in my office discussing with a patient at my clinics, and he told me, could you rush a little bit, because in 5 minutes I have to be at Montsouris, and in 2 hours I will be at HEGP. I say, sorry, excuse me. And can you give me back my CD, my imaging? Okay. So on the same day, do you understand that the Social Security is likely to reimburse a patient for the same advice about the same disease 3 times in a row? It's true. So, and we are dealing with cancer, but the same story is true for functional diseases. You have urinary leakage, you go to see Professor, I don't know, François Hab, then Chartier-Kastler, then on the same day, and you will be refunded. So at the moment, when they are saying, well, we are bankrupt, there is no money, okay, maybe we can discuss that after the 3rd clinics about a urinary stone of 3 millimeter, maybe we could stop to reimburse for the 3rd advice. So there are many things that we could do to make the system goes a little bit better, because it's free, so people say, okay, let's go. Let's have many options. One of the issues that we have as a surgeon is to decrease the ischemia, because as I told you, you can face a bleeding during the surgery. So what you want to control is the artery, and if you control for, I would say for time, which would be excessive, the artery, then you will injure the kidney. And so it's very important that when it comes to the clamp, to keep it below 30 minutes. This is why I'm telling you that on the paper it seems to be very easy, but it could be technically tricky if you don't want to end up with margin, with a patient who was how do you say, Elias, groupe sanguin en anglais. Blood type, yeah, with the blood type, which is different. When he came in the OR, he was A+, and then he's leaving the OR, he's O negative. So because you had so much transfusion, and so it's absolutely important for you to understand that it could be, it can be complicated. And you see that the learning curve of a surgeon is coming from the report that he's doing during the surgery. Because they use at the beginning, and I was one of them, a lot of what we call hemostatic agents. So Flow-Seal, Tacosil, and when the surgeon is very confident, it's just a running suture. And it's very elegant. So look at the medical surgical report. They say, we use 3 times Flow-Seal and was Tacosil, and then we put some Vicryl, what is it? Mince, I forgot the name that you put in the prostatectomy. Qui ressemble à une compresse. Surgicel. So, there are other techniques to deal with cancer, and we have to be aware of that. Not because we believe that it is the option or a better option than surgery, but you have to be open-minded, and the patient are coming to your office to challenge you and to say, are you sure that I need to undergo surgery because there is this cryotherapy technique? Or so you can freeze the tumor, or you can eat it. And it is true in many, many solid, I would say, tumor. This is an opportunity. So maybe for a small exophytic tumor, it's interesting. So some surgeons, they want to keep the opportunity to deal with the patient. So they say, okay, we will freeze the tumor, but I will do it laparoscopically. So anyway, so it's like a desperate movement to try to keep something and don't want to give it to the radiologist. So yeah, climate changes. This is global warming. No, I could do this slide with the virus, no, and the COVID-19. This was, remember the EAU? It was 15 years ago. No, you were not in medical school. There was a volcano erupting in Iceland, and all the airplane traffic was locked in Europe, and I think all over not in Europe. It was disturbed and performed because just of the smoke of a volcano. Do you remember the name of the volcano? Can you pronounce it? You can pronounce it at the end of the dinner when you are when you are totally drunk, because this is the name of the volcano. Is Eyjafjallajökull. Voilà. It's very complicated. So, but I remember this situation because me, as far as I am concerned, I came 1 year before. No, 1 year, very much in advance. 1 day before the Congress. So I was in the event where was supposed to be like 20,000 colleagues, and I was alone in the Congress Center. So this year I received all the prizes: best award, best presentation, best. I was alone. So I was the chairman. I was giving myself the prizes and so on. And so one day, some guys looked at my curriculum vitae, CV. I say, wow, this year you were very good. And of course, I'm not saying that there was the volcano this year. I say, yes, I was, very committed to this event and so on. I have like 25 prizes from this event and Congress. So if there is an opportunity for you to go to a Congress when they award you and so on, please use the opportunity of the COVID-19 to get awarded and to have a lot of prizes. It will be good for your own, I would say, career. So the face of surgery has changed when it comes to kidney cancer. It's true in wall surgery. And as I told you, it's the Star Wars generation. So now people are begging on their knee in your office, please make a robotic surgery on me. And this is a problem because if you don't have a robot, then the patient are leaving your office now, and it's absolutely irrational. But this is the way it is, and at least sometimes they can discuss with you if they know that you have access to the robot. You have the robot, you don't make the surgery with the robot, but it's in the hospital, you have it, yes. Okay, you can make the old-fashioned surgery. But they just want to know that you have this opportunity. So this is the Da Vinci. Da Vinci is the name of the company developing the robotic surgery. And there is, to date, one unique platform that can come to the, I would say, surgical room, the OR, which is the Da Vinci. It will not be the case within 2 weeks or 1 month, because there are new robots coming. There was one unique company, Da Vinci, making a lot of profit, making a lot of money. But no. And do you know who is using which specialty of surgery is using the robot the most all over the world? Huh? Yes, that's true. So I said surgeons. Can you realize that it is a shame to use a robot to cut your tear? So, no, anyway, this is true that the gynecologists is the specialty which are using the most robots. And actually, initially, it was developed for cardiac surgeon because it was supposed to be used far away from the field for, I would say, military doctors who were likely to make the surgery, I don't know, from, I don't know, you say porte-avions. Porte-avions? Aircraft. He's my translator, official translator from Lebanon. So aircraft carrier, well, Top Gun, quoi. And so they were likely to perform the surgery from the boat, and people were injured on the field. It was never used like this. The cardiac surgeon, they left the field, I think. And so the urologists for many, many years were the people who were using the most the robot and not the gynecologist. Why? Because the robot is perfectly adapted for pelvic surgery, where you do not change the location, I would say, of the target of the organ that you are going to remove or to dissect. When it comes to colorectal surgery, it can be tricky, for instance, because you will go from the pelvis, the left column, then you will move. So when the space within the belly is quite large, there is now, with the next generation of robots, this opportunity to be flexible with the table and with the robots. It's called the XI. But anyway, for many, many years, only, I would say, the very focalized surgeons could use that. And most of the time, it was for the urologist and not the gynecologist. So all roads lead to Rome, to Roma. This is for my friend Alberto Bossi, because he's from Belgium, he's from France, but most of all he's from Italy. And when I see him with his colleagues in Congress, ASCO GU and so on, he's so happy to speak Italian with Alberto Bossi, with Alberto Briganti, and they are together and so on and so on. So this is what I miss the most from these international congresses, all these languages. No, Alberto is committed to speak in French and sometimes in English. Are we performing the same surgery? It's just a question. Are the results superior, identical? I'm just telling you that when you have a drug, I told you yesterday, it's very easy to test it, very easy. You have a drug, you have a company, and the company is developing the drug. So the company will afford a lot of money to have the drug assessed in a phase 2 and a phase 3 trial. So the company will deliver $25 million for one trial. And do you realize that the keynote, for instance, we are discussing the keynote, there are at the same times more than 100 keynotes undergoing all over the world, meaning that they test the pembrolizumab in many, many options. Very large umbrella. So 100 multiplied by 25 million. And you realize that there is no issue. If you come with your startup, you have an idea and so on, they are big guys in the field of, I would say, pharma, and they want to stick with the methodology, and they want to stick with evidence-based medicine, and they want to stick with the fact that if you publish in a big journal, then you will have a high level of evidence, and then you will have a big grade of recommendation. There is a business behind it. I'm not criticizing the fact that this is not the way to evaluate the situation, but there is a business. You should be aware that 85% of the articles that are published in the New England Journal of Medicine are issued from pharma company. It's very rare to have a trial, for instance, evaluating the advantage of laparoscopic surgery against open surgery in hernia repair. There is one big trial about that. This is the reason why I'm talking about it. And this kind of paper, not supporting by, I would say, pharma company, are, I would say, really pure, so-called pure paper, because any trial supported by the industry is coming out very rapidly, very quickly, because it's a question of money and the way they invest. So it's very important. And the journals are making a big competition, New England, Nature, Science, together. So there is also a business in the, I would say, editorship area, and it's very important for you to understand. So different surgical approach is just a question of cosmetic aspect. But you are going to tell me, okay, he was not a model anyway. He's 82 years old. And so what is your argument? Say, well, he will not have a big scar. Okay, but look at him. The other point is he will be back to his activity very rapidly. Okay, he's 82. So what is his activity? Watching Netflix? He's very active. He will help the society to move on and so on. So sometimes, as surgeons, we are a bit, I would say, short of strong arguments to say, listen, my friend, the robot is the way to go for the simple reason that it is ergonomic. It is much more comfortable for the surgeon. This is a reality. You see it, you can discuss. It's very elegant, and so on and so on. So there are some, I would say, points that you cannot explain with the field of evidence medicine. But the director of the hospital, he doesn't care. If he tells you, have you ever done a laparoscopy? You stand all the day, you are like this. At the end of the day, regardless of what is your own situation, medical situation, you shake. It's impossible not to shake. When you hold something for hours, you will shake. When you are using a robot, you put your elbow on the deck, you have a 3D vision, it's very comfortable. So the third case of the day, you perform it in the same environment as the first case of the day. I wish that you are in a good health condition, but the probability that you in the room will never undergo surgery between now and your age of 82 or 85 years old is very low. You will have to undergo surgery. So you are a doctor. And you will go to the surgeon office, and one thing is that when the surgeon is nice with you, he will tell you something. Not the price of the surgery. He will tell you, I will put you first in the morning. This is an advantage. And everyone knows it. You are not waiting in your room until 5 in the afternoon, and then the anesthesiologist shows up and says, you are cancelled. We are not making your surgery. It's very often in France that we have this situation, because anesthesiologists, they are not very involved in the management of the patient. They don't care. First in the morning, but also first in the morning because the surgeon is cool and fresh, and you understand subjectively that is the best slot for you to get the surgery. Meaning that the reproducibility we were discussing yesterday with the pathologist and so on, it's also a true story for the surgeon. Even if you are a great surgeon, even if you have a fantastic surgeon, at the end of the day, you receive many calls, the environment is very aggressive, and so on and so on. So when you perform the surgery at 3 p.m., is not having the surgery at 8 a.m. So the point is that with the robots, at least you have some reproducibility and in the, I would say, surgical behavior. So it's very important. So typically, this is the kind of case, Monday morning, that I will have to do in my hospital. When you see that it is tricky, because you say, okay, should I take the kidney out, or should I perform a partial nephrectomy? And you have also to explain the situation to the patient. And when it comes to surgery, it's very important that you deal with the complication. And they don't want to look at the literature. If they come to your office in Paris, you say, there was a big trial or a big series, retrospective series from New York, but you are not in New York, you're in Paris. So please, check your own complication in your own, I would say, population of patients. It's very important to report your complications. You say, you know, in our experience, we do like 200 a year. We have 5% of complication, and this is the type of complication we are facing. When you sit in an aircraft and it's going to take off, they are not saying, you know, they are saying there is a mask in case of loss of pressure, put it on your face and then to your child and so on. But they are not saying if we burst, if we lose a wing. So at some point, everyone would be reluctant to travel on a plane. And you all know when you're jumping or when you're sitting in a plane that you can die at some point. You know it, but you don't want the pilot to say it to you, okay? You know it. You think about it, and then you take your Diet Coke and you look at Netflix, and you say, it will not be me. It will be another plane. But inside you, you know it. The problem when you deal with complication and you explain comorbidities to a patient is exactly that. Where is the limit? What should I say to your patient? Of course, you can end up in intensive care unit. Of course, you can die. But it's very, very rare. So you have to communicate with the patient, but ease also the situation by providing, I would say, the most frequent complication that you face. And the most frequent, if you do a lot, is perfectly acceptable. Yes, sometimes we have big blood loss and you can have a transfusion. Yes, sometimes you have a urinary leak and we have to place a catheter. So anyway, what you can do is to give, I would say, information data or some form that you will have from your laptop, you will print and explain to the patient, and you tell him, read it. If there is anything you don't understand, you can come back to me. So the French Association of Urologists, they have many forms like this, and if there is medical legal issue, and you have explained everything, and you said, look, I gave him the form, he read it, he was aware, it will ease the process if there is a lawyer against you or if there is any issue that you will have to face outside the field of medicine. Okay, so please keep in mind the indication of the biopsy. Please keep in mind the fact that you do not rely on the size of the tumor to assess the potential partial nephrectomy, but the location of the tumor. You can have a 5 centimeter tumor, which is very easy, and a 1 centimeter, which is very tricky. It depends of the location. This is why we do not say it's a 3 centimeter tumor. We say we will use the renal score, or we will say it's a 2 centimeters tumor next to the hilar vessels, or next to the cavities. And it is not the same story. So it's very important to have, I would say, a good imaging. And you as a surgeon, you have to refuse, because if you are a surgeon, you are, I would say, on call all over the day, and people are ringing you, you have emails, and you show up in the OR, the last minute the patient is already under general anesthesia, is in a position, and you take out the kidney. And it was done in Tenon 15 years ago. I was resident, I remember that, and they took out the wrong kidney. They left the tumor, and they take out so it's very difficult to explain to the patient. When you do a hip prosthesis, you can say, I didn't do the right side, but it's okay. But when you leave the kidney, and you take out the good kidney, so it is a very difficult situation to face. So please refuse to do or to perform surgery, you as a surgeon, if you don't have the images, or if you have not seen the images before you use the scalpel. It's very important. And there are many medical legal issues coming from that situation. The side, okay? And especially in orthopedic surgery. So it's okay when it's a toe surgery, a knee surgery, you can still explain, but when it comes to the wrong testicle, the wrong kidney, it makes the situation a bit complicated. So protect yourself. Use the shield, and the shield is going to be the imaging, and you have to have a nice imaging. And the centrality is the key parameter of tumor complexity, okay? So When it's here, it's very complicated. So you have some score. There is one score from Italy. It's Padua score. It's less popular than the renal score, the Kutikoff. But anyway, every score that is going to depict the centrality of the tumor is absolutely important. And you see that from the CT that I showed you, that you will have the flow of complication that you can expect is really linked to the location of the tumor within the kidney when you go for partial nephrectomy. Or you are telling me he has another kidney, I don't care. But there are many patients coming to your office because they will challenge you because they have a single kidney and they are facing this kind of situation. Of course, you can say you can go under dialysis. But do you know the life expectancy of a patient diagnosed with a cancer who would go under dialysis? Because the quality of life under dialysis is very costly for the society. The quality of life is not very good. And in addition, your life expectancy when you have been diagnosed with a cancer and you're under dialysis is less than 40% 3 years after the diagnosis. Okay? So meaning that you are not providing a good medical service to the patient on many aspects when you tell him, okay, I will remove the kidney anyway. Renal score, blood loss, and I think, is Laurence there? Or who is speaking? Alberto, it's your turn now. There is room for radiotherapy in kidney cancer? Of course. Okay. Yeah, I'm done. Bah oui.
So, is there a role for radiotherapy in treating renal cancer? This is something which has already been tackled by someone that you probably know. Who knows this man? This man gave us 10 commandments, as you know, if you are monotheist. But he also gave us the 11th commandment, which was, they shall not use radiotherapy to treat renal cancer. It does not work. This is what you can still read on a lot of books, especially if they have been printed by urologists some 15, 20 to 50 to 100 years ago. So I will try to show you that this is not the case. First case scenario, you see there is a little one up there, first case scenario. We all know now that as for a number of other cancer, a number of other oncological situations, metastasectomy, so the idea of taking care of metastasis by an active ablative therapy, whatever, can improve a lot of endpoints of the patients. Not only the most, if you want, simple one, which is quality of life. Metastasis can cause, of course, a lot of local complications. And if you treat the metastasis, you may prevent those local complications. But we have some hints that, at least in some oncological situations, this may translate in some advantages in other important endpoints. You remember we discussed yesterday with Enrique Grande from Madrid, the impact of this concept of abscopal effect. I'm not totally sure this may explain some effect you have in treating the metastasis, but still we know this. And we know, this is Lancet Oncology 2014, that local treatment for metastasis of renal cell carcinoma may work, may impact those patients. If you look at forest plots for overall survival or cancer-specific survival, in a lot of studies that have compared doing something or doing nothing for distant metastasis in kidney cancer, you clearly see that all these studies goes in favor of metastasectomy with hard endpoints. Overall survival, cancer-specific survival. This is not randomized evidence. Okay, so you are not going home on Monday saying we have the proven efficacy of treating the metastasis, but this is hypothesis generating. And this is important for our patients. So all studies going in this side. Radiotherapy is maybe another technique to treat metastasis of renal cell carcinoma as we use radiotherapy to treat metastases from other diseases. Bear in mind, I'm not speaking about radiotherapy as a palliative role, okay? I'm speaking as radiotherapy in this role you have seen with hard endpoints. It's true, and I mentioned this yesterday too, that radiotherapy is certainly not useful if you consider conventional fractionation, 1.8, 2 gray per fraction. I guess also the known radiotherapist in this room knows what I'm talking about when I talk about conventional fractionation. This is how the world of radiotherapists have used radiotherapy for years, and this for sure is not the right fractionation for prostate cancer. Evidence, and I will speak about this, is growing, showing us that probably fewer fraction at high dose may have a totally different impact on the radiobiology of the disease. And we call about stereotactic body radiotherapy. You're going to back to this later on. With dose per fraction of 10 grays, but also up to 15, 25 gray per fraction. This is totally a different radiobiology, a totally different impact of radiotherapy on the biology of the cell. I will have a slide on this. And this may translate in some effect in renal cell carcinoma. So that's why if you look to all text of the management of renal cell carcinoma, radiotherapy is not mentioned. Because at that time we didn't know. Of course there is no level 1. The study I showed you about metastasectomy were all done by surgery. But there is probably no reason to think that radiotherapy may have a role on it. This is just to show you what is the treatment planning of a lesion which is treated by stereotactic body radiotherapy. Please, and I will come back to that, I'm not saying here that there is a specific machine that should be used. We also have our robot in radiotherapy, which from some aspect may have the same kind of approach as Morgan told you. Okay? So also in terms of, for example, advertising special techniques, you can see people now, of course, advertising for robot in the surgery, but you can see also radiotherapists advertising for CyberKnife. I'm not talking about CyberKnife, I'm talking about stereotactic body radiotherapy, which you can do with different machines and also CyberKnife, but not necessarily only with CyberKnife. The dose distribution you obtain on this metastasis here is so much better as compared to what we obtain with 3D or IMRT techniques that makes interesting this idea of applying stereotactic body technique to give such high doses. So the concept for you, take-home message, conventional techniques of radiotherapy, 3D conformal, IMRT, do not give you the possibility to deliver such high dose as needed in renal cancer if you don't have stereotactic body radiotherapy technique available. So I told you yesterday, Belgium are upfront, radiotherapy colleague in Belgium are upfront in trying to promote radiotherapy for kidney cancer, and Gerde Merler from Leuven has also looked at this meta-analysis of how radiotherapy has been used to treat metastases. And you see here a lot of treated sites, a little bit all comers, but when you are, of course, starting a new technique, starting a new strategy, you have to take a little bit what comes. You cannot stratify correctly. The number of lesions that are treated are here. The follow-up is there. I think that, of course, we have published local control results, as you can see there. But to me, the most important, for the moment, results are the one on the adverse events. Because, as you know from Latin, don't forget we are all doctors, before being surgeons or radiotherapists, is primum non nocere, which means, first of all, try to make sure that your technique is not harmful for your patient. And when you see those kind of data, grade 3 and more than grade 3 toxicities, Well, you are somewhat reassured. At least I know I'm not doing bad to my patients. Time will come to show that this is helpful, of course. This should be shown in a correct and very well organized way, but at least we have this sort of data. Also the UDOU group, you are probably aware of the French group for urinary oncology, genitourinary oncology. We have collected the data exactly in the same situation. Of course, we don't have more than 200 cases that have been treated in several French institutions in which we can do high dose, extremely high dose radiotherapy, not 2Gay perfection, okay? We get rid of those because we know that those was totally ineffective. We have the results here. Again, it's not that important that we try to understand if those curves are good or not as compared to something else, but there is some effect of local radiotherapy in these situations. But then the point comes to ask of ourselves if radiotherapy may also be an effective treatment to treat the primary in renal cell carcinoma. Why not? If we have the technique, the technology to treat the metastases, very high dose as I told you, these may hold true also for treating the primary. And we had, it's not very recent material, look, 2005, this is published on the European Journal of Radiotherapy, which is called Radiotherapy and Oncology. This is one of the first series of patients, not that many, I admit. They didn't have any sort of nephrectomy because of medical reasons, and they were treated with this concept of high dose. So you see here, 5, 10 gray per fraction, very shy, timid, high dose. I told you, we may use even higher doses, but at that time, okay, people were a little bit frightened by the idea of using higher dose in the abdomen, okay? Of course, you may evaluate the result following several endpoints. You ask yourself, are your patients living longer? If you don't treat them, don't forget these were patients not amenable to surgery because of medical conditions. You may ask a lot of questions, but still, what we have is a local response which seems to be encouraging, okay? I will not go much further because we don't have the data to go much further up to now. These are the survival curves, but again, I put it in red up there on the right-hand corner, which is to me still the most important result for these studies, which is kidney function okay. What does this mean? That this study with this kind of radiotherapy didn't impact too much on the kidney function. And this is important for our patients. European Urology, 2006, you know probably the man who was signing this paper, he said there may be a role for ablative high-dose per fraction radiation on human implanted renal cell carcinoma in mouse. So in parallel of what I'm telling you, the first data in the clinic, we also had some nice work on ablative dose of stereotactic body radiotherapy. So just a few slides on what is the concept of stereotactic body radiotherapy. The concept is defined by 3 or 4 points that I guess also surgeons should be aware of, because stereotactic body radiotherapy, as I told you, become our robot. And you are dealing with radiotherapists. You will discuss stereotactic body radiotherapy indication for your patients in the future more and more. It's probably interesting for you to know that first, this means a limited number of very high dose per fraction. So you don't do stereotactic body radiotherapy if you see the report 25, 30 fraction. What is this doing, this colleague of mine? He's selling stereotactic body radiotherapy doing 25 fraction? They will, the machine you will use multiple fields, not 2, 3, 4 fields, as we have already been doing for years in the field of radiotherapy. They use multiple fields which are only a few millimeters larger than the target you have to hit. You know, the concept of radiotherapy using margins of 1 centimeter, 2 centimeters, if the organ is moving, for example, in the thorax. No. Stereotactic radiotherapy uses margins of a few millimeters. You are highly confident in precision. You have to put in technology that gives you the possibility to exactly target your organ you want to treat precisely. And of course, this tells you why we don't want to go for 25 fractions, because this technique, to target as you have to do the organ you want to treat, are very time consuming. It may take you 45 to 50 minutes to target correctly, for example, a renal lesion. And you don't want to do this for 25 times. This is too time consuming. If you are confident in your precision in terms of repositioning of your patients and treatment, you can treat it in 5 times, 2 times, 1 time, if you are confident in it. You have to have the technology to be confident. You will have extremely conformal dosimetry. What does it mean? That the dose will immediately goes down from 100%, the one that you want to give, to 0% in a few millimeters. And this is a question of technology. You cannot do this with simple machine. This man invented the concept of stereotactic body radiotherapy. He was not a radiotherapist. He was a brain surgeon. He had the problem of treating small lesion for which he felt at that time, look, 1951, okay? He felt that his surgery would have been too much in terms of risk of side effects. So he thought we may maybe target this with the stereotactic method. So that's why stereotactic radiotherapy was born, first with and for intracranial targets. And he invented this sort of helmet. As I told you, he had to fix the brain in order to make sure that he was targeting correctly the lesion he wanted to treat. And so he had to make his patient firmly fixed to the machine. And the first machine he invented was the gamma knife. Have you ever heard about the gamma knife? Probably you have, because there are still some of those used in the clinic. The concept is very simple. You have a 200 little sources of cobalt. They all send a ray which you may target correctly where you want. You see here. And all you have the helmet that I showed you, the patient would be put it there. So again, this concept of precision and repositioning of your patients. Nowadays, we may do something else. And Morgan has left, but this is not Morgan's dentist chair. No, this is a cyberknife. This is our robot. This is extremely costly technology. But as I told you, stereotactic body radiotherapy does not necessarily need a cyberknife. Okay, we have one at Gustave Roussy, but we are doing stereotactic body radiotherapy also on other machines, which nowadays have sufficient precision in repositioning of the patient to satisfy the list of requirements I told you. Okay? But this is a robotic arm that will turn around the patient, which is, you know, on this chair or on this bed, and you may move the bed, you may move the robotic arm of the linac, which is miniaturized inside it. Okay. 2 words of biology, because I guess this will only be the only possibility you will have to understand a bit how this high dose in renal cancer will work. So this is the most standard treatment you may imagine. 74 gray given in 37 fraction. I guess you are familiar with this for prostate cancer or whatever. This is what you do. You see here some strange Greek symbols. This, in the radiotherapy vocabulary, refers to the radiosensitivity of tissues. Not all tissues are reacting the same way. Mucosa, inside the mouth, in the bladder, in the rectum are reacting to radiotherapy totally differently as compared to tumor tissue. How to evaluate, how to take into account this by this concept of the alpha beta that you see up there. Okay? So 3 gray correspond to a certain radio sensitivity, 2 gray correspond to a totally different one. It's just 1 gray difference, but you will see that this difference may be extremely important as soon as you move to less fraction. So here the total will be 74. Here you give 5 times 5.5 gray. And if you do a little calculation, you may say, well, but this is inferior to 74, okay? But biologically, these correspond to a higher dose, 80 gray, because of the radiosensitivity of tissues. So you don't have to stick to mathematics, but you have to think in terms of radiosensitivity. And the exercise is even more important if you move to only 3 fraction. You do 3 times 10 gray, and these are the doses that you may get if you take into account the biology of the tissue. If you do 1 time 25 gray, this is the range of the dose you are giving to your tissue, 140 to 168 gray, not 25 gray as the same here. You got it? So this explains why the higher the dose, the higher the biological effect you may get. And this is what we are looking for when treating renal cell carcinoma. And this is why we are treating it with high dose. And we want to be in this situation, certainly not in this one. It has been shown that the biology behind of this is a very clear-cut one. When you go with different several fractions, what you are hitting is the nucleus of the cell. Okay, with several effects, which is not important. When you are hitting once, 25 gray, 1 only fraction, you are probably impacting on the wall outside, disrupting the metabolism there and killing the cell with a totally different mechanism. Okay? I don't want you to remember all this, but just to realize how different things can be on the biology. And so we had the first series of patients based on this treated with 1 single fraction of 25 gray using the CyberKnife that I showed you. And this is 2015, so it's not new material. Of course, few patients, all inoperable, or having 1 kidney, for which the surgeon would say, I'm not very willing to go for surgery on the remaining kidney, let's try radiotherapy. 1 shot, 25 gray, is not 25 gray as you may imagine given by 2 gray per fraction, as you know now, is much higher the dose we give, is much better the result we get. Again, I'm not that much interested in showing you the efficacy outcomes of those patients because it's such a few population which, I'm not confident on that. But what is important is the toxicity for the moment. Very few side effects due to such a targeted treatment as I showed you. Shankar Siva, which is a radiotherapist from Australia, Melbourne, has put a lot of efforts in these last years to at least trying to put together data, because we are all, as radiotherapists, treating some patients in these situations. But what we need is to put together data. So he had the idea of founding this IROC consortium, as you can see here, Cancer published 2018, and he tried to put together patients 2023 that were treated with this indication. So we are not speaking about metastasis now. Don't forget, we are speaking about treating the primary in the kidney. And he also was able to compare these 2 strategies. Let's use 1 only fraction or more than 1 fraction, because this is a debate. I showed you the data. Of course, giving 1 fraction of 20, 25 grays is much more technologically demanding because of precision, blah, blah, you know why now. But still, this is probably the way to go. Also in our series, clear cell carcinoma are the most irradiated one. Tumor dimension could also be evaluated with precision. And these are the total dose. So when you use one fraction, 25 gray, as you can see here, more than one fraction, 40 gray, following several fractionation scheme. If you put this in a multivariable model to check what are the prognostic factors that really impact on the outcome of those patients, you will see the number of fraction. So indeed, it seems that if you use very few fraction with high dose, this may translate in better result. And then you have the dimension of the tumor. You are limited with radiotherapy by tumor which are too big, okay? These are the curves in terms of local control. So you have a red curve, which is the one fraction regimen, and the blue curve, which are more than one fraction regimen. 230 patients. I'm not saying that these are particularly meaningful, but they are encouraging. We are not hurting our patients. If you look to cancer-specific survival and progression-free survival, probably using one fraction of 20-25 gray is better, and you know why radiobiologically. And we may use other techniques to treat renal cell carcinoma. These are Japanese techniques with carbon ion radiation therapy. These are very few teams that can use this technique because you need technology which is not, for example, available everywhere in Europe either. But this is just to give you an idea of what we can do also with much more modern radiotherapy. A phenomenon which you can see in terms of volume of the disease, and I guess that this should be known by urologists, is that if you ever met a patient treated with radiotherapy for the primary renal cell carcinoma, don't forget that in the first month, you may even see, in terms of tumor volume, an increase of the tumor volume. But this, if you wait long enough, is not the definitive. If you base your judgment on the volume of the tumor, repeated CT scan after radiotherapy, well, you may get this impression in the first month of follow-up, okay? So don't forget to wait long enough to be in the green part of the curve, okay? Third point I want to make, and the final one, you see up there, third. Is there a role for radiotherapy in the post-op setting? This was a question that in the radiotherapy community has been the argument for discussions and some little studies. This is published in 2010, Annals of Oncology. They have put together data on trials, on series of patients that have been treated by post-op radiotherapy because of prognostic factors, bad prognostic factors after surgery for renal cell carcinoma. They could put up 7 controlled studies for 735 patients, which is not nothing for such an indication. And surprisingly enough, you see that the forest plot would somewhat favor this idea of selecting patients for post-op radiotherapy, okay? So they are not saying, these authors, that this is the way to go, but this is maybe the opportunity, with, of course, very important and very impressive p-value, but this may be the opportunity to randomize patients in this setting. So, what does the European Association of Urology says about radiotherapy for renal cell carcinoma? Well, they just mentioned stereotactic radiotherapy for bone or brain metastasis, for local control and symptom relief. It's a bit confused because I guess that you know now that these two indications should be tackled with totally different treatment regimen. If you want to go for ablative and local control radiotherapy, you have to use the technology I told you about. If you want to go for symptom relief, 1 time 8 gray, 5 time 4 gray, all the techniques your radiotherapies use are far enough. But I guess you have now in your mind this big difference between these two indications. So, end of the day, I hope you are convinced now that there is a role for radiotherapy, at least for metastatic renal cell carcinoma. We probably can do as well as surgeons to control the metastasis. We certainly can do good to your patient if you believe that there is a need for palliative radiotherapy. There is possibly a role for radiotherapy in the management of primary renal cell carcinoma. So if your patient, you feel that a treatment is needed, but for medical reason this could not be surgery, don't forget that radiotherapy may help you. Okay? What about the post-op setting? We have those data that are at least hypothesis generating. I would not be surprised that in the near future the question may be posed. But technologically speaking, if you want to go for ablative radiotherapy, you have to think in terms of stereotactic body radiotherapy. This is absolutely mandatory if you want to get the same results of those groups. Is there room for randomized clinical trial? This depends on you, on the urological community. Certainly not on the radiotherapy one. It's the surgeon that may have this idea of helping the community of the patients that may not be treated with surgery to go on this way. We are seeing at Gustave Roussy sometimes patients that are exactly in this situation. For medical reason, they cannot undergo surgery, and we start also treating some patients in this indication. There are not 10,000 patients a year, certainly not, but this, I guess, is something that more and more you will see in your practice. Thank you for your attention. If you have questions.
Okay, so good morning. Welcome to all of you. For those who need a coffee, it's the right time to get one. First, I want to congratulate because very little of you are on their cell phone. So I think, Alberto, it's a big success. My name is Laurence Albiges. I'm a medical oncologist. I just want to, because I wasn't there yesterday when you had the intro, I want to check who is a urologist in the room. Okay, who is not a urologist in the room? Okay, great. My main focus is GU malignancies. I work with Alberto. At the end of my talk, I show you a picture of all the members of the team. And what I've been asked by Morgan is to cover renal cell carcinoma. So I know some of you are in the very beginning of their surgical training in terms of resident and so on. I will give the perspective of a medical oncologist, but honestly, I think what I'm going to tell you is something that you will learn with the different years of your training. Feel free to interrupt, feel free to have questions. I'm going to try to keep it as simple as possible, but I want you to have the big idea on how we treat metastatic renal cell carcinoma. Yes, so I'll be discussing different guidelines. I'm involved in those different guidelines, so this is my main disclosure. And so if you, at some point, need to make a mental break during my presentation, and if you say, oh, where can I get this information? There are at least 2 sources that you can go check on. The ESMO guidelines is the one we use as medical oncologists, and it's been updated every 2 years, and now we change it each time there is new information. So for instance, given last ESMO, that was last weekend actually, there is a major change, and I'm going to teach you this major change, but it will be updated in the coming weeks online. And then there is the EAU guidelines for those of you that are not French, or the AFU recommendation for the French among you, where you can find the same information. And it's several of us that are working in both, okay, like Axel Bex, myself, and so on. So we make sure that it's quite homogenized, and medical oncologists as well as surgeons are learning the same things. So the big picture with regard to incidence. I think it's funny because when Mustafa in the back or myself, we start our training, we used to say there is 8,000 new kidney cancer per year in France. And now it has been moved up to 12,000 every year. Why is that? Because of many patients having, like ultrasound or CT scan for which we find incidental mass, usually small kidney cancer, but there is no impact on overall survival, meaning that actually we are not curing more patients. We have more patients with kidney cancer, but this patient would not evolve towards a metastatic disease, and you as surgeon usually take good care of them, do a surgery, and this patient will not relapse. So this is something you should have in mind. With regard to epidemiology, the thing you need to know is that you have 2 males for 1 female. And there is a biological rationale for that because of the genes that are involved in kidney cancer. Some of these are located on the X chromosome, and this explains why we have more into male than female. And with regard to established risk factors, it's the very common one, common to many cancers: smoking, high BMI, hypertension, and so on. We used to learn that up to 15 to 20% present with metastatic disease. This is not true. Now it's about 10%, which is a good thing, okay? And what we usually have in mind is that 30% have a recurrence after curative intent nephrectomy. It's of course very different if you have what we call high-risk disease, large tumor, high Froment grade, ESUP grade, I should say, and these patients are more likely to progress. One thing I hope I will see in my career is the screening. For the moment, we don't have screening tests for RCC. You could think, oh, well, it's easy because it's something we could check in the urines, and for the moment, we don't have any test that help us to detect patients with RCC. So there's no screening, and there's no systematic screening, even including echography, ultrasound, and so on. So with regard to pathology, I think most of you are familiar with the vast majority of our patients are clear cell renal cell carcinoma. My focus for like 90% of my talk will be on clear cell. I'll mention the others at the end, okay? But what I'm going to show you and try to teach you is clear cell management, because this is what you're going to see. If you have a metastatic patient with non-clear cell, this patient should be referred to a tertiary center, not for surgery, because you can operate on those patients, but for systemic treatment, they should be treated in large centers, because we're trying to make the field move forward and have new drugs being developed in this setting. It's clearly an unmet need, as those tumors usually have a worse outcome than the clear cell. So with regard to biology, actually there are differences, and those differences we learn them from looking at hereditary kidney cancer. We've learned from family with kidney cancer that clear cell RCC is related to VHL disease that impacts the VHL gene that is on the 3 chromosome, short arm. And with regard to other histology, we have also learned from hereditary syndromes what are the other genes involved. So this was identified in hereditary disease. However, we now know that VHL is involved in sporadic RCC, meaning any RCC that you see, there is a VHL impairment. So we've learned from genetic and from family in inherited presentation, but it's the same biology in patients with sporadic disease. And I'll just show one slide on this, because you need to have read about HIF factor. You know prostate cancer. You know androgen receptor biology. It's a transcription factor. You know that, okay? You've all learned that. Well, basically, there is another transcription factor that you need to learn about that is named HIF, okay? Remember, transcription factor, what is their role? Is to go into the nucleus, go on the DNA, stick to the some element within the DNA, and induce transcription of gene with RNA synthesis and then protein synthesis. HIF is a transcription factor exactly as the androgen receptor. Same idea. But HIF, on a regular basis, is being degraded. So I'm going to try to check if, yeah, exactly. HIF is being degraded by VHL. VHL is a protein that we all have, and daily now, like when I speak to you, you don't need angiogenesis. You're fine, you don't have a wound healing, you are not coming out of surgery. You don't need to have a wound healing process. So what is being done is that VHL takes the HIF that is within your cells and send it to the proteasome where it is being destroyed. If you have surgery, if you have a wound healing, if you have anything that induces a stress, including hypoxia, what is going to happen is that VHL is going to stop doing its work. So hypoxia, VHL is going to stop destroying HIF, and HIF is going to do its job. And the job of HIF is to induce survival, VEGF, and other angiogenic factors. And why is it important that I explain that? Is that in RCC, we have a constitutive activation of this pathway, because VHL being impaired, HIF is not being destroyed. And then you induce neoangiogenesis. So basically, you tell your cells, or the tumor within your tumor cell is saying, I need to induce neoangiogenesis, okay? That's the constitutive alteration that we see in clear cell RCC that induce VEGF pathway, but also survival pathway. And this is very, very important to understand because our drugs are going to target this alteration. So one word on prognosis. How long does a patient with metastatic kidney cancer survive? I know you're a surgeon, but I know you've been student as well. You went to medical school, so you have some lesson about RCC. Metastatic patient, about 5 years ago, the prognosis was 2 years. And the 2 years was spread between 3 different categories. The categories are defined by risk factors that you need to learn. The risk factors are what we call IMDC criteria. I'm going to speak a lot about them because they define the treatment strategy we use. It's 6 of them, very common. You don't need to do biomarker or sophisticated biology. The first one is performance status, except that we use Karnofsky, but it's pretty much the same, okay? PS1, it means your patient is post-symptomatic. PS2, your patient has a low Karnofsky. So one poor risk factor is to have a performance status that is below 80 for Karnofsky. The second one is hemoglobin level. Very easy, you take the normal level within your lab. Okay, you don't have to learn 13, 12, 10. It's the one that is provided by your lab. Any hemoglobin below 12 for a man and 13 for a female is anemia. So one risk factor. Time from diagnosis to treatment. This one is a bit tricky because you could think, oh, it's time between my surgery, because I'm a urologist, I operated on this patient, and time to metastatic disease. No, it's time to the fact that we decide to start treatment, okay? What does it capture? It captures the fact that you have upfront metastatic disease, or you have metachronous metastatic disease, okay? Fourth is elevated calcium. Fifth is platelets and neutrophils. For those of you who initially had learned the MSK-CC prognosis model, what you had was LDH, and LDH has been replaced by platelets and neutrophils. But it's the same idea. It is the inflammatory status of the disease, okay? And so once again, you use the lab values, normal lab values. High platelets, so thrombocytosis, or high neutrophils, mean inflammatory status, means poor prognosis. So you look at those 6 factors, or you ask your resident to do it. If you can't do it yourself, you can have an app on your cell phone. It's very easy. And depending on the number of risk factors, you have different overall survival, okay? So the one I want you to know are the one here. These are the one we've learned in the TKI era, meaning sunitinib, axitinib, all those drugs. If you have 0 risk factors, your patient was about to survive 4 years. 4 years, okay? Metastatic patient, good risk, no risk factor, 4 years. 1 or 2 risk factors, this is what we call intermediate, 2 years overall survival. This is why I told you 2 years, because intermediate is the major case, most frequent situation, sorry. And then poor risk, 3 or more, it's 6 to 9 months. So as long as you know that, you're a surgeon, you see a patient that comes with a huge kidney cancer, anemia, high thrombocytosis, high polynuclear neutrophils, poor performance status. He has a survival expectancy of 8 months. Are you going to take this patient to surgery? The answer is no, okay? You're not going to waste your time and his time with 1 month surgery, wound healing, and blah, 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 and then I meet this patient 2 months and a half afterwards. And then his life expectancy is 4 months. Doesn't make sense, okay? So that explains why you should not operate on patients with poor prognosis, okay? And this is also one of the reasons why Carmina was built, but also discussed a lot. And I agree with you that poor performance status are the one you're not going to take to surgery, but sometimes you're tempted. There is a case unfortunately I didn't have the opportunity to bring today. Maybe I can email that case to the group. It's a young patient. She's 50, rather young patient. She's 50, and she had bulky tumor, anemia, high platelets, and upfront metastatic disease in the lung. But the gross majority of the tumor was on the kidney, okay? And I know the surgeon because the surgeon has been one of my residents. And he say, oh, the vast majority of the tumor is in the kidney. I think I should take her to surgery. And it has been discussed in his hospital, in the tumor board, and they say, yes, it's a bulky tumor. She has quite a lot of symptoms. We should operate on, okay? So she had surgery on the 24th of July. And August 15, she was admitted to ER for breathing difficulties and pain and so on. And she had a major relapse on the kidney bed, but also especially on the lung and on bone and liver. And so I meet this patient 2 weeks right after that, and she had poor prognosis disease. We took her to surgery, and she actually blew in, meaning that she had such a tumor spread that I had to start my systemic treatment as an emergency on the same day I met her for the first time and so on. So please, if you have a patient with poor prognosis, even if it's biologically driven, meaning 2 or 3 biological factors, discuss this with your oncologist. Looking back, I think this patient should have had a biopsy, and we should have started systemic treatment. And if after 6 months or 12 months she's fine, then we'll take her to surgery. And this happens more and more. Alberto can testify in the tumor board. After 1 year, if my patient is deriving great benefit from systemic treatment, then I discuss delayed nephrectomy. But please don't take a patient with poor prognosis to surgery, even if you're willing to do some heroic act. So I'm going to train now you on first-line treatment. This is what the guidelines were 2 years ago. There has been 2 steps in the guidelines, so I'm going to walk you through the first steps and then the second steps, okay? Before that, what we had, so 3 years ago, was single-agent VEGF-TKI, targeting what I've shown you, the VEGF axis that is induced by VHL impairment, and then immune checkpoint. Keep it simple. 2 family, VEGF-TKI and immune checkpoint. And we use that in sequence. And in the guidelines, we had to start with VEGF-TKI, and then immune checkpoint, then VEGF-TKI. Very simple. 2017, okay? But you're much younger. So what happened in 2018? The first step of the progress in first line was the approval of a doublet immune checkpoint. 2 immunotherapy combined, okay? In intermediate and poor. On which ground was this approved? On the ground of this study, you need to know this study, Checkmate 214, that used patient first line, never treated. They stratify by the IMDC that I've shown you, 0 risk factor, 1, 2, intermediate or poor. And they randomized single agent TKI, sunitinib, that was our standard of care, versus nivolumab plus ipilimumab. The primary endpoint population is intermediate and poor. Why is that? For 3 reasons. The first one is that we know that inflammatory disease are more likely to respond to immune checkpoint. So there is a biological rationale. The second is that we had data from nivolumab single agent that it works well in intermediate and poor risk disease because of this inflammatory status. So we had single agent data saying we should do this combination. And the third reason is that if you go into a very poor prognosis population, the events are occurring very fast. The patient progress or die. So you, in the race against other company, you come first, okay? So that was the rationale to go into this space of intermediate and poor. And so this study is absolutely positive, hazard ratio of 0.63 in this population for overall survival. Major benefit, okay? I presented last Monday the update at ESMO, And with 4-year follow-up, so 48 months, the same, we have a hazard ratio of 0.65. So what's happening in 2 years is exactly the same after 4 years of follow-up. So very strong benefit for overall survival with nivolumab plus ipilimumab. Does it induce tumor shrinkage on the tumor, on the metastasis? The answer is yes. Response rate, meaning, you know what the response rate is, okay? I'm going to take 1 minute to explain. In oncology, we look at 4 things. We look at overall survival, first slide I've shown you. We look at response rate. Response rate is RECIST criteria. I know you know all that, but what does mean objective response in RECIST? Do you know what it means? It means a tumor shrinkage of more than 35%, okay? So what I'm saying here is that 42% of my patient has a reduction in my target lesion of more than 30%. I say 35, my mistake, sorry. I was thinking about the primary response, sorry. So it's 30% of tumor shrinkage. I think it is very important that you have that in mind, okay? Because you can have some patients that have 20% of tumor reduction. They won't be counted in those 42% of patients, okay? So RECIST is tumor shrinkage of more than 30%, almost 1/3, okay? It's what we call objective response. It also includes complete response. So overall response rate is the addition of complete response and partial response, okay? So I've said, first endpoint, overall survival. Second endpoint, response rate. And we usually look at overall response rate, the sum of these two, complete and partial. So all that had a significant tumor shrinkage. And the third is progression-free survival, time to progression, okay? These are the 2 activity endpoints, the 3 activity endpoints that we look in our trial. The 4th endpoint that we look is safety, okay? So whenever you discuss with your medical oncologist, and he says, oh, there is this new data that is super interesting, you say, okay, explain me what was the benefit in overall survival. What was the benefit in response rate? How does it reduce the tumor? What was the benefit in progression-free survival? And what was the safety, okay? And you need to have those 4 items in mind, and this is how, as medical oncologists, we look at the data we report. So it means that you should, at each time you discuss a trial, add those 4 slides on each trial, basically. Of course, if you're in the adjuvant space, what are you going to look? Going to look at recurrence-free survival, time to recurrence, okay? But it's the same idea as progression-free survival. It's time to progression, okay? So this study was positive for primary endpoint overall survival, response rate, higher for nivo-ipi than sunitinib. And the third one was PFS, and I haven't put the slide, but now with more follow-up, the PFS is also in favor of the combination. Now I've shown you that the guidelines just put that in intermediate and poor. Remember? The white here. Not in good risk. Why is that? And then I said the primary endpoint of the population was intermediate and poor. So this is where we look at the activity. If we look now at good risk patient, good risk patient account for 20% of our patients. So it's not the vast majority. Good risk patient, what is very interesting is that response rate, this is response rate, overall response rate, is favoring sunitinib. So TKI works better in good risk. So it's exactly the demonstration of what I was saying in terms of hypothesis. Immune checkpoint works better in inflammatory disease. In good risk patient, you should stick to TKI. This is the safety data. So how many of my patients are having side effect? And it's half of my patients with nivolumab, ipilimumab, and 2/3 of my patients with sunitinib. But more interesting is how many patients I had to stop my treatment for toxicity, 22% for nivolumab, ipilimumab. So this regimen is challenging, okay? I'm going to tell you it's nice in terms of quality of life. I'm going to tell you toxicity occurs within the first 6 months only. But the more I prescribe it, the more toxicity I see, okay? And this is my daily routine as you do surgery on your patient, okay? So please, for nivolumab, ipilimumab, you have to be aware that despite the fact that it seems easy to handle and that patients have a good quality of life, the magnitude of toxicity is something that is just growing with the number of patients you treat. Moose in the back has also a lot of experience with nivo-ipi. And honestly, like my last patient, she's 40 years old, and she had an hypophysitis I had never had one. I know it's in the literature, but usually with 3 milligrams per kg. This lady was admitted because of major headache and like symptoms that were evocating a metastasis to the brain. We performed MRI, and it was immune-inflamed toxicity, okay? So please be aware that the magnitude of toxicity is very spread, and you have to work in close collaboration with not only your medical oncologist, but of course other specialty, neurologists, rheumatologists, cardiologists, and endocrinologists, and so on, GI doctors. So you have to learn about this, be trained about this, to identify. Why is it important? At the end of my talk, I'm going to spend some minutes on adjuvant. It is important to have that in mind because we're going to use this agent in the adjuvant space. So you will be the ones seeing those patients. So you need to know this toxicity. So the first step, I say, was nivolumab plus ipilimumab, 2018. Then one more step is 2019. Why is that? Because we have new strategy that came into the guidelines. These were the EAU updated guidelines with a doublet, pembrolizumab, axitinib. Pembrolizumab is PD-L1 inhibitor, axitinib is a VEGF TKI. On which ground was this drug approved? There has been 3 studies now reported with VEGF TKI plus immune checkpoint. 2 were reported more than 1 year ago, and the last one was reported last Saturday during our presidential session at ESMO. So I'm going to walk you through these data. The one I want you to remember of is this one, Keynote 426. Pembrolizumab axitinib is the one that is both in the European guidelines and in the French guidelines. Both studies were reported in New England, and the third one that just came out is also in the New England. What we know is that with VEGF TKIs, sunitinib, pazopanib, cabozantinib, axitinib, we have an immune modulation role. What does that mean? That VEGF itself is present on your T cells. And that the impact that you do with your VEGF targeting is also indirectly modulating the immune environment through endothelial cells and through hypoxia. And this is very important because it means that your VEGF inhibitor, sunitinib, axitinib, is actually helping your checkpoint inhibitor. So that's the concept of synergy, okay? And what we are seeing, so this is the impact on each immune cell component of BEV, sunitinib, sorafenib, pazopanib, and so on. And to put a long story short, I think the best demonstration is that there is a clear overall survival benefit when you combine the 2 approaches, pembrolizumab plus axitinib. And the first report showed a hazard ratio of 0.53. Of course, I'm going to compare those studies, so you don't have to do that in your mind right away. But primary endpoint is met, overall survival. Overall population. I didn't mention IMDC here. Why? Because you're also including good risk patient. You have the VEGF backbone in your combination here. Second endpoint, response rate. Objective response rate is 59.3. So basically, 6 patients out of 10 have a significant tumor shrinkage. So this is huge, okay? It's the same with the other study. And so if you put next to another, the pembro plus axitinib, the keynote, and then here, the checkmate 214, you have an overall survival benefit. Careful, I told you 0.63, but this is the ITT, the overall population, including the good risk. So you could look at the hazard ratio and say, okay, my choice is made. I'm going to go for TKI plus immune checkpoint because the magnitude of benefit for survival is more important. What is interesting here is that, as I mentioned, TKI plus IO is working across all IMDC subgroups, so you don't have to pay attention about that. And you disrespect PD-L1, okay? I haven't mentioned anything about PD-L1 because unlike in bladder carcinoma, although we know PD-L1 status is able to enrich for responders for doublet immune checkpoint, for VEGF TKI plus IO, because you have the VEGF backbone, you don't care. You don't have to look at PD-L1 expression. So this is a simplistic version. Now, with regard to toxicity, the toxicity we see with the regimen are the one we were used to see with single-agent TKI. What you can have as a take-home message is we enhance the known toxicity. We enhance the diarrhea, we enhance the hypertension, but this is This is axitinib, I think. And we have more liver toxicity here with ALT and AST increase. This is cumbersome. This is a problem for us, okay? We spend a lot of time looking at the labs, liver labs of our patient, and some of our patients develop real hepatitis. So this is something not easy to handle, and you have to have a liver doctor within your network to handle this kind of toxicity. So these are the new guidelines you need to learn, or at least that were the one until last Saturday, okay? So Pembro plus Axi across the 3 risk group, Niveau EP in intermediate and poor, okay? Very simple. That was the situation until last Saturday. And so last Saturday we had the presentation of another combination, but it's pretty much the same information. So it's gonna be simple in your head, which is the Checkmate 9ER. And here the doublet is different, is nivolumab, as in Niveau EP, PD-1 inhibitor, and cabozantinib, that is one of our VEGF potent inhibitor. And the same comparator arm. So basically the same idea as Axi-Pembro, except you have 2 different drugs. The study is highly positive on progression-free survival. I started with PFS. Look, 8 months with sunitinib is the time you have a disease control before progression, median time, okay? And 16 months, so 2-fold longer with cabo plus nivolumab. So clear activity. When we see this as medical oncologists, we're very happy. Hazard ratio 0.5 is fantastic. It's really, really good. And of course, we want to have an overall survival benefit. And we're 0.6. So we see the magnitude of benefit in terms of overall survival as well with this approach that is significant. And response rate, third endpoint I mentioned, pretty much the same. I think you remember that I say 6 patients out of 10 have a significant tumor shrinkage. Here is pretty much the same. 56% is exactly the same to me. Okay? So we have very strong benefit for this regimen as well. So don't spend too much time on this slide. The take-home message are the following. So this you don't look. It's phase 1 data that I was commenting at ESMO, but what you need to look is this one. Okay? Cabo Nivo, keynote 426. Response rate and PFS are similar for those combinations. We're in the range of 58, 60%. Progression-free survival, 15 months. So this means that we seem to have the same activity, although the follow-up is not exactly the same. We have more follow-up for some of these trials. I haven't put the updated follow-up, Abdullah, sorry, I should have. And this is the 18 months follow-up for the 9ER. So, one word for the medical oncologist in the room. What is interesting to me is the percentage of patients that have upfront progressive disease. For the moment, I've just mentioned overall response rate as the thing you should look at, but it is interesting to see in how many patients your strategy is not going to work. Take my patient that I met in August. This patient was blowing in the kidney, in the bone, in the lung. She was having difficulty to breathe. I know that I'm not going to take her to second line, and she needs to respond to my first strategy. So when I pick my combination in first line, I want to select the one that has the more chance to induce not only a response, but less likely to have upfront progressive disease. And this is where I think the new combinations are of interest. Because if you look at nivolumab plus ipilimumab, it's not on this slide because it's TKI, on a VEGF TKI backbone, the upfront progressive disease can be up to 25 or 30%. So quite a large number of patients. If you look at Axi-Pembro, the regimen that is available in France now, 11%. So 1 patient out of 10 may not respond. So 1 patient of 10 will have progressive disease, despite what I consider as maybe the most potent regimen that was available. But now with Cabo Nivo, we're getting to 6%. So in this patient, if I had Cabo Nivo at that time, I would have used that because I want to make sure she's not going to have disease progression, basically. So I select the combination that has a less likelihood to have upfront progressive disease. But this is very selected case. The vast majority of our cases are non-symptomatic and will start either with Nivo EP or with Axi-Pembro, okay? So it's just for you to understand, and it's for the discussion with the medical oncologist in the room so that they know how I think about how we should integrate those regimen. So I have 2 strategies now, Nivo EP and Axi-Pembro, and I should add here Cabo-Nivo. I did this slide before Cabo-Nivo came out. So Nivo-EP, long follow-up, I said, 4 years follow-up now, very consistent. Complete response rate 11, excellent quality of life, but the problem of toxicity that I've already mentioned. Axi Pembro or Cabo-Nivo, strong and early overall survival benefit, and short follow-up, my next slide will be on this. High response rate in my overall population. All comers, I don't have to think about this, 6 patients out of 10 will respond. Long PFS, more than 1 year, works across all IMDC risk group, while this one is for intermediate and poor, and I don't have to pay attention to PDL1. So that's clearly something that seems quite easy to handle. I will take 1 minute to comment for the medical oncologist in the room about follow-up. This is the Axi Pembro data. Initial presentation, 12.8 months. Last ASCO 2020 presentation, 2 years follow-up. The hazard ratio moves from 0.53 to 0.68. So if you increase your hazard ratio, it means that the magnitude of benefit is not as high, okay? And why is that? Because in this, you have a very potent TKI, that is axitinib, an agent that I use a lot, that is a very good TKI, but this does not induce remission, okay? And so your patients that are great responders to axitinib, at some point, they will develop resistance, which is not the case for all immune checkpoint, and very likely that CTLA-4 is behaving differently. Now, I look at the other study. I know it's small font, but the key message is the following. Nivolumab, ipilimumab, I mentioned, 0.63 on the initial report, 0.66 on the 32-month follow-up, stable at 42 months, and I mentioned 48 months with a 0.65. So here, clearly, CTLA-4 is inducing a long-term sustained benefit. And that's the rationale for medical oncologists to use nivolumab plus ipilimumab, because we believe that we'll take long-term, we'll take our patient to sustain benefit over time, okay? So what will be the next step? I've shown you there's a lot of trials that I've reported. So maybe what we want to do is the best of both worlds. We want the CTLA-4 ipilimumab to induce long-term overall survival benefit, but we want the TKI so that my patient is not going to progress. And so the ongoing trials are triplets. Nivo-EP plus Cabo versus Nivo-EP. This is super hard, okay? This is what I do every Monday with my patient that I enroll in this trial. I don't know if I'm going to survive this trial. It's so challenging to handle, okay? I look at my cell phone each time to check the liver toxicity. It's not easy to handle. But maybe that's the move forward for patients that have very aggressive disease, like the lady I was mentioning. And this is the next trial that we are eagerly waiting to hear from. So I'm going to switch now to second line, where we stand, what are the questions. I've shown you that 3 years ago, what we were doing was TKI, nivolumab, TKI. And so that was very easy. We just had to sequence. Our work was to select if we go this path or this path, meaning do we do TKI, IO TKI, or TKI, TKI, and then IO? That was the question we were asking ourselves at that time. This was based on the rationale of 2 studies. You don't have to learn them. You just have to know that nivolumab and cabozantinib are second-line single-agent, following single-agent approved drug. Nivolumab is one of the 2 immune checkpoints I've mentioned in my first-line presentation. This is IV drug. This is overall survival benefit, first endpoint, and clear quality of life benefit. Nivolumab has changed my life, honestly. You move from a patient that has diarrhea every day, that has hand-foot syndrome, that has myositis, and so on, to a patient that says, I'm feeling very well, doctor. I have no toxicity, I have this little rash, no problem. So single agent PD-1 is something that is easy to handle. I'm not saying there is no toxicity, because there's about 15 to 20% of significant toxicity, but it means 1 patient out of 10, okay? So this is something that is very manageable. And it is important for you to have that in mind, because once again, I'm going to discuss adjuvant in 1 minute. And so if you have something that has few side effects and induce overall survival benefit, this is a drug you want to develop in adjuvant space, okay? Cabozantinib, the other agent that was approved about the same time, 2015, it's a very potent TKI. It's the one I've mentioned in a 9ER trial as well as in a COSMIC trial. Strong PFS benefit, overall response rate benefit, and overall survival benefit. You don't have to learn that. You just have to learn that this agent is approved in second line. And the problem we have now is that because we're changing the first line, it does impact the second line. So my way of seeing things is the following. In a patient where you have used axitinib plus pembrolizumab, irrespective of risk group, because you have used one PD-1 and one VEGF inhibitor, you want to go to another VEGF inhibitor because you don't have other options. So you select the one that you considered as the most potent in terms of rescue, and usually we use cabozantinib, okay? If I have used nivolumab plus ipilimumab in intermediate and poor, then I use a TKI. Any TKI. It could be sunitinib, it could be pazopanib, it could be axitinib, it could be cabozantinib. Okay? So after nivo-ipi, any TKI works. I personally use axitinib because it's the one that is the easiest to manage in terms of safety profile and the ratio and the activity safety ratio. So I personally use axitinib. And sometimes I use cabo in patients that have very rapidly evolving disease. So, adjuvant space. I know yesterday all of you that were at this dinner went to bed, but at that time I received a text. And it was not from Morgan, be reassured. It was a text from a colleague that said, look, this study is positive in bladder. So yesterday, there was one thing that you could not learn because it was not out, is in the adjuvant space, after surgery, after cystectomy that you perform, we now have data suggesting that single agent PD-1, and here was the nivolumab, the one that is positive with regard to the endpoint of disease-free survival, okay, time to recurrence. So it's the first very key information. We know that Atezo study was not there. So it means that, yes, immune checkpoint is coming in the adjuvant space. And I think you have understand now, good safety profile, overall survival benefit, because you're inducing an immune response. So it's the perfect space for adjuvant. So this is bladder. Too bad you had the training yesterday. Maybe later today, Morgan will touch on this, okay? But clearly, if it is evolving in bladder, it's going to come in RCC. It actually have even more rational in RCC. So what we know in RCC for adjuvant space is that VEGF TKI is not a drug that we want to use. It has toxicity, and it failed to demonstrate disease-free survival benefit. So we don't use adjuvant treatment in RCC. However, we develop adjuvant immune checkpoint trial, and a lot of you who are working in academic centers, you know that if you operate well, you will be operating with your other surgeon in the team, a large kidney cancer with high grade, the patient will be referred for one of these trials. What we look at is either nivolumab, PD-1, Atezo, PD-L1, nivo-ipi, the one that is approved in first line, or pembro, single agent PD-1 as well, or combination of another PD-L1 and CTLA-4. And so it's a lot of patients that are being enrolled, and we don't know if we need to treat them 6 months, 1 year, we have no idea. But there is a rationale that in the adjuvant space, this agent can play a role. We have not yet any results from the RCC trials. It is going to come when you'll be doing your training this year, next year, not 2020, but maybe 2021 or the year after. These trials takes a lot of time to be conducted because it's a lot of patients, and then you need to wait until time of recurrence, and you know that from the TKI era, it's about 5 years. Time to recurrence, median time to recurrence, okay? But the problem will be, do we need to treat all patients? How can we select the ones that are more likely to respond? You know that it's not working in all patients. So we need to select the high grade, the inflamed tumors that are more likely to respond in the adjuvant space. One word on non-clear cell. So I said all tumors that are not clear cell RCC. For the moment, we know they have a dismal prognosis. So they have a shorter overall survival, usually 1.5 years. So it's very challenging to handle. And what we do for the moment is we treat them with the agent we had. So it means basically VEGF TKI. There are some data with Pembro that are interesting, but we don't have any randomized data. So I'll be concluding on this. You have a lot of chance to arrive in this field now because things are evolving a lot, and it's very interesting. Combination of either immune checkpoint plus VEGF TKI are standard of care, and we need to stay tuned for adjuvant, non-clear cell, sequence, in which order we shall use our treatment, new targets. I'm developing with many others an HIF inhibitor. This is something that is very interesting. And biomarker-based strategy, because as I said, all patients are not responding, okay? You've seen the Checkmate 214 data. The plateau may be around 30%, so it still means that 2/3 of our patients are progressing, okay? Yesterday morning, I had an investor meeting, so it's only business, okay? And they need to know where are the trials, they know the trials super well, the people that are investing in drug company. And basically, their question was, there are a lot of questions. One of them was, okay, but you're curing a lot of patients now. Do we still need to invest? And the answer is yes, okay? There are still 2/3 of our patients that are not being put in response or in long-term remission. So there's a lot of work ongoing. And so we need to do biomarker and new target development, but this is what we do as medical oncologists. Thank you very much for your attention. So I say I'm going to present the team. So Gustave Roussy is outside Paris, so it's all green. No, it's a joke, not today. And so the way we have built the group is the following. We have the prostate lead that is Karim Fizazi, and I'm sure all of you know him. I took over Bernard Escudier for the RCC group. Johan Loriot is handling our bladder program. Christophe Mazar is now head of early drug development, doing a lot of phase 1. Giulia Bacciarello is doing germ cell tumors with Karim Fizazi. And you see Alberto here, Alberto Bussi, who is our radiation oncologist. So every Tuesday I am in a room with Alberto, and we're working on all cases, and we're discussing all our new cases in the tumor board. We welcome a lot of fellow medical oncologists, but also urologists that are willing to come for, alors I'm sorry, I'm going to switch to French, but l'ancien DESC ou la FST maintenant, donc si vous voulez, on accueille les internes pour 6 mois. We're welcoming non-French fellow as well. So please feel free to apply if you are keen on learning more on how to handle GU tumors. Thank you very much.
The primary endpoint is not overall survival. The primary endpoint for these trials are disease-free survival. So it means the time that the tumor needs to relapse locally or with metastasis. These are the baseline characteristics, and I think it is important to realize that most of the patients were bladder cancer patients. Only 7% of patients recruited were upper tract tumors, and the majority of the patients were T3 or T4 stage. So high risk, I would say high risk for relapse, okay? Even 50% of the patients, 50%, they were node positive. So highly risk for relapse. Unfortunately, atezolizumab did not impact at all in terms of disease-free survival or overall survival in this field. So it was a little bit upset, these results that were reported at ASCO by Maha Hussain. Unfortunately, the biomarker didn't work at all. So patients with PD-L1 negative and patients with PD-L1 positive did not were improving the disease-free survival with atezolizumab. And that was the data that we have at that time. Yesterday, we have the press release from one of these trials. The INVIGOR-010 is the one that we just commented, atezo versus observation. The Ambassador trial is an independent trial with very similar design, comparing Pembro versus observation. And yesterday, we had the press release of the Checkmate 274 trial, nivolumab versus placebo. And as you can see, and unfortunately, we don't have so many data on this field, the patient population included was very similar to the one included in the UDOU 10, and the primary endpoint is very similar, disease-free survival. However, there are two primary endpoints, disease-free survival in patients with PD-L1 positive tumors and disease-free survival in the intention to treat population. And this is the press release. And the press release is saying that nivolumab is impacting in disease-free survival versus placebo as an adjuvant treatment. So we are, this press release was yesterday released, and so we don't have so much data to comment on, but well, it means that probably we will have drug to offer as an adjuvant treatment, as a single agent, nivolumab, and well, it is changing probably the practice. Let's see the data. I don't really know when this data will be released. Maybe at EAU, maybe at ASCO GU. Let's see when the data are released. But definitely, this data will impact in the daily clinical practice. A lot of questions are coming. Why atezolizumab, a PD-L1 inhibitor, seems it's not working in this field? Why nivolumab, a PD-1 inhibitor, is working? Are there any difference in the baseline characteristics of the patients, in the definition for high risk of relapse? Disease-free survival impact without overall survival impact is enough primary endpoint to be approved and to be considered for approval by the regulatory agencies? What is the cost, not only in terms of resources, in terms of money, but what is the cost of giving a nivolumab as a single agent in the adjuvant setting in terms of toxicity? Is the toxicity, well, one of the key things here? Let's see. A lot of questions are coming. As I said, this press release was released yesterday, and it was released at 4 p.m. Eastern time, so it means it was like 11 p.m. in Europe. So, well, more fresh data than this is impossible. So I just wanted to do this comment as far as this is very brand new, and this is really very good news for patients that came yesterday. Okay, so let's go into, yeah.
Can you hear us? Okay. Can you go back to the slide with the 3 trials? Can you explain again for everyone in the room what was defined as high risk, and what was usually what is the time to recurrence? Because maybe we can also imagine when we'll have the overall survival information in this trial.
Absolutely. Well, high risk for relapse were considered those patients with PT2, PT3, PT4 with or without lymph nodes involvement. And this is the thing. PT2 is a high risk for relapse tumor? Don't know. But those patients with PT2 are those patients who receive prior neoadjuvant treatment before going to cystectomy. So this is not only cystectomy and you have a PT2. These are patients who receive neoadjuvant treatment. After the neoadjuvant treatment, they did cystectomy, and the pathology report after the cystectomy was a PT2. So these patients were considered high risk for relapse. However, I don't have the exact data of the definition in the Ambassador and in the CheckMate 274, as far as both trials are not yet reported. The definition is coming from the UDOU 10 trial, the only trial reported so far, but still not published. About the endpoint, disease-free survival. That's a great question. Disease-free survival means local recurrence, distant recurrence. Is there a translation in between disease-free survival and impact in overall survival? In chemotherapy, we saw yesterday that, yes, it seems there is a translation in the impact in disease-free survival and the later impact in the overall survival. But this is something that we still don't really know in the field of urothelial tumors. We don't know exactly what are the subgroup of patients that are benefiting more from receiving immunotherapy. This is the subgroup analysis for the INVIGO 130. And as you can see here, it is impacting that probably those patients with the highest risk, So those patients with PT4 are the ones benefiting more from the adjuvant treatment. However, you cannot see that much different in those patients with lymph nodes involvement, you know? So probably we will need to discuss about it. And another thing coming from the INVIGOR-010, but the INVIGOR-010 is a negative trial. It's a negative trial. What about the use of adjuvant treatment in patients with upper tract tumors? We don't really know about it because in the INVIGOR-010 trial, the observation seems to do it better than atezo. So a lot of questions are coming. Of course, this is a subgroup analysis. This is just exploratory analysis. We cannot extrapolate definitive conclusions from this data. And we need to put this data into the context of a positive trial, the Checkmate 274. And these are great questions. And can you see, can you feel how attractive, how exciting the field of urothelial tumors is right now and will be in the next future? This is exciting. This is exciting how Pembro is already approved in non-muscle invasive stage. Atezo has very good data in non-muscle invasive stage. In the neoadjuvant treatment, we saw yesterday how single-agent immuno can induce pathological complete responses. Doublets of immuno can induce pathological complete responses. In comparison with chemotherapy, seems they are not higher than with chemotherapy, but we can select patients and we can avoid the use of chemotherapy in the neoadjuvant setting. In the adjuvant setting, it seems that Nivo is working, Atezo is not. We don't really know why. PD-L1, as you can see here, is not the driver. Take a look at those patients with PD-L1 negative. PD-L1 negative. It seems that Atezo is doing better than observation in PD-L1 negative. However, in PD-L1 positive, it seems that observation is doing better. So nobody can really understand why are these results. And the Checkmate is positive for disease-free survival. If you are asking me for how good is the positivity, how this drug can impact in the overall survival, how can this drug can impact in the quality of life of patients, I don't really know. We need to see the data before that. Thank you so much for the questions. More questions about the adjuvant treatment? We don't really know that much because this is the only thing that I have. So, well, let's see. And it's positive for both, for the intention to treat population and for the PD-L1 positive population. So we will need to see if we have a biomarker or maybe not, which is what I think. Okay. So let's move to the metastatic setting. And let me do a brief summary and a little bit of history of what we have to treat our patients in the first line setting. Alan Jagoda was a famous urologist in the 70s who was working in New York and was the first guy who said that, okay, chemotherapy is active in urothelial tumors, but properly, cisplatin was the most active chemotherapy we can give to patients with urothelial tumors. So from this paper from Jagoda in Cancer in 1980, based on results of clinical trials in the 70s, well, it was established that cisplatin chemotherapy was the main chemotherapy we should give to our patients. Patrick Lawler is a medical oncologist working in Indiana, in the University of Indiana, and he was the first guy who was randomizing patients to receive cisplatin alone versus combinations of chemotherapy with cisplatin. And as you can see, combinations with cisplatin did it better in progression-free and overall survival than cisplatin alone. And this is the first time that a combination, MBAC at this time, demonstrated an overall survival of around 12 months, of around 1 year. And this is the median overall survival we can really expect with all chemotherapy, all cisplatin-based schemes. Hans Bordermasse conducted a very large EORTC trial. And this EORTC trial is the backbone for the treatment of urothelial tumors in the last 3 or 4 decades. Why I'm saying that? Well, In this EORTC trial, the two main regimens based on cisplatin were compared head-to-head. Gemcitabine plus cisplatin, the now worldwide standard of care, I would say, versus MVAC. As you can see, there were no major difference in terms of overall survival when comparing these two regimens. Median overall survival was pretty similar, 14 months for for GemCis and 15 months for MVAC. Hazard ratio was absolutely no difference at all, 1.09. And well, it was considered cisplatin gemcitabine as the standard as far as this is better tolerated than MVAC regimen. It is important for you to realize about this part of the curve, about the tail of the curve. In those patients eligible to receive cisplatin, treated with cisplatin-based regimens, and no matter if you are using GemCis or MVAC, around 10% of patients, 15% of patients maybe, they are very long-lasting survivors. This is something that we don't see in those patients that are not treated with cisplatin-based regimens. Matt Galsky, in 2011, he's working in New York at the Mount Sinai in New York. He's a great guy, a brilliant guy, did the Galsky criteria. What are the Galsky criteria? Well, Galsky criteria are the official criteria to define a patient's eligible or ineligible, fit or unfit to receive cisplatin-based regimens. Okay, these are the Galsky criteria. A good performance status. If your patient has a ECOG performance status of 2 or more, he's not eligible. A good creatinine clearance. If your patient has a creatinine clearance less than 60 milliliters minute, the patient is not eligible to receive cisplatin. Hearing loss, peripheral neuropathy, and of course, heart failure or relevant cardiovascular history. Okay, if your patient is meeting one of these criteria, one of these Galsky criteria, the patient is not eligible to receive cisplatin. Okay, this is good, but take a look at this. What is happening in the real world? What is happening in the daily practice, in the community setting? These are the results in terms of survival of the largest ever reported retrospective daily life analysis. More than 3,000 patients were assessed retrospectively in US and Europe. And as you can see in daily practice, this is not the same to be eligible for cisplatin than receiving cisplatin. So it means that in the clinic, physicians are not really following the Galsky criteria. So in the daily practice, probably there are other factors in addition to Galsky criteria that are conditioning our treatment decision choice. And this is extremely important. And always that I have a resident, always that I have a fellow seated in front of me in the consultation at the office, I am always telling the same. Your hands are the best drug for your patient, because depending on your decisions, your patient can live longer or can live shorter. Take a look at this. Those patients in blue that are cisplatin eligible and are treated with cisplatin-based combination, they are living longer, 20 months, than those patients in dotted blue that are eligible for cisplatin, and because of any reason, the investigator, the physician, is not giving cisplatin-based combination. When there is a drop in the median survival, we can expect from 20 months to 12, 13 months. In addition to that, this is exactly the same overall survival that you can expect in patients ineligible for cisplatin and, of course, non-treated with cisplatin or even treated with cisplatin. The median, the prognosis will be much, much purer if the patient is not receiving cisplatin or is ineligible to receive cisplatin. Okay, so eligibility is a good prognostic factors in urothelial tumors. And in addition to that, we have other two factors to consider. First, Bajorin risk factors. And I remind you what are the Bajorin risk factors: ECOG2 or presence of visceral metastasis. So patients can have 0 of these variant risk factors, 1 or 2 of them. And if your patients have liver metastasis, it means straightforward to have variant risk factors too. And as you can see, you can identify from the prognostic perspective which are the patients with the better prognosis. Patients with no variant risk factors group, the median expected overall survival in those patients who treated with cisplatin is 33 months. If the patients have only one of these variant risk factors, the median survival is 13 months. And if the patients have 2 of these variant risk factors, the median survival will be only 9 months. And in addition to that, PD-L1 expression is also another prognostic factors in urothelial tumors. So those patients that are PD-L1 positive, they have better prognosis than those patients that are PD-L1 negative. And of course, if you are in front of a patient with metastatic urothelial tumors, you need to take into consideration these factors, because these factors are conditioning the prognosis. And these factors are conditioning the treatment you can give or what you can expect from the chemotherapy you can give to your patients. Okay, so this is the summary we have. And take a look at the data of Maria De Santis. Take a look at the data of what we can do in patients unfit or ineligible for cisplatin. No difference at all when we were giving Carbogem versus the modified MVAC, the MCABI regimen. Of course, no cisplatin at all in any of these arms. And take a look at this, because I think it is important. Do you remember the median survival with MVAC or with cisgem? It was around 14, 15 months. Take a look at the drop in the median survival we can expect from 14 to 15 months down to 9 months. But the most impressive thing, at least for me, is the last part of the curve. You don't really see long-lasting survivors here. So patients ineligible for cisplatin means not only that they are not eligible for cisplatin-based regimens, it means that there is no choice, no option for these patients to be long-lasting survivors. Okay, and this is the explosion. This is what we have now. Take a look at the milestones, what we advanced in the last 40 years. Almost nothing, almost nothing. But take a look at how many different drugs, different combinations, different strategies we have seen so far in the field of urothelial tumors in the last 5 years. Immunotherapy is changing, has already changed the landscape in urothelial tumors. Let's do a summary of what we have. Okay, what is the immunotherapy? What immunotherapy is adding to our patients for those patients that are platinum refractory? This is a recent meta-analysis conducted by Matt Galsky at the memorial that you can see on the left. And this is the updated results coming from the IDMDC group in the US and Canada that was reported at ASCO. And data are extremely consistent. The activity of PD-1 and PD-L1, and remember that the FDA has approved 5 PD-1, PD-L1 inhibitors, pembrolizumab, atezolizumab, nivolumab, durvalumab, and avelumab, 5 different agents as a single agent in the platinum refractory setting. Take a look at the data in terms of survival. In the clinical trials, in the meta-analysis from Matt Galsky and colleagues, and in the real-world practice in the data from the IMDC. And as you can see, this is pretty consistent activity, pretty consistent data in the clinical trials compared with the activity obtained in the daily practice. So this is what we can really expect. Can you see any difference at all in the different drugs? Probably not in this field. The Saul trial is the largest retrospective trial, largest phase 4 trial, observational trial, conducted with atezolizumab in more than 1,000 patients in the clinic. And in this trial, we learned that the most important factor that is predicting for the activity when you are using an immuno-oncology drug, at this time atezolizumab, in the platinum refractory setting, is the ECOG performance status of the patients. So those patients with a good ECOG performance status are doing much, much better than patients with a deteriorated performance status. Okay, this is a key message to bring back home. This is important because, and as you can see in this slide, the expression of PD-L1 is not really impacting in the prognosis. The most important prognosis here is the ECOG performance status of the patient. So my advice to you is do not wait until the patient is deteriorated to think about offering immunotherapy. The immunotherapy is working in those patients with the better performance status. This is a good message to take into consideration. Translated this data into the daily practice. This was one of my first patients treated with immunotherapy. These patients had an urothelial bladder tumor in 2011. It was a PT2 after the cystectomy. After 3 years of the cystectomy, the patient relapsed in the lungs and in the lymph nodes. We offered for the standard chemotherapy, cisplatin gemcitabine, for 6 cycles. And despite of that, just after 3 months after we finished the chemotherapy, a progression in the liver, in the lungs, and in the lymph node was observed, and we recruited these patients for the INVIGOR 210. Take a look at this imaging of one of the metastases in the liver, 25 millimeters, and take a look at the small increase in size at the first CT scan we did after 3 cycles of atezolizumab. Well, if we are following strictly the RECIST criteria, this is a progression, because this is an enlargement of more than 10% of the size. Okay, but the patient was feeling better, and the patient was saying, hey, doctor, I feel much, much better. I don't feel tired. I don't have any pain. I recover my normal life. So we continue with the medication and take a look at how the normal liver is invading the metastasis. So it is almost a complete response, not yet. Take a look at another lesion, 13 milliliters. Take a look at a small increase in size from 13 to 16 milliliters, but take a look at that, a complete response in other of the lesions. And do you remember this guy has also metastasis at the lungs? Well, this was the initial size of the metastasis, but take a look at this. There was a huge increase when the patient has received only 3 cycles of atezolizumab. I told you before, the patient was feeling better. The patient was feeling less tired. The patient was feeling less pain, less dyspnea. But take a look, we maintain the treatment because of the clinical benefit of the patient, and take a look at what happened. We need to be back doctors again. What I mean is we need to ask the patient, how do you feel? Do you feel better or not? The medication is working or not? This is extremely important to have that into consideration. You know, the oncologists, when we were using chemotherapy, when we were using targeted agents, we were like technicians, and we were just following the report of the radiologist to do anything with the patients, to say, okay, the patient is responding, I continue with the medication, I need to deal with the drug doses that I have, but I need to continue with the medication. If the patient is progressing in the CT scan, I need to change and I need to switch to another line of treatment. This is not the case when using immunotherapy. This is what we can expect in our patients. So we need to be back doctors again. We need to ask the patient, how do they feel when using immunotherapy? And I think it is important key learning when using these kind of approaches. But in the field of platinum refractory setting, we have 3 drugs, 3 extremely promising drugs under development. These are enfortumab vedotin. And this is the press release that came out this week. And in this press release, it is saying that enfortumab compared with chemotherapy in patients that are platinum refractory and that are immune refractory, enfortumab is impacting in overall survival. So enfortumab will be added to one of the main drugs, main options that our patients with urothelial tumors will have shortly. So chemotherapy, immunotherapy, and enfortumab are the 3 of them already impacting in overall survival. Sacituzumab is another monoclonal antibody that is linking in one hand TROP2, and in the other hand it is linked to a kind of irinotecan, and this is inducing a huge tumor shrinkage with an impact in 27% of patients with response by RECIST criteria in patients refractory to chemotherapy and immunotherapy. So probably shortly we will have at least 4 lines of treatment to offer to the majority of the patients with urothelial tumors. And finally, erdafitinib. Erdafitinib is the first fibroblast growth factor receptor inhibitor to be approved in this field. And erdafitinib is impacting in terms of responses in a phase 2 trial that was able to have the approval by FDA in this field. So patients with mutations or molecular alterations affecting to the FGFR genes can have a new options, erdafitinib, offering for 40% of responses and a median progression-free survival of around 5 to 6 months on this patient. Okay, what about the first-line setting? In the first-line setting, we can classify patients according to these 3 main groups. Patients eligible for cisplatin, according to Galsky criteria, patients ineligible for cisplatin, but eligible to receive carboplatin-based regimens, and patients ineligible for any platinum-based chemotherapy. Plus or minus, around 40% of the patients are eligible for cisplatin, 20% of the patients are ineligible for cisplatin, 20% of the patients are ineligible for any platinum-based chemotherapy. For those patients eligible for cisplatin, I think that the current standard of care is maintenance therapy of chemo followed by maintenance therapy with avelumab. For those patients that are ineligible for cisplatin, I think we have 2 options. Patients with PD-L1 negative tumors, well, the carbogem followed by maintenance avelumab should be considered the standard. Patients with PD-L1 high tumors, well, we can offer 2 things to those patients. Carbogem followed by maintenance avelumab, or atezo or pembrolizumab as a single agent. And of course, in patients ineligible for any platinum-based chemotherapy, you can use 2 things, atezo or pembro, according to the current labeling, or gemcitabine with or without paclitaxel as single agent or in combination. Okay, let's go and let's analyze one of these, one by one, these alternatives. Maintenance therapy. Well, maintenance therapy is considered today, according to the ESMO guidelines, according to the NCCN guidelines, and shortly it will be considered according to the European Urology guidelines as the standard of care. This is the design of the Javelin Bladder 100 trial. Avelumab was compared with the best supportive care in patients that were having benefit from the 4 to 6 cycles of a standard chemotherapy. So those patients who were under complete response, partial response, or stable disease with chemotherapy were randomized to receive avelumab or best supportive care. This is the primary endpoint, overall survival, and as you can see here, with a median overall survival of 21 months versus 14 months, and with a hazard ratio of 0.69, avelumab maintenance is impacting in the overall survival of patients who receive chemotherapy first. So this is the first time that in the first-line setting, one drug is impacting in overall survival over a standard chemotherapy. Okay, this is pretty clear, and this is the reason, these are the results that are considering avelumab maintenance therapy as the current standard. However, we have several questions, several caveats that will need to be solved shortly. These caveats are, okay, you are picking the winners. You are selecting those patients with the better prognosis. You are selecting those patients with clinical benefit to chemotherapy. So the question is, what can we do for patients that are progressing during chemotherapy? How can we select in advance? How can we identify in advance those patients, well, to treat them differently from chemotherapy? This is the first thing. Second thing, this is the proportion of patients who receive immunotherapy in the control arm. And only 43% of patients in the avelumab arm finally receive an in the best supportive care arm, finally receive a PD-1 or PD-L1 subsequently. So it means that around 60% of the patients are not receiving immunotherapy. We need to make sure, because immunotherapy is impacting in overall survival, we need to make sure that all our patients with urothelial tumors are finally receiving immunotherapy. And this is an option and a possibility for these patients to be long-lasting survivors. More things. Petros Grivas at this ESMO meeting presented this group analysis. What we should do in patients with PD-L1 negative. It seems that patients with PD-L1 negative, they did not benefit in the same range that patients with PD-L1 positive. PD-L1 negative tumors should be offered for maintenance therapy with avelumab? Let's see. And what about patients with visceral metastasis, especially those patients with liver metastasis? We should offer immunotherapy for those patients? Well, in the forest plot analysis, it is not really clear if we should or not. Don't forget that these are exploratory analysis, subgroup analysis. This is just hypothesis generating. And finally, take a look at the overall survival with maintenance avelumab in those patients who achieve a complete response with chemotherapy. No impact at all in terms of overall survival. And remember the graphs I showed you before with cisplatin-based chemotherapy. Do you remember this 10 to 15% of patients that were long-lasting survivors with cisplatin-based chemotherapy? There are some patients, probably those in which are sensitive, extremely sensitive to chemotherapy, that will not benefit to receiving avelumab, because the activity of the chemotherapy is really, really long-lasting and impacting in a long-lasting survival. So a lot of questions that need to be solved, a lot of questions that are good for debate in this field. What about the use of single-agent immunotherapy? Well, we have two drugs approved in this field, atezo and pembrolizumab. You know that atezolizumab is a PD-L1 inhibitor, pembrolizumab is a PD-1 inhibitor. And as you can see here, in the Vigor 130, this is the phase 3 trial that it has 3 arms, combination arm, chemo plus atezo monotherapy, and the standard chemotherapy arm. Okay, and as you can see, in those patients that are PD-L1 positive, according to the FDA and EMA labeling, those patients with PD-L1 positive treated with atezolizumab in blue, you can see that they have a huge benefit ahead of, in comparison with, the chemotherapy, standard chemotherapy arm. So why not to offer atezo single agent to our patients? These data, well, were not really consistent with the ones obtained in the KEYNOTE-361 trial with pembro. This trial has already been released at ESMO, and as you can see, you cannot really see that much different in those patients PD-L1 positive treated with pembro versus standard chemotherapy. Median survival is not less, 16 months for pembro, 15 months for chemo, but you are not really observing this difference in terms of activity. But take a look at what happened in the Danube trial. The Danube trial has already been released by Tom Pauls at the ESMO meeting, at the recent ESMO meeting. And in those patients with PD-L1 positive population, who received the combination of durvalumab and tremelimumab. Durvalumab is a PD-L1 inhibitor, tremelimumab is a CTLA-4 inhibitor. Take a look at the statistically significant improvement in overall survival for the combination. So it seems that yes, we can treat patients with immunotherapy only as a single agent or do double combination like durvalumab and tremelimumab if we select those patients by PD-L1 expression. Remember that PD-L1 is a good prognostic factor for patients with urothelial tumors. And it seems that PD-L1 could predict the activity of durvalumab and tremelimumab. Future combinations, chemo plus immuno. Well, the INVIGO 130, this is the design of the trial. I had the opportunity to present this trial at the last ESMO meeting, at the presidential session. And you have 3 arms here, standard chemo versus atezo single agent versus the combination of chemo plus atezo. There were 3 primary endpoints. The first one was progression-free survival. The combination of chemo plus atezo was better in terms of progression-free survival than chemo alone. So chemo alone was offering for 6.3 months of median progression-free survival. The combination offered for 8.2 months. Hazard ratio was 0.82. Okay, it was positive, but take a look at the trend into an improvement in overall survival for the combination. With a consistent hazard ratio, 0.83, the combination of chemo plus atezo is showing a promising trend, not yet statistically significant. Let's see how the curve is evolving with a longer follow-up. And in addition to that, and extremely interesting from the clinical perspective, take a look at the percentage of patients treated with the combination who achieve a complete response, double than with chemotherapy alone. So it means that probably there are some patients in which offering the combination of chemo plus atezo, you can have a higher rate of complete responders. Let's see if this is something translated into an overall survival. When we analyze the subgroup analysis, what I can say is that those patients with better prognosis are doing better with the combination. Take a look at the outcome in those patients with ECOG 0 or 1, and take a look at the outcome in those patients with variant risk factor 0 or 1. The combination of chemo plus atezo in those patients is working better. But at the same time, take a look at the poor outcome of the combination in those patients with ECOG 2 or with liver metastasis, very poor. And probably the most exciting data are coming from this subgroup analysis. Patients treated with cisplatin in the INVIGO 130 trial did it much better with the combination than with the than with standard chemotherapy. Take a look at the medians, 21 months of median overall survival for those patients treated with the combination with cisplatin and atezo versus 13 months with a hazard ratio of 0.66. I'm convinced there will be future analysis on this particular subgroup of patients that probably are the one with the better prognosis. Matt Galsky did this report at last ASCO meeting trying to do translational research, and we could find two different kinds of prognostic markers here. Positive prognostic markers for immunotherapy, which are especially PD-L1 expression and high tumor mutational burden, and the ApoBake signature is correlated very good with the tumor mutational burden. And on the other side, and do you remember yesterday we were talking about negative predictors for activity, TGF-beta is not well, or is allowing us to identify those patients that are not likely to respond to immunotherapy. So this is also important, not only to know which patients will be responding, but to know which patients will not be responding in this field. The KEYNOTE-361 trial has the same design that the INVIGO 130, but changing atezo for pembro. Pembro single agent, standard chemo, or the combination of pembro plus standard chemo. Unfortunately, the progression-free survival did not reach the statistical significance. This is not the threshold for statistical significance the authors were aiming for. The overall survival did not meet the statistical significance again, so the threshold was not met at this time. And there are two other phase 3 trials that are up and running, and the results are waiting for next year. The CheckMate 901, in which cisplatin gemcitabine will be combined with nivo, and the NILE trial where durvalumab, the PD-L1 inhibitor, with or without tremelimumab, will be combined with chemotherapy. Let's see what can we expect from these trials. Immune doublets. Well, at ASCO, Tom Powers presented the DANUBE trial. The DANUBE trial had 3 arms: durvalumab single agent, the combination of durvalumab and tremelimumab, PD-L1 plus acetylcholine versus standard of care chemotherapy. This is the primary. The trial had 2 primary endpoints. This is the first one: the activity of durvalumab single agent in those patients with PD-L1 positive tumors. Unfortunately, hazard ratio for survival was not met, and unfortunately, durvalumab is not impacting in overall survival in this prospectively selected PD-L1 positive population. And this is the second primary endpoint of the trial, the activity in terms of survival of the combination of durvalumab and tremelimumab versus chemotherapy. And unfortunately, take a look at the upper limit for the statistical significance. Unfortunately, durvalumab and tremelimumab did not impact versus chemotherapy in an improvement in overall survival. There is a very positive trend, and as you can see the typical kinetic of response of immunotherapy. In a first part of the curve, it seems that chemotherapy is doing better than immunotherapy, but there is a crossover here, and from here, and this is just after 6 to 9 months of treatment, you can see a large and better improvement of immunotherapy in a long term than with chemotherapy. And what is the most interesting data for me? You have already seen this graph before. In the PD-L1 positive population, the combination of durvalumab and tremelimumab is significantly impacting in overall survival versus chemotherapy. But this is a secondary endpoint of the trial. So in global, the Danube trial is not positive, unfortunately, but in this secondary endpoint, in the patient population with PD-L1 positive tumors, the combination of durvalumab and tremelimumab seem that may impact in terms of overall survival versus standard chemotherapy. In this particular subgroup of patients with PD-L1 positive, the combination of durvalumab and tremelimumab has a similar response rate compared to chemotherapy. And once again, very interestingly, around 12% of patients are showing complete responders, so almost doublets what we can expect with complete responders in the chemotherapy, standard chemotherapy. We are waiting for the results, not only the Danube that have been released, but from the Checkmate 901. And this trial has a Nivo-IP arm, which, well, let's see what happens in the future. Take a look at the data that Dr. Sharma presented at ESMO this week. And as you can see, and this is a platinum refractory patient population, take a look at the curves for overall survival. Probably median survivals are not impressive, medians, but take a look at this extremely promising last part of the curve, tail of the curve. Take a look at the proportion of patients that are alive after 4 years, up to 30% of the patients with the combination of nivolumab and ipilimumab are alive after 4 years. So this is a major breakthrough that we can expect in the future. And I'm just finalizing targeted agents plus immunotherapy. Well, probably the most promising combination that we may have is the combination of enfortumab vedotin plus pembrolizumab. 73% of responders, according to RECIST criteria, in patients with first-line ineligible to resist cisplatin, median progression-free survival of 12 months. Probably this is the most attractive and promising combination that we have. Only one concern in terms of toxicity, which is the neuropathy. It seems that pembro neuropathy is added to enfortumab vedotin overlapping neurotoxicity. And this is the design of the most promising phase 3 trial in the first-line setting that we have so far. This trial is recruiting patients now in the first line. Initially, it was designed with 3 arms of treatment. You have the standard chemotherapy arm. You have the same combination, enfortumab vedotin versus pembrolizumab, the same combination we saw the data. And it was a third arm combining cisplatin or carboplatin plus enfortumab and pembrolizumab. But unfortunately, because of futility and toxicity, this trial needs to be removed from the trial. So enfortumab and pembrolizumab will be compared with the standard chemotherapy. Let's see what is the outcome in the future. I hope I didn't bore you. I hope you are not sleeping. And thank you so much for your attention.
You are perfect.
Enrique, it's Morgan. You were perfect. I was listening to you at the gym because I don't have this physical appearance without working my body a little bit. So I was listening to you and you did a great job. Even me, you convinced me to become a medical oncologist. So,
more updated.
Yeah, thank you. Is there any question for Enrique? They are astonished. Laurence, maybe you want to raise the point.
Yes.
Attends, you need the microphone, I think.
Hey, Laurence.
Can you come closer to the laptop?
I cannot see you.
No, it's because it's complicated. I will explain.
Enrique, Thank you very much. It was fantastic. My question is for you with regard to first line, because I think it is what is important for them. The vast majority in the room are urologists. So for the maintenance, we keep it, for the moment, we keep it simple. We just use avelumab maintenance, or do you think things are going to evolve a little?
You mean for the combo?
Yes.
No, today the standard of care is chemo, 4 to 6 cycles of standard chemo, followed by maintenance avelumab, full stop.
Okay.
Fantastic. And the second question, because Morgan said I can ask questions, is what is the most appealing strategy for you? First line, second line. You mentioned EV data plus Pembro. Do you think that's the way to go?
Absolutely. I think this is the most promising strategy. My only concern with this combination is that we are not using cisplatin, which this group of 10 to 15% of patients that are long-lasting survivor, if they receive cisplatin, I think we may be missing this group of patients. But let's see. The phase 2 trial is extremely positive for PFS and response rate. I think it is extremely positive and promising combination. Let's see. It's exciting. The field of bladder cancer is exploding. I think we should be very proud to be living in as a first.
Okay.
Thank you.
Thank you, Enrique.
Thank you.
Thank you so much. He can still listen to us.
Thank you so much.
The TV, we had a blackout at the last minute of your last word. So it's perfect. Can you hear me?
Yes.
Okay. So thank you so much. You are free now. You can follow us on streaming, but you can go back to your activity. And hopefully you will be there next year for the 5th edition.
I hope so. Thank you.
You're back on there. So we will hopefully have you in Paris. Thank you so much for your availability and the quality of your lecture. See you soon. Bye.
So for many, many years, and it is still the case in metastatics, in the metastatic setting, all the studies that you have seen, which were promoted and discussed by Enrique Grande, you can see that in the metastatic setting, in the rare population, it's difficult to recruit metastatic patients with urothelial carcinoma. So there is always a mixed up of cases. I mentioned that already, but it's important because we believe that aside from the anatomical distinction that you have between the bladder cancer and the upper tract, there is also, I would say, a biological behavior which is a bit different. She needs to do a tweet, sorry. It's very important for my promotion. I start my career and I have recruited Laurence Albiges as my social media promoter. So you can follow me on Twitter. It's @mropre. I have Instagram, it's for private inner circle, I would say. Because me in a swimming suit is not my best advantage. So conflict of interest. It's I don't have to say anything. Look, there is the sound. Have a good day. Comment je coupe ça, moi? Merde. How do you... No, it's me. Because I recorded the lecture, I thought that it would be only virtual, the UDOU. So when I prepare my slide, I say, okay, I will not see you. So I will pre-record, so I will be relaxing in my room. But now that I've learned that I could be there, is it possible to mute? Yeah, okay, cool. So... The EAU is one of the unique scientific association which is promoting specific guidelines for upper tract cancer. I know it's coming on. The French association is doing that also.
Many oncourological tumors have
it's on each slide. So can you just mute it?
If you don't mind, I would like to go
the sign.
into
no problem.
4 different points regarding...
No, it's perfect. It's perfect. See, there will be video. What? No, but it's just the sound. Bon. We don't care about this. So we have guidelines. There is a big book of the guidelines, which is each year renovated by each panel of the EAU. And Laurence, for instance, is sitting in the panel of renal cell carcinoma. They are doing a very good job, the EAU, and I think the guidelines promoted by the EAU are very popular all over the world, Asia, outside Europe. It's very well known, and it's I can tell you, huge methodology, huge quality, big input, big commitment of the people sitting there. So it's a quality paper, and you can have a lot of information just coming from the guidelines. They are pocket guidelines. They have a big book, so it's interesting. And every panel, what's going on, is sending his paper for publication to European Urology every 2 or 3 years, according to the target of impact factor of European Urology in accordance with the editor-in-chief, Jim Cato, who wants an impact factor of more than 20. It's very high for a surgical journal. So, and Laurence is associate editor or board member of the European Urology Oncology, which is another journal from the family of the EU, where you can submit your paper if you have activity in the field of cancer. And you said, I was at UDOU. Can you accept my paper? And so she would say, maybe. And the journal is going to be indexed in 1 year. And they will release the impact factor in 2 years, I believe. So it's interesting to send a lot of manuscripts to European Urology Oncology. So what are we going to discuss? 4 points. The molecular characterization. You cannot escape or run away from this anymore. It's impossible, even as a urologist. So don't say, I was not aware. There is molecular characterization, even in upper tract. And we are going to discuss that. Perioperative systemic chemotherapy or immunotherapy. We launched a trial supported by AstraZeneca in France with the GETUG and the AFU, which is called INDUCT. I will speak about that. It's a phase 2 trial that we open in 12 centers in France. And it's the use of immunotherapy plus chemo around radical nephroureterectomy. So there is also an activity in the field of upper tract. It's difficult to convince the pharmaceutical partners to invest time and money in that entity because it's a rare disease. So, of course, and I would be developing a drug, I would prefer to have it prescribed on a large scale. But it makes sense also to, I would say, study specifically upper tract diseases. Avoiding undertreatment is the third point I would like to share with you, because for many, many years, the unique gold standard treatment was radical nephroureterectomy. Is there any possibility to do something else? And for all the urologists in the room, you have been doing flexible ureteroscopy to remove stones. Do you know that? Have you been to this kind of surgery? It's very fascinating. Olivier Traxer in Tenon. All the day long. And single post-operative dose of intravesical chemotherapy. So we can use the tools that were used for the functional urology, urinary stone, acute pain in the kidney, in the field of oncology. So we use the technology to treat cancer, and it's interesting. So first point is that it's a slide coming from Laurence Albiges, Johan Loriot. You can use it forever if you have this slide. Is the urothelial carcinoma a model of high mutational load tumor? Just meaning that if you have a cancer at a certain stage, and you have a diagnosis, it doesn't mean that this cancer, the face on the biological behavior, will stay as it is when you diagnose it. Meaning that when you have a discussion around a metastatic setting, and you had some biopsy that were coming from the early stages, maybe you are facing another disease, and you are facing something else. So you have to understand that there is a plasticity and evolution of the tumor along the time, and it's important for you to consider that nothing is frozen in the field of oncology, okay? Things can change. So this is why the tissue sample that you have should be adapted at the moment where you are trying to treat the patient. The urothelial carcinoma of the bladder and the upper tract are called the disparate twins, fake twins, okay? Les faux jumeaux. Why? Not only for the epidemiology, as I told you, because there are, of course, a lot more data available for bladder cancer for the simple reason that in France we have, for instance, 14,000 of bladder cancer new cases per year. The number of upper tract is around 3,000, 4,000. on the last, I would say, investigation that we had at the French Association of Urology. We had a scientific report about the upper tract, the data that were coming up from our, I would say, discussion, register, database, and so on and so on. But there is also, in terms of epidemiology and I would say process of development and carcinogenic pathway differences between bladder cancer and upper tract cancer, which are very interesting. For instance, the fact that some upper tract tumor belongs to the HNPCC spectrum, which is the so-called Lynch syndrome, hereditary non-polyposis colorectal carcinoma. I'm not saying today that any tumor that you are going to diagnose with any patient that you are going to diagnose with an upper tract has a HNPCC-like tumor. I'm just saying that you have to think about it when it comes to a young patient and when there is a past medical history of colorectal carcinoma in the family, etc. Just meaning that in facing this patient, you should lead a targeted medical interview. You don't want to see, do you have diabetes? Did you have prostate cancer in your family? No. You see a patient with an upper tract tumor, you need to raise the good points. And also the fact that we treat a lot upper tract tumor in parallel from what we know with bladder cancer, which makes sense. But if you agree with me, the gold standard today for locally advanced bladder cancer is neoadjuvant chemotherapy and cystectomy. And for many, many years, it was just radical nephrorectomy alone, and there was nothing in the field of upper tract. And we have seen that there was a very important trial which was released by Alison Birtle from the UK, which is called the PUT trial. PUT for peri-operative upper tract. Okay? In fact, it was post-operative, because initially she designed a trial to have the possibility to deliver before and after. And after, it's a problem, because if you remove a renal entity by removing the kidney, they have the possibility to deliver a cisplatin-based chemotherapy, which is linked with the renal function of the patient, makes the window of opportunity a little bit, I would say, smaller, because there is a proportion of patients that is going to decrease the renal function in 30-35% of cases, and this patient will not be suitable anymore for chemotherapy. So you could say, okay, if this is the case, maybe I should deliver the chemo before, because the two kidneys are working, and then I will take out the kidney. So this is a philosophy which is different, because if you discuss with a medical oncologist, say, look, I have an upper tract tumor diagnosed in my patient, would you be happy to deliver the chemo? Okay, but bring me the proof that there is a tumor. And you know that when you go to the bladder cancer, you can remove a big amount of tissue because you perform a transurethral resection of the bladder. When it's upper tract, it's tiny, small biopsy. And sometimes the cytologist or the pathologist is telling you, oh, I cannot say anything from the tiny bite of tissue that you brought back to me. It's impossible. So you have an ethical problem because you are going to deliver a chemotherapy to someone where you don't have the proof that the cancer exists. You believe it's true, but it's a problem. You cannot treat just an image on a CT. So it's challenging. So HNPCC, you should be aware of that, because the first doctors who were giving or treating patients according to the concept of personalized medicine is colorectal cancer. Because in HNPCC, there were short sequences of DNA, non-coding DNA, which were depicted by PCR. It has nothing to do with NGS, PCR, polymerase chain reaction. It's called microsatellite instability. It's non-coding DNA, very easily depicted, and always there in case of HNPCC tumor. And it translates the fact that there is an impairment in the mismatch repair genes, MSH1, MLH2, and so on. It has an influence on the prognosis. So young patients diagnosed with this type of colorectal cancer have positive microsatellite instability, and it has an influence on the prognosis, but not only on the choice of the chemotherapy. So in daily practice now, if you go to a tumor board where you have medical oncologists, gastroenterologists, colorectal surgeon, they will discuss colorectal cancer and say, is it positive for microsatellite or yes? And you go for a chemotherapy, can be Folfox or irinotecan in another case. And I don't know because I've not been updated, Leslie, on the field of colorectal cancer, but just to tell you that there was the first step towards the personalized medicine. And this has been translated in the field of urology because I told you that there was a proportion of upper tract tumor displaying microsatellite instability. Meaning that we know today that it has the same influence on the prognosis that as it was depicted in colorectal cancer, meaning that you have to do a targeted medical interview, and if you diagnose this type of patient, the median age of diagnosis is 75 years. So if you have a patient of 57 with a renal pelvis tumor, he probably belongs to the HNPCC. So he should undergo colonoscopy. If she is a woman, she should be referred to a gynecologist. So you as a clinician, even if you have not involved, I would say, in the molecular exploration, you need to have the good, I would say, behavior when you handle this type of patient. And that's very important because the spectrum, as you can see, is not limited to the colorectal or to the colon. It's broader than we thought at the beginning. Microsatellite instability is something which is done not by PCR anymore, and in most centers they do by immunohistochemistry, targeting the enzyme that I was talking to you about, MSH2, MLH1, MSH2, and it's quite easy to obtain and not very expensive. So I'm just sharing with you this publication, demonstrating once again that there are more and more teams working into the individualization of upper tract tumor. And you have heard that there were molecular characterization which has been promoted in the field of advanced bladder cancer, luminal, basal, scar-like. This is coming also in upper tract. So why? Are we facing the same disease? Apparently not. Not exactly the same. So it is interesting to make the distinction. But I agree with you, you can have also a concomitant disease. You have a primary tumor in the renal pelvis, and you have, I would say, a spread of the cells through the urinary flow in the bladder reservoir. So if you do a sequencing of the tumor, you will see that it will match between the bladder tumor and the upper tract. So it is less the case. You can have a primary tumor in the bladder reservoir, treat it, and a few years after, you can have another tumor in the upper tract. So there are different theories about the urothelium and the ability of the urothelium to initiate the carcinogenic pathway. This is the team for Surenamatin and set learners. They are very, very active. There is a genome atlas in the United States which has recorded a lot of tumor. And this is where the next big step is. And I mean, if a country like the United States has invested so much money in that, it is because these data will be absolutely precious for tomorrow's medicine. Because tomorrow's medicine is not a blood test anymore, it's there. This kind of tests that you will have available, the cost will decrease. We will do more and more sequencing and have more and more, I would say, to take into consideration the mutation, the polymorphism, and the way the tumor is likely to develop, because we are not equal facing a disease. You have the environmental factor, and you have your own DNA that you have from an inheritage from your parents. And it is, aside from the mutation, it's called the polymorphism, our ability to interact with the environment and to develop a disease. If you remember Chernobyl in the 80s, when there was this nuclear explosion in Russia, or in Ukraine, to be very accurate. Have you seen the TV show, Chernobyl? Very nice. There was a huge explosion in the incidence of thyroid cancer after Chernobyl, but not 100%. Meaning that some patients, being in a very aggressive environment with radiation, are still resistant to develop a disease. So it's come, as I told you, it's coming from the DNA that you carry and the environment. Some people are telling you should avoid smoking. But if in 20 years you can identify in the population the people who are likely to develop a cancer because they smoke, you will let the remnant part of the population smoke. Note that we don't know to do it. We said to everybody, stop smoking. But you know some people who have been smoking for 40 years and they do not develop any cancer, which is true. So it's like the chemotherapy. Not everybody going to respond to chemotherapy. Not everybody will develop a cancer if he smokes or she smokes. But as we don't know, we say, don't smoke. Okay? This is the reality. The PUT trial. The PUT trial is huge. It's called game changer. Game changer in the field, because if you look at the guidelines in the field of upper tract, as I told you, the grade of evidence is low. What have they done? They have recruited a lot of patients, because it's a rare disease, with an upper tract tumor. In one arm, 130, in the other arm, 130. And they had surgery, and after surgery, they were randomized between chemotherapy and surveillance, as we do it. So there was this opportunity, and this kind of trial can only be run in United Kingdom. It's absolutely fantastic, and you can see you don't have to be a statistician to understand that there was an advantage when you look at the survival curve for the group receiving the chemotherapy. So we don't have, I would say, the data are not mature enough to have survival data on the long run. We're still waiting for that. And this was presented 2 years ago, in 2018. So we were excited. For the people working in the field, we were a bit excited. A trial in upper tract and so on. And I've been sending emails to Alison Burton. I don't understand why you have been presenting that, and there is no paper, no article which has been published after, and so on and so on. And finally, 2 years after, like a turtle, smoothly, she came up in the Lancet. I said, there must be something behind this trial. She has difficulty to publish it. Because when Arnaud Méjean spoke about Carmena in front of the audience at the ASCO, the day after, it was published in the New England. 2 years between the presentation and the publication. So it's quite rare. And so now we have the paper. And you have to understand that when you launch such a trial, there is an independent group of experts, what we call IDMC. And they look at the data to see if the situation is safe and so on. And there was such a huge difference between the arm of chemo and the arm of surveillance that the IDMC has asked the steering committee of the trial to interrupt it. To say, no, it's unethical to keep moving forward by having an arm with a surveillance. So any patient who is undergoing a radical nephrorectomy in France or wherever you are in Europe should be discussed at the tumor board after the surgery to receive chemotherapy. What we can see is, as I told you, there was a challenge with the decrease of the renal function. And they say, okay, if you are in the arm chemotherapy, we'll stratify according to the renal function and maybe deliver carbo or cisplatin-based chemo. And actually, when you look at the forest plot and you read between the lines, it appears that, honestly, the chemotherapy which works in that field is cisplatin-based. There is, I would say, a trend, but not a statistic in favor of carbo. So usually, if you want to go for that, you have to discuss the possibility to deliver cisplatin-based chemotherapy. And Alison Burton has announced that she will launch a PUT2 trial, and she will probably use the immunotherapy in combo. But in the meantime, we knew that the PUT was launched, and in France, with the GTUG and the CCFU, I told you, we discussed the opportunity to launch a trial in upper tract, and we convinced the partner to follow us into that direction for the simple reason that I put you on the slide the pro and the cons in favor and against the possibility to deliver neoadjuvant chemotherapy. But on the paper, it makes sense. On the reality, it could be tricky and difficult. As I told you, you have what we call composite criteria to diagnose the disease and include the patient. So we will try to include 80 patients in France with a neoadjuvant setting receiving chemotherapy plus durvalumab. And trying to assess the impact of the systemic treatment plus the surgery on the outcome of these patients. There was a phase 2 trial was launched in United States by the ECOG Akron group, small group of patients. But interesting, you can look at the design and the methodology. They had high-grade upper tract, creatinine clearance, and you can see carbo, GEM, and MVAC, I would say the so-called standard in arm A. In arm A, there were a 14% complete response, meaning that at this time of radical nephrorectomy, they were PT0 on the specimen. So there is a debate now. It's the case also for the cystectomy. When you have an invasive tumor, you deliver the chemo, and you are PT0 at the time, at the stage of cystectomy. And some people are saying, why did you take out my bladder? I have no more tumor. Yeah, but you have the endocavitary disease, you have the bladder wall disease, and you have the micrometastatic phenomenon. And this is why, at some point, I agree, if you have an endocavitary clearance, it doesn't mean that the disease has disappeared, but the patient will not understand the situation. Or it is difficult for us to assess the development of the disease outside the bladder for the simple reason that not a single, I would say, modality of imaging is really performant and accurate in the field of bladder cancer. This is not the case in prostate cancer. This is not the case in kidney cancer, I believe. So bladder cancer is very tricky from that perspective. But we were discussing at the GETUG, and it was ongoing discussion for 1 year and a half, the possibility to launch a trial where you do chemotherapy, you do transrectal resection of the bladder, you have a T2 tumor, you do the chemo, you go endoscopically, it's a PT0, you have 3 arms. One arm cystectomy, one arm you do nothing, and one arm you would say you will deliver adjuvant chemotherapy. Very good question, very interesting question. But on the paper, the feasibility, and I think that when we went around the table, and I remember Stéphane Cullin and Karim Fizazi were leading the discussion, we had to end up with the conclusion that we could not do it. We could not do it because people on the field would have difficulty to propose the trial to the patient. And my point is, I will come to you. My point is that when you design a trial, you have, I told you yesterday, to sit on the chair and simulate that you would be a patient and you would face the proposal, would you accept it? If you have the feeling that you would not be in a situation to accept it, you don't want to come up with a trial because it's a long, time-consuming process to launch a trial. And when at some point you are disappointed by the enrollment and your recruitment, it's even more painful. What is your question? Upper tract? Not that we know, and that's also a point. Aside from the imaging, when you go to prostate cancer, PSA has been criticizing for many, many years, but it is still there. We discussed yesterday urinary marker, and there are few partners of this event, such as OncoDiag and so on. There are some markers in the urine for the follow-up of the patient that are coming soon, that you will prescribe but not yet reimbursed. But we are not a very accurate marker that we can have and use in daily practice so far. So, yeah. It's a difficulty that we have in the upper tract, and especially as I told you, because 50 years ago the upper tract were ranked in the renal cell carcinoma. So now they are ranked in the metastatic cancer, bladder cancer. And as I told you from the beginning, we need to work specifically on upper tract. This is the first step ahead, and it is a specific entity, and promoting, I would say, unique guidelines, delivering talk and session at the UDOU in many congresses dedicated to upper tract will help us to go into the good direction. But we are lacking tools in the management of this tumor. Look at the immunotherapy in upper tract. You see the proportion of patients in Vigor 210. 21% of upper tract included. And then Roche came to us and said, my phase 2 was positive, my phase 3 is negative. How do you explain that? I say, okay. So maybe one point we have to raise is the proportion of upper tract you have included in your patient population. It's not the only explanation, but it is something that has never been raised. They were looking at the statistic, the group, and so on and so on. But at some point, if you mix up together all these cases, and if you look at all studies from the 70s, you will see many, many studies dealing with metastatic renal cell carcinoma, where they include renal pelvis and big tumor from the upper tract. And they were, if you are a pathologist, there is a subtype, it's called collecting duct carcinoma of Bellini, which is quite rare, very aggressive in young patients, which has similar morphological aspects that they share together with the upper tract. And it's very interesting. We have never digged into this direction, and I think we should, because the Bellini collecting duct carcinoma is something that we see from time to time. It's very aggressive. So interesting. And when you look and you read between the lines, from Galsky at the ESMO in 2018, you can see that there was a higher objective overall response rate in bladder cancer, lower tract, compared to upper tract. So once again, it makes sense to have specific trial. You have a risk stratification. It is the case in prostate cancer. It is the case in bladder cancer. We have promoted this flowchart in the guidelines at the European level to help us, and probably the criteria are just clinical and I would say histological, will evolve in the near future. But at least it exists, and it will help you to select the patients that are probably the good candidates for the kidney sparing management. Meaning that today it is not acceptable to have 100% of the patient treated by radical nephroureterectomy when it comes to upper tract. I'm not saying oppositely that we should not perform radical nephroureterectomy anymore. But I believe that 2/3 of the patient should undergo radical nephroureterectomy, and 1/3, roughly, have to maybe undergo a kidney sparing strategy. And by kidney sparing strategy, please do not think only of flexible ureteroscopy. They have good treatments. For instance, I performed 2 weeks ago in an 82 years old a segmental ureterectomy with a robot, which is nice. You can do a small lymphadenectomy next to the segmental ureterectomy, which is quite tricky to perform with your flexible ureteroscope when you want to go to the nodes. If you have seen a ureteroscopy, you will understand my point. So I'm just saying that, and the tumor size has been underlined and emphasized because for several years it was 1 centimeter. And we raised the bar to 2 centimeters. It's very subjective because you know you can have several spots of the disease all over the upper tract and maybe one unique tumor of 2 centimeters. So it's very subjective. But when you design some guidelines, you have to discuss. You want to give the big picture and make a long story short. So it's very important for you to have and to send clear messages. But of course, on the field, it is difficult. And be careful. I think this picture says it all. It is a tricky disease and it can be aggressive, extremely aggressive. So yes, there are good candidates for kidney sparing management, but you have to select them. So at the end of the day, the question is, am I delivering an over-treatment by removing the whole kidney unit? And of course, your challenge is to remove the whole ureter and the bladder cuff. I've seen too many patients coming to my office because they had just a kidney removal for renal pelvis tumor with a remnant ureter which was left behind. And after, when you have a recurrence there, it's awful. So you, as a urologist, if you understand the behavior of the disease and the anatomy, then you remove the urinary tract. You don't care about the... So you have to deal with the bladder cuff. And it's absolutely important. Or to treat it endoscopically in the renal cavities, or you can decide to go for a segmental ureterectomy. Suboptimal versus over-treatment. This is the... I do that in elderly or in patient where there is one unique kidney, or in patient who are really begging for me to leave the kidney, because segmental ureterectomy for distal ureter lesion can be done even in high-risk lesion. So it's interesting, contingent upon the fact that the patient would be likely to achieve a very close and stringent follow-up and surveillance. And this is a deal that we have to discuss with the patient, because if he disagrees, if he doesn't want to undergo, it's like going to a gastroenterologist who would tell you every 3 months you will have a colonoscopy. Me, I would be happy, but maybe some people would be reluctant. It's a good opportunity to be on a diet. But the reality is there, is that you cannot follow up this patient just with the CT and the cytology. It is not enough. There are new tools that are coming up. This is interesting. It is used in gastroenterology as well. This is called confocal laser endomicroscopy, the cell visio system. It's like doing frozen section per endoscopically, you know, bringing the pathologist inside the patient. But the problem is for you to interpret these images, because you are a urologist. You look at this, you say, what's going on? What the fuck? If you are a German, because the German, they can do everything themselves. They can do the chemo, they can do the surgery. And I have invited a German to do Marcus Greffen from the Martinique Clinic. He came, he has done in front of me the pathology himself. He put the sample in the ink and so on. What's the point? He's doing everything himself. So, okay, but not everybody is German. So, we are in a situation where, okay, we bring back nice images, but we need to be able and to learn how to interpret these images. And if you come, the problem, you do a flexible ureteroscopy. You look at the paper, you say, let's have a diagnosis. You go next to the tumor. You see the tumor, and it's clearly written, you should take a biopsy, wait for the pathological assessment, go to the tumor board, discuss the patient, put the patient asleep again, under general anesthesia, and then treat him. And the patient, he doesn't understand. You are facing a tumor, you saw it, you do a biopsy, you should treat it. And most of the urologists are treating at the same time. But the problem, you never know if you are treating a high-grade lesion, because you don't have the assessment. And the cytology is not always reliable. So this will help you perioperatively to select the patient with high-grade lesion. And it's very efficient and available in gastroenterology already. So we are going to test it. Alberto Breda, who is working with Juan Palu, Fondation Puig Vert, Barcelona, he tried it already, he published a report, 14 patients, not that much, but anyway. There was a very good correlation between the cell visio system assessing the fact that it was a high grade and the correlation on the tissue sample. Very interesting. So you have to follow up on that. Last point, before we go to lunch, before it rains. We are very lucky during this UDOU edition. Each time we have a break, it's raining. Tonight you will enjoy the dinner. It's on a boat, under the rain. Very Parisian style. The guidelines, when you look at that, there is a grade B of recommendation for post-operative instillation of chemotherapy after radical nephroureterectomy. Wow. Who is a urologist in the room? Raise your hand. Okay. Who is doing that? Raise your hand. Nobody. Okay. Grade B of recommendation. So meaning that the patient can come up with the guidelines, say, why didn't you perform the instillation of chemo? It's like the early post-operative instillation after the transurethral bladder resection. There is a scar in the bladder. And when you look at the trial from Tim O'Brien and a trial from Asia, I think it's coming from Japan, assessing the efficacy of the chemotherapy in the bladder, they never mention when they do it after the surgery, in which delay. Tim O'Brien, you know the guy? He is brilliant, but he doesn't give many details on that. And the point is that if you believe in the concept of chemotherapy, you have to deliver it very soon after the procedure. So if you want to reinsure your patient and be safe, you will deliver it 15 days after. But 15 days is too late, because the cells, exfoliating cells, are, I would say, in the urine, should be destroyed immediately after the procedure. So what they do in some centers, they do a cystogram, 24, 48 hours after. If there is no leakage, they deliver the chemo. And once again, I told you you can have a recurrence within the bladder after a radical nephrectomy in 30% of cases. So it's a lot. So you need to follow up this patient. That's important. And what you have seen, if you use a flexible ureteroscopy, and you are very good at using this device, and you say, oh, I'm in the right kidney, let me go to the left kidney, have a look at the whole urinary tract. What has been detected is an increase in the number of recurrences in the urinary tract after the use of flexible ureteroscopy. So one question which is raised now is whether or not we should do an instillation of chemotherapy when you have performed a flexible ureteroscopy for an upper tract tumor, because there is a tumor seeding from the urine flow and from the manipulation of the tumor. What I do when I do a radical nephroureterectomy, regardless of the location of the tumor within the urinary tract, I put a lock, an hemolock, on the ureter, because if you manipulate and you move, I would say, the renal unit, you could disseminate some cells within the upper tract. To illustrate one last thing about the upper tract tumor, which is very interesting, it was published in the Lancet. It's called the Chinese herb nephropathy. Have you heard about that? There were some people, the story started in Belgium, in fact. There were some people in Belgium ordering on internet some Chinese herbs that they put in their tea, or they use for Ayurvedic massage. Have you done that, Ayurvedic massage? Ayurvedic, I don't know how to say it. Anyway, so these people are coming and they use herbs. But you have to know that many agents that are coming from the drugs are coming from the herbs, the active principle. Meaning that these Chinese herbs were going through the skin, were destroyed in the liver, and catabolized in the kidney, creating some irritative phenomenon, and leading to a cancer, renal pelvis cancer. And in this Chinese herb, they have discovered an acid which is called acid aristolochic. And it was perfectly described that you should not use some herbs for your tea or for your message without knowing which agent is active in this herb. And it helped to elucidate, I would say, a mystery in medicine, which was called the Balkan nephropathy. Because in the 70s, there were many patients, there was no transplantation in Eastern Europe, coming to France or coming to Western Europe to have transplantation, renal insufficiency, and a huge incidence of upper tract tumor in the eastern part of the Balkan. We didn't understand why. So there was 100 more cases in the Balkan in regard with the incidence compared to the remnant part of Europe. And with the advent of the exploration of the Chinese herb nephropathy, they went back to the Balkan, and they went to the crops, the field where the peasants are working, and they saw that in the herbs surrounding this population, there were a lot of acid aristolochic. And so it has been elucidated that the nephropathy from the Balkan is coming from the environment. I was telling you about Chernobyl, and the fact that you have your own susceptibility to the environmental factor, but there are some environmental factors that can influence the development of the disease. So the nephropathy of the Balkan, the Chinese herb nephropathy, is the same story. It's called acid aristolochic, which is the cause and which is going to trigger the development of the disease. So very, I would say, interesting, the link between upper tract and colorectal cancer when it comes to HNPCC, the link between upper tract and the nephropathy of the Balkan and the Chinese herb nephropathy. And I think that it makes sense to have a broad vision of what's going on in the urinary tract. Bladder recurrence following radical nephroureterectomy, I told you, is a challenge. And if you deal with this patient, you need to follow up on them. Any question with upper tract? Last point, yes? You are there, my friend. Look. You try to trick me, but I will reply just before you end your question. The phase 3 trial, which has been released, there was a small society from Israel. A few years ago, and they came up to my office, but not only to my office, but I had the opportunity to discuss with them and say, we develop a gel, like a gel, because when you do an instillation in the bladder, the problem is you put the product and you say to the patient, okay, turn your body upside down, keep it in the bladder for 1 hour, don't go to the toilet, and you expect that the product will go next to the bladder wall, which is okay, probably, but there is a dilution. If you have used contrast to do an imaging of the upper tract and you use a syringe, you have seen the dilution after 5 minutes is massive. You need another syringe and you ask the resident, give me more contrast, give me more contrast. So the BCG is the same story, okay? So the problem is like to put on the bladder wall something that is sticky enough to have an adherence to the bladder wall. The problem, I used it as a compassionate treatment in an elderly woman. She was 92 years old with a tumor and we didn't want to remove his kidney. So the guy came, he said, it's a chemoablation, it's fantastic. So it worked, but it was so sticky that she had an obstruction from the product at the beginning. So I said, whoa, okay, I will not do it again. You know, well, she died, but okay. But the primary chemoablation, now I would say that the product is mature. It was 4 years ago. And now they came up with this study, Olympus trial in the United States, which has been published in the Lancet Oncology. So it's quite a good journal when you have a publication dedicated to upper tract in that type of journal, Lancet for Put, Lancet Oncology. If you are interested of what's going on in the field of upper tract, you can read this kind of paper. And once again, Seth Lerner, Surena Matin, they came up with the possibility to use this gel, which is not, I would say, mature in its technical design. And they have shown that this is the gel that you will use. And so you will go next to the tumor and deliver it. The question is whether or not we should treat the tumor with the laser, do a biopsy, try to remove it, or just put the gel. So the technology is ready. Few patients have been treated already. And you can see that the follow-up was very stringent. Screening, baseline, 3 months ureteroscopy, 6 months ureteroscopy, 9 months ureteroscopy, 12 months. It's a journey, I would say. And anywhere, tumor is unreachable. And this is the particularity. You know that when you have a tumor in the lower calice, it can be tricky to go with your flexible ureteroscope. But when you use the channel, you lose the deflection. And you cannot use your tips and your tools to go and to treat the tumor. So there you can reach and put the gel and expect a chemoablation. So the urologists are saying, no chemoablation. We still remove the tumor and then we put the gel. You want to save your job as a urologist. But it is an interesting concept. You didn't see the population included, and we will expand this trial to Europe, and we will open centers now, very soon. And you will see that there is probably a future for this technology in the field of upper tract tumor. This is my Twitter account, because if you want to follow me, I'm happy to have you as a follower, especially the woman sitting in the room. And Laurence is one of my followers. And we interact by Twitter in front of everybody. Voilà. Thank you. And now I think it's time for lunch. So I would like to thank Laurence Albiges, Alberto Bossi, my friend Mostefa, who is behind, Alexandre Delataille, who is the godfather of my second son. And we are going to have lunch thanks to the organization of Sophie Salama and Mélanie Thébault. What? We start at 2 with prostate cancer, a small topic. And what else? And Bertrand Tombal, coming from Belgium.
So we don't care about the other disease. The most important thing is prostate, and you know. So I will be with Pierre Blanchard, who is radio-oncologist at Institut Gustave Roussy, to discuss with you localized prostate cancer, locally advanced prostate cancer. And tomorrow morning, you will have the Tombal show. During 4 hours, you are going to discuss all the metastatic part of the disease with all the molecules that we have now to treat our patient. So we are going to start with some short topic. We are going to discuss biopsies. We are going to discuss active surveillance. We are going to discuss, of course, surgery, because most of you are surgeons. So, of course, we are going to discuss radical prostatectomy and the place of the robot. and what is the advantage of this technology. And of course, our colleague Pierre Blanchard will discuss the place of radiation therapy for localized prostate cancer. And after that, we'll discuss locally advanced prostate cancer with surgery or radiation therapy. And probably the answer is surgery and radiation therapy, of course, in order to control the disease. After that, we'll have a short break and we'll have to discuss the oligomet and the place of local therapies. And we'll have some discussion or clinical case if we have time. So let's start with prostate needle biopsy. Clearly, during the last 10 years, I will say we had a really evolution and revolution in this prostate biopsy field. When I was medical student, we used to perform prostate biopsy under general anesthesia with your finger to know where you are going to put the needle. So clearly you see that there's a lot of technology now, and we are now dealing with this targeted biopsy, with the image, with the fusion image between your MRI and your ultrasound. And probably in the future, you will have a robot who will perform the biopsy, and it will be more easier for all of us. So I start with this clinical case because I want to have this session very interactive. So don't sleep because I'm going to ask you a lot of questions. And I know it's difficult after lunch to try to be awake and to continue to listen to all of the data that you are going to have. But clearly, I want to have interaction, so I put some clinical case and you will see how we are going to interact. So this is a man, 58 years old. He has his family, his father who died from prostate cancer. Last year his PSA was 3.4 and now this year it was 6. You are a good physician, so you examine your patients. So you do a digital rectal examination and you didn't find any problem, no nodule. And you have an ultrasound who tell you that the prostate volume is 45 cc without any hypoechogenic area. So what are you going to do for this patient? MRI. MRI for everybody? Yes? Okay, so MRI first. Yes, you're right. We have to perform multiparametric MRI. I really encourage you to have some course on how to interpret MRI. It's very difficult, at least at the beginning. And there is specific courses from uroradiologists to learn how to interpret the different sequence, because you will have to look at the T2 sequence, then to the axial dynamic contrast enhanced MRI, and also look at the diffusion sequence of your MRI to understand if the nodule that you saw on the T2 is really suspicious of prostate cancer or not. So you have to know that there is a classification for all the different nodules that you are going to see, the PIRADS classification that start at 1 and finish at 5. Of course, 1 and 2 is very inflammatory area, so not very suspicious. 3 is we don't know, and 4, 5 is very suspicious of malignant disease. There is also another thing that you have to learn. It's also that each part of the prostate has a number. Okay, so we start at the right base of the prostate with number 1. Then on the anterior part is 1A, then 1P, and 2P for the far lateral peripheral zone of the prostate at the base. So clearly there is a classification, and it's very well known and very used, of the location of where you are going to do the biopsy. And it's very important because the radiologist is going to use this classification to tell you where is the disease, and the pathologist is going to answer also to the location that you, of course, tell him when you send the biopsy. So what is the link and what is the correlation between the PIRADS classification and the risk of having prostate cancer? You see that clearly when you have there is, of course, a link. And if you have a PIRADS 3, you have a risk of having prostate cancer in 30% of the case. PIRADS 4 is more than 40%, 50%, and PIRADS 5 is 66%. Of course, it depends completely to the uroradiologist, because he's very aware about the MRI. They will are going to make a very good diagnosis, and they tell you exactly what you have. I know, for instance, in my area where I work, where I have to send my patient if I want to have a negative MRI. I know also where to send my patient if I want to have a positive MRI in 100% of the case. So clearly, you have to involve your radiologist in the interpretation of the MRI to have a good correlation between the pyrite classification and what you are going to have on biopsies. So what we have to know also concerning MRIs is depend of the radiologist, I told you. There is also an important thing, is that there is a correlation between what they see and what they don't see, and if it is or not aggressive prostate cancer. This study look at MRIs, and they compare two radiologists, and they look at also the volume of the disease that was seen on MRI, and then they compare to the pathological result of the patient who had surgery. And there is two important things on this table. First of all, when you have, when you have a very aggressive prostate cancer, so Gleason 8, 9, they see the disease. All radiologists see the disease in 1% of the case. When there is a very small foci of prostate cancer and not very aggressive prostate cancer, you see that they don't see him all the time, especially if the volume is low. So this is very important, because that means that you are not going to miss a very aggressive prostate cancer, but you are going to miss some insignificant prostate cancer. And this is exactly what we need in our daily practice. When you have a patient with an elevated PSA, you ask for MRI. If the MRI is negative, the risk of having a very aggressive prostate cancer is very low. It's not 0%, but it's 0 point something. But if you see something very aggressive, usually the patient have an aggressive prostate cancer. Again, it depends on the radiologist, the interpretation of MRI, and there is this Clara study who compare junior and senior radiologists, and they found clearly that senior are better than junior, of course, for interpretation, but there is also not the same conclusion between abnormal area, between radiologists, and between two analyses, because they repeat the analysis 2 months after. They give the MRI to a radiologist, and they give again the same MRI to the same pathologist 2 months after. And the correlation is not 100%, unfortunately, except for the very aggressive prostate cancer and the very abnormal area. So clearly, multiparametric MRI is very important to select the patient who are going to have a biopsy, and also to decrease the number of patients for who you don't have to perform biopsy because they have a very low risk of having a significant prostate cancer. So we continue with our clinical case. You have two abnormalities, pyrite 4 on the peripheral zone. So what are you going to do in your daily practice? You are going to do systematic biopsy, so random biopsy. You are going to do biopsy under MRI, or you are going to do biopsy with fusion of the MRI and the ultrasound. What are you going to do in your daily practice? Fusion biopsy, okay, with which system? Which system do you have? You have GPS-guided biopsies with the fusion of the MRI and the ultrasound. You have the Coelis system. You have the cognitive fusion, so it means that you know that it's on the right base, so you are going to do directly a lot of biopsy on the right base of the prostate. Or you do a lot of biopsy, 30 biopsy in the prostate, so you do a saturation biopsy, and then you have the diagnosis. Directly, okay? So there is different system. First, there is a biopsy under MRI. Not very used in France. I don't know in Italy or in Belgium if they have. In Lebanon, they have a lot. They do a lot of biopsy under MRI directly. It's very expensive because all the material is very expensive. The second possibility is what we call the cognitive fusion biopsy. You look at the MRI, you say, okay, there is a nodule, right base, very peripheral. So you perform your ultrasound and you put a lot of biopsy in this area. This is what we call cognitive biopsy. Third possibility, it's a real-time MRI ultrasound fusion. So this is a system that we have, and it's guided with a GPS. Or there is a 3D ultrasound image fusion and organ-based tracking. This is the Coeli system that is, for me, the best system to perform the biopsy. And unfortunately, I don't have it in my institution. So clearly, I'm totally not linked to different company. So first, first possibility is to perform the biopsy under MRI. And there is this publication a couple of years ago who look at patients who have two sets of negative biopsy. And they perform MRI and then perform biopsy in abnormalities. And they found an incidence of prostate cancer in 59% of the case. So very high incidence of prostate cancer in this case. Second possibility is the Coeli system. So it's a little bit time consuming, but clearly the machine is going to tell you with this 3D view, where did you do your biopsy? And is it far or not to the nodule that you have on the MRI? This is, for me, the perfect system. At the end of the biopsy, you give to a patient something like this, showing him the prostate, the abnormalities, and where you perform the biopsy. Another possibility is that what we have in my institution, it's a GPS-guided targeted biopsies. So you have the MRI, and the system have the integration of all the image of the MRI, and is able to tell you exactly and to show you exactly where you are, and you link it to the image that you have with your ultrasound, and so you can know where you do the biopsy. So I show a very easy case with this huge lesion that you have here, and you can see here on your ultrasound. The major advantage of this system is the quality of the image of the ultrasound that you don't have with the Coeli system. And this probably explains why I had a very good result with this system compared to the Coeli system. Because Coeli system, they put all the money in the software for the correlation between where you do the biopsy, the image of MRI, and the image of ultrasound. And in this system, they put all the money in the quality of the image that you have when you do the biopsy. And clearly, and sometimes you see exactly the same thing that what you have on MRI. So this is the result that I had in Mondor when I look at the result of the fusion biopsy that we perform with this system. And you see that so this is a protocol that we have with 18 biopsies. So we do the sextant biopsy plus 6 biopsy in the far lateral peripheral zone of the prostate. We do biopsy in the transitional zone, and then we do biopsy in the abnormalities seen on MRI. So when you look at the result of only 6 biopsy, you see that the detection rate is 63%. When you add the 6 biopsy in the far lateral peripheral zone of the prostate, you increase the detection rate to 72%. Then if you add the transitional zone, you have a 91%. And if you add, of course, the MRI-guided biopsy, you have 100% of diagnosis. If you perform only targeted biopsy, you see that the incidence of prostate cancer in this group is only 73%. So clearly you miss some prostate cancer when you are going to do only targeted biopsy. And this is the reason why you have in the recommendation that you have to perform systematic biopsy plus targeted biopsy, not only targeted biopsy. So there is a publication who compare the 3 approach: cognitive biopsy, targeted by GPS, and the Coeli system. And they found that Coeli system is the best system in order to really detect prostate cancer. What is the future? The future is artificial intelligence. Artificial intelligence is going to tell you exactly where is the cancer, and on the pathology, is it really a cancer? So we have to keep in mind that in the near future, pathologists will be in trouble because the computer is going to read the slide, and going to tell you exactly if there is a cancer or not. And this artificial intelligent program look at the MRI, look at the slides, and compare, you see, the correlation between the two with the area under the curve of 0.96, so it's close to 100% of specificity and sensitivity. So what do we have in the EU guidelines concerning biopsy? You see that in biopsy-naive patients, we have to perform a multiparametric MRI before the biopsy. Second point, when you have a positive MRI, that means period 3 or more, you have to combine systematic biopsy and targeted biopsy. And if the multiparametric is negative, so period 1 or 2, and you have a clinical suspicion of prostate cancer is low, you can just follow the patient and not perform a biopsy right now. There is one important study that you have to know, is a precision trial. Who knows this trial? Who knows the conclusion of the trial? What is the conclusion of this trial? You don't know. Okay, but at least you heard about this study. So this is a very important study published in New England Journal of Medicine 2 years ago. They include patients who have a suspicion of prostate cancer based on abnormal PSA or abnormal DRE. And they random the patient into groups. First group, they perform multiparametric MRI. If it's negative, no biopsy. If it's positive, they perform targeted biopsy. If not, they go directly, in the other group, they go directly to 12 systematic biopsies. The primary outcome is the proportion of men with clinically significant prostate cancer, that means a Gleason score greater than 3.4. And they have secondary outcome with a proportion of men with clinically insignificant prostate cancer, the proportion of men who avoid biopsy, and also the post-intervention complication. And what they found is that when you perform MRI and targeted biopsy, you have an incidence of significant prostate cancer in 38% of the case, compared to 26% if you do only systematic biopsy. Clearly, there is an advantage. And again, you see that there is very good uroradiologists who perform this study and were included in this study, because you see that the rate of clinically significant prostate cancer when you have a period 5 is 83%. Okay, so clearly, interpretation of MRI depends on the radiologist. So what they found also, that they found that 28% of men didn't have prostate biopsy, so they are not included in this group. And so that means that there is a group of patients who don't need prostate biopsy. There is 12% more of men who have a clinically significant prostate cancer. There is 13% fewer men with clinically insignificant prostate cancer. So clearly, there is an advantage by performing this prostate targeted biopsies. Any question concerning the biopsies? No, it's fine. So we move on to active surveillance. And we start with this clinical case. We have this patient, 55 years old, no past history, no urinary problem, no erectile dysfunction. He has in his family his uncle who has prostate cancer, and he has on PSA screening a PSA of 3.5, normal DRE. The GP did the MRI, who found the period 3 lesion in the 3P zone, and he had 12 biopsy. And we found a prostate cancer, Gleason 6, on 1 millimeter, on 3 millimeter. So my question for you is, do you agree that this patient can have active surveillance? And yes?
Yes.
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 And what is your active surveillance protocol?
Like examination of the rectal.
Yes.
And when you ram the first year.
Yeah.
And PSA.
Yeah.
And
Biopsy?
no. Yes, 1 year, yes. Biopsy.
Active surveillance, not just what you're waiting, okay? So biopsies?
Yes.
Okay. So you are going to follow the patient with a PSA, with the MRIs, and with biopsies. Okay, when are you going to repeat biopsies? 1 year?
Yes,
At 1 year?
at 1 year, and if it's okay, we can wait.
Okay, what is your protocol? I'm interested in that. What is your protocol of active surveillance? There is a lot of protocols. There is a lot, but what is yours? Because you read all the literature, so you are now an expert.
Yeah, John Hopkins.
John Hopkins. Okay,
Yes.
so what do they do?
They just repeat the PSA, okay, following with the patient with MRI 1 year after, and this is the surveillance for the patient. After that, if there is a criteria for to go out of the surveillance,
Yeah.
if there is PSA more than 10,
Yeah.
okay. Second one, if there is 3 biopsy or 2 biopsy, okay, positive. Okay, if there is the option of the patient to go out of the surveillance. Okay.
Okay, everybody agree? So we are going to see the different protocol because there is a lot of publication on that, and there is not really a consensus on well, there is some consensus on inclusion criteria, but we'll see that there is a lot of different attitudes. So let's see what do we have in the literature concerning active surveillance. Just to tell you first that active surveillance is completely different to watchful waiting. Watchful waiting is that you had a prostate cancer diagnosis, you have an old patient, you are going to see him every 1 or 2 years with PSA or nothing. So it's for patients who are no risk of dying from prostate cancer. So it's a palliative attitude. It's just for patients who have a life expectancy of less than 10 years. Okay, so clearly patients who are not going to die from prostate cancer. Active surveillance is for young patients who have a long life expectancy, and we are going to reassess the cancer with DRE, PSA, rebiopsy, and MRI. So what are the inclusion criteria that we have in the literature of paper looking at this active surveillance protocol? You see that at least all of them include patients with Gleason 6, but there is some study who include patients with Gleason 7. You can include a patient with a Gleason 7 in active surveillance if the grade 4 is less than 10 to 20% of the grade, of the total grade. Okay, so grade 4 less than 10 to 20%. Positive biopsy, you see that it's between 2 and 3. The major problem is that all of these different studies have a different protocol. Sometimes it's based on 6 biopsy, sometimes on 12 biopsy, sometimes on saturation biopsy. So, on this point, there is no consensus. Percentage of cancer involved in single core, usually less than 50%. PSA, less than 10, but sometimes you see less than 20 or 15. So what do we have in the recommendation? It's for patients to have a PSA less than 10, PSA density less than 0.2, clinical stage T1, T2, Gleason score usually 6, but some Gleason 7 with a grade 4 of less than 10 to 20%, 2 positive biopsies and not more, and of course for patients who are willing to attend to the follow-up visit. So when are they going to discontinue active surveillance, and what is the proportion of patients who will stop active surveillance? So you see that the median time from entry to discontinuing active surveillance in years is between 2 and 5 years. What is the proportion of patients who are still under active surveillance at 5 years? So this is patient who discontinue. So patient who continue is usually between 50 to 70%. And at 10 years, half of the patient continue active surveillance. So this has to be discussed with the patient when you are going to see him for a prostate cancer diagnosis and for who you think about an active surveillance protocol. What is the risk of dying from prostate cancer, despite the fact that you go for active surveillance and despite the fact that it's a very low aggressive prostate cancer? You see that the risk of prostate cancer mortality is very low, between 0 and 2%. So it's not 0. In some cases, unfortunately, there are patients who will escape from this active surveillance, who will be lost of follow-up, or they will have a progression of the disease and you didn't see it. It can happen. So when are you going to stop active surveillance? First, based on the PSC kinetic. If you have a PSA double incline less than 3 years, you have to stop active surveillance. If you have an increase in Gleason score or an increase in tumor volume, you are going to stop active surveillance. You, of course, some patients are very afraid about having prostate cancer. There is some patients who are very stressed about that. They have a lot of anxiety. So in this case, you have to stop active surveillance and go to a curative treatment. What do we have also? In other issue of active surveillance, there is a non-compliance of the patient, anxiety, we discussed. And there is also the risk of repeating the biopsy in terms of infection, in terms of disease, in terms of pain. And so, of course, you have to discuss that with the patient. So if you ask me how I do active surveillance, I was waiting for this question, but you were not, you didn't want to ask me directly this question. So I usually follow the protocol that we had in France. We had a huge protocol of active surveillance, and I copy exactly the protocol. So I repeat the PSA every 6 months. I do a re-biopsy at 6 months, and then I perform biopsy every 2 years, and I include MRI every 2 years. Okay? Of course, in the future, we hope that MRI will be able to help us to identify patients who will progress, and we are going, I hope, to stop to repeat biopsy because it's painful. It's always a risk of having prostatitis. So in the future, of course, we will have imaging, and we have all these different markers, very interesting on the paper. But unfortunately, in France, very difficult to have because it's not reimbursed. So the patient have to pay, and this is a huge problem. For instance, we have a Prolaris. This is a gene expression profile of the patient to tell you if the risk of progression is here or not. But the cost is 1,500 euros. So usually the patient doesn't want to pay, unfortunately. So do you have any question concerning active surveillance, or is it clear? Yes. Yes. Yes, you can. Yes, it's not a problem. Okay. So I stop on these 2 topics. Pierre is going to discuss radiation therapy for localized prostate cancer. Yes.
Good afternoon, everyone. Thank you, Alexandre, for the invitation. So we're going to discuss two topics about radiation therapy for prostate cancer, and we've changed a little bit the protocol because I have to do something in 1 hour, but I'll be back for clinical case discussion. So I'm a radiation oncologist at Gustave Roussy, and the first talk is on localized prostate cancer, and then we'll discuss locally advanced. So the first talk is on the best protocols for localized prostate cancer. It's supposed to last 15 minutes, so it's going to be a short talk, and I will discuss what we call fractionation, so the number of fractions that we do. I will discuss brachytherapy and hormonal therapy mostly. So just to start with a little bit of physics, just a little bit of physics to wake you up. We use photons for radiation therapy, and as you know, all photons, they go through the matter. So if you send a photon beam, it goes through the patient and it goes out of the patient at the other side, which means that if you treat the prostate here, as you can see between the 2 dotted lines, you will give dose at the entrance, then to the prostate, and then at the exit of the patient. So that can explain some of the side effects. The best way to deliver radiotherapy is using proton machines, because proton machines, they don't have exit dose. They have an entrance dose at the beginning, but then they stop at the end of the patient. So you don't have an exit dose, and so you have much less dose outside of at the back of the treated volume. Those machines are very expensive, and to be fully honest, I'm not sure it's very useful for prostate cancer. There is another way to give radiotherapy very precisely to one part of the patient, is to use brachytherapy. And brachytherapy, you put the radiation directly inside the tumor. So basically, you don't have entrance dose because the seeds are inside the tumor, and you don't have an exit dose because, again, they are inside the tumor. So that's with brachy, you just give dose to the prostate and very limited dose to the surrounding organs. Of course, there's a little bit of dose to the surrounding organs. And what is also appealing with brachy is that, as you all know, the prostate moves. If you have a feces or a gas in the rectum, then the prostate goes moves forward. If the bladder is full, then it goes a little bit below. So the prostate moves. If you have your brachytherapy seeds, then they will move along with the prostate. So clearly, brachytherapy is the most conformal technique to deliver radiotherapy, and that explains parts of the results. And so, how do we give brachy? And I encourage you, if you can, to go and see your radiation oncologist to see one implant of brachy. It's in the dorsal lithotomy position using ultrasound or MRI guidance and ultrasound. And you put the seeds inside the prostate using a transperineal approach. So that's something that has been done for the last 30 or 35 years using the techniques that we use today. Of course, the tools are a little bit better today, but we have very long-term follow-up for those patients. It's used as a definitive treatment, monotherapy in low-risk disease, but most of these patients now undergo active surveillance, and in favorable intermediate risk disease. Classical contraindications to brachytherapy are the presence of low urinary tract symptoms. Typically, we say that an IPSS above 15 is a contraindication. In most patients, we would actually treat only patients with an IPSS below 10, I would say. Why is that? Because the most severe side effects from brachy are urinary side effects that occur between 3 and 6 months after the implantation, mostly irritative side effects. And if you have a patient that already has those symptoms before, it's going to be really a problem for him. Large prostates, superior, the limit is 60 cc. A large or a recent TURP, if you have a TURP, it's quite obvious that you don't have tissue where you can implant the seeds. So if you don't have, you cannot leave the seeds in the urine, of course. So you need tissue. So a large TURP is a problem. And then there are problems with the implant, like pubic arc interference and, of course, contraindication to anesthesia. The results, that's a series of 300 patients that had been treated at MD Anderson when I was there. As you see, only intermediate risk prostate cancer, 300 patients. It's favorable intermediate risk prostate cancer. PSA between 10 and 15, Gleason 6, or Gleason 7, 3+4 with a PSA below 10. At 5 years, 6 patients have relapsed out of the 300, so it's about 95% of biochemical control at 5 years. And then with our urologic colleagues, John Davis, still at MD Anderson, we have compared in a prospective cohort that was not randomized, but 2 series of patients treated with either robotic nerve sparing, prostatectomy, or brachytherapy, and looked at the quality of life, not at the oncologic results, but at the quality of life. And as you can see here, we see better rates in terms of incontinence and impotence for brachytherapy, as expected. We see lower rates for brachytherapy, so better rates for surgery in terms of urinary bother or obstruction. That's what we need. There's something that was not very clear, is that patient had a higher satisfaction rate with brachytherapy than with surgery, and I think that's something that should be explored, because decision regrets is something that's being studied more and more, and it very much depends on the way the treatment is being presented, the way the side effects are being presented. So we don't have a reason for that. It's just it's in the EPIC questionnaire. There's a question about satisfaction. So it was just the result. So that's basically what you see. And of course, when you look at the symptoms by symptoms, of course, sexual function is better with non-surgical treatment, but urinary function is better if you have removed the prostate, you have less obstruction. That's obvious. So that's the results of brachy. I want to really make a point here because there are less and less centers that do brachytherapy, and it's a very good treatment for localized prostate cancer. So external beam, we have treated these patients with 8 weeks of radiation for a long time. And what we know is that increasing the dose of radiation will increase the PSA control. That's quite obvious, at least 7 randomized controlled trials. But there is more rectal toxicity, mostly. And that rectal toxicity can be mitigated if you use proper treatment, so image guidance and IMRT. So that's the way most people do 8 weeks of radiation using IMRT and what we call IGRT, which means that we reposition every day the prostate to the place where it is really. If you just remember a few years ago, if you wanted to irradiate, as is shown here, the lymph nodes, you would have put the same dose of radiation in a big square all over the place. Here you can be much more conformal. What we have known is, since the past 4 or 5 years, is that you can decrease the number of fractions from 40 to 20, so half of the fractions. There are multiple randomized trials, 3 very large non-inferiority trials, more than 6,000 patients that have shown, and here is just one example of the Canadian trial called the PROFIT trial, published by Charles Scatton and the colleagues from the PMH. Showing that you have exactly the same PSA control if you do either 8 weeks or 4 weeks of radiation, and no increase in toxicity. In these trials, there were only the prostate and the base of the seminal vesicles were treated, so no pelvic radiations. It could be a problem if you want to treat the pelvic lymph nodes. What we now know, what we would call the new kid on the block, is stereotactic body radiotherapy. So it's the use of highly conformal radiation techniques that allow you to deliver not 2 gray per fraction, not 3 gray per fraction, but between 7 and 8.5, 9 grays per fraction, which means that you can treat the prostate in 5 days instead of 4 weeks for 20 fractions, or 8 weeks if you give 40 fractions. And as you can see here, that's the example of the hypo-RTPC trial from the Scandinavian group, published in the Lancet last year. The PSA control is exactly the same if you give 8 weeks of radiation or 7 days in this trial of radiation. It was this one. But the most frequent protocols are 5 days. Similar PSA control. Again, 2 very large randomized trials, but again, no pelvic nodal radiotherapy in these trials. So if you need to treat the lymph nodes, you could not use such short regimens. And in terms of GU and GI toxicity, no difference. So that's what it looks like, a patient treated at Gustave Roussy. You see, so we contour the prostate. We can do a fusion with the MRI. What you see here is a prostate, is a spacer here between the prostate and the rectum that I had implanted using a transperineal approach under local anesthesia, and you can create some distance between the prostate and the rectum to also avoid some rectal toxicity. So that's the way we contour, and in terms of dose, the dose is very conformal, and you see the dose mostly centered on the prostate and less dose to the rectum because of the spacer. That's a way we can treat prostate cancer patient, especially low and intermediate risk prostate cancer patient, in 5 days. It's not exactly 5 days because it's every other day. So it's actually a week and a half, but it's 5 treatment days. So because we are able to do all those stuff and great radiation and high dose and very conformal and no more side effects, of course, the side effects don't change. It's the same, it's just shorter time, the same side effects. We don't need hormones. And here I am going to disappoint not you, but the patients, because everyone would love to get rid of the hormones, but we cannot. And in these intermediate risk prostate cancer patients, we have shown that increasing the dose of radiation decreases biochemical failure. But the only thing that increases overall survival is the addition of ADT. So in intermediate risk prostate cancer patient, we need to give ADT plus radiotherapy, at least in unfavorable intermediate risk prostate cancer patient. Maybe in favorable, I think radiotherapy alone, or surgery alone, of course, would be sufficient. But you see here in this large study by the EORTC published by Michel Bolla that if you have received 70, 74, 78 gray, the benefit of the hormonal therapy is consistent. And that's true in multiple other trials. So that's a very consistent message. You need hormonal therapy with radiotherapy if you treat unfavorable intermediate risk prostate cancer patient. So what about salvage? And just 2 slides on salvage. The first point is how many patients require salvage. And that's a very important work that had been done by Jean-Baptiste Boval and colleagues on 4,000 patients in 7 academic centers. I believe you took part in this study, Alexandre. Only intermediate risk prostate cancer patient. Only intermediate risk prostate cancer patient. And the need for adjuvant therapy in this patient that had undergone surgery was around a third of the patient, and that was 43% in patients who had unfavorable features. Unfavorable being a predominant grade 4, being more than 50% of positive biopsy core, or being multiple intermediate risk factors. So you have a PSA of 12 and Gleason 7, then you are considered unfavorable. And so and you can see here that if you have one unfavorable intermediate risk factor, one unfavorable factor, the risk of requiring adjuvant therapy is 40%. If you have 2, it's more than 50%. And that's very important when you consider the patient, that you can tell them, I think what could explain the satisfaction results that I've discussed at the very beginning is that patients are being told sometimes that surgery will be a monotherapy. And although it's clear for high risk that you tell them it's surgery plus something, even in intermediate, it's surgery plus potentially something. It's not, we all hope that it's going to be only surgery, but you never know. So that's very important in terms of number of patients requiring adjuvant treatment. And when we do adjuvant treatment, well, what we know now from the 3 large randomized trials that have been presented last year is that early salvage is equivalent to adjuvant treatment. So we almost never give adjuvant treatment at my institution, only to patients who have a persistent elevated PSA, but that's not really adjuvant. There must be something left. And if you give early salvage, you will avoid overtreatment. If you give adjuvant, you will treat many patients who don't require adjuvant treatment. So that's important. The dose remains high, and it's 66 to 70 gray, and we don't do hypofractionation because when in a postoperative setting, the risk of toxicity increases with the fraction size, so you will have too much toxicity if you give hypofractionation. So far, if you, the patient treated with salvage radiotherapy have longer treatment than patients treated with definitive radiotherapy. And salvage radiotherapy is more toxic than definitive radiotherapy. Of course, you add the toxicity of both treatment. What about androgen deprivation therapy? It clearly improves clinical PFS, especially in patients at high risk of relapse. So we do give ADT plus radiotherapy in patients who have a high PSA value at relapse, so above 0.5, a rapid PSA doubling time, less than 9 months, a high Gleason, primary Gleason. If you have a very predominant Gleason 4 or Gleason 5, of course, you would give it, or T3B, or, of course, a macroscopically relapse. So that's the key point to me in terms of salvage treatment. So conclusion, brachy is very important, and you should keep brachy in mind. Moderate hypofractionation is the standard of care for external beam, except when you need pelvic nodal radiation. Stereotactic body radiotherapy to replace moderately hypofractionation, but the technical aspects are important, and it's still taking, it's still coming into the centers, I would say, in France. We've been using it routinely for 2 years at Gustave Roussy, but that's quite recent. And ADT is key in unfavorable patients. What we don't know is the role of pelvic radiation. So you can do it, you don't have to. There's no, it's like a pelvic lymph node dissection. It's not clear if it has a curative role or if it's a diagnostic or staging role. So same for radiation. Do you have any question for this part on localized treatment? So that's not completely clear. We have two studies, one from the US who used 2 years of bicalutamide, and the study from France, the two large studies, the study from France used LHRH analogs for 6 months. So in France, we mostly use 6 months, but it can be discussed. And it depends also if you treat a salvage patient who had positive lymph node, sometimes you want to give a bit longer than just 6 months. But yeah, 6 months is appropriate. Minimum, yeah. Any other question?
So you said that in your institution, hypofractionation is a standard now.
Yeah.
Do you think it's going to be the same for the other center?
So the big problem is that in countries like the US or France, you are paid by the fraction. So if you give 20 fractions, you are paid half the money that you would receive if you give 40 fractions. So that explains why a lot of liberal centers don't do hypofractionation. And even in academic hospitals, we still with the T2A paid by the fractions. So that's the same problem. And sometimes the director of the hospital tells you, you have to treat longer. So there's a big problem. What has been going on for a long time is to have a bundled payment. So you would receive some amount of money for prostate cancer treatment, whatever the modality of treatment, surgery, radiation. And if we do that, I suspect that many centers will start using short fractionation, of course, or you're using brachytherapy again, because brachytherapy is almost not reimbursed. So that would be very cost effective for the patient and for the hospital. So, yes. So hypofractionation, 60 gray in 20 fractions should be the standard of care for all of these patients. That's just a simple message. There was no selection in the randomized trial according to IPSS, prostate size. And all those trials have been done in intermediate risk prostate cancer patients. So that's typically all those patients for whom probably pelvic lymph node dissection, pelvic radiotherapy has no role. And so you can treat just the prostate or prostate plus seminal vesicles. Yeah. Okay. Okay. So sure. Good. So good point. So I misunderstood your question. I thought it was compared to 8 weeks of treatment. But then if you have SBRT is a very good option, and for most patients, SBRT would be appropriate. Sure. Can you? Yeah. So so I did not talk about that. It's a good point. We can see a few slides in the talk, the next talk. You'll see, because we discuss a little bit the difference between surgery and radiotherapy in terms of side effects, and they are not so much different for us for intermediate or high risk prostate cancer, except for hormones. So we can move to the next talk. Okay. So locally advanced prostate cancer. It's a different field. Okay. It's a different field, and I want to talk about 3 things. First, very quickly, what was the foundation of making ADT plus radiotherapy the standard of care for such a long time? Second, discuss about the comparison between surgery and radiotherapy, and then delve with a little more detail into what is the optimal radiotherapy regimen for those patients. So, where does the evidence come from? First, maybe 30 years ago, or Professor Delatay can correct me if I'm wrong, but surgery for locally advanced prostate cancer was difficult, was not done, so those patients were not operated upon, and radiotherapy was the standard of care for those patients. And we have had 2 series of randomized trials. One series has shown that long-term hormonal therapy in these patients, in addition to radiotherapy, improved survival. And as I told you, we have multiple evidence showing that ADT improves survival in prostate cancer patients that don't receive surgery. One by the ORTC, very famous, from Michel Bolla, and one from the RTOG that I present you here. So adding long-term ADT improves survival over radiation alone. But at some point, back, and I'm talking about back 20 years ago, the medical oncologists, the urologists said, okay, that's very fine, but if you just give ADT to those patients, it would be as good as if you give them ADT plus radiotherapy. So those trials have been done that compared ADT alone to ADT plus radiotherapy. And as you can see here, there is also an increase in overall survival or in disease-specific survival if you give ADT plus radiotherapy compared to ADT alone. So ADT plus radiotherapy is better than ADT and is better than radiotherapy alone in terms of overall survival. That's what made the standard of care long-term ADT plus radiotherapy. And then we've had multiple surgical teams, including Mondor's, but many other centers that have done, one last thing. We have increased the dose of radiotherapy over the past decades by 10 grays, and those 10 grays going from 70 to 80 grays, so 7 weeks to 8 weeks of treatment, have all shown an improvement in biochemical failure. So you have more PSA control, but you don't have more survival. So that's very important. ADT improves survival, increase in radiotherapy dose, improves PSA control, but not survival. So, and as I was saying, many surgical teams have started doing surgery on those patients. Remember, it's not exactly the same kind of patients. The patients in the randomized trial that I was discussing before were clinical T3. They were clinical T3 with clinical T3 digital. I'm sorry, I'm repeating 3 times, but it's not the same as the MRI T3 that we see nowadays. And you see a very small extracapsular extension on the MRI, but the patient, if you do the DRE, is T1C. So it's clearly not the same kind of patients. But these patients have started receiving surgery with good results. And if you look at the guidelines, the NCCN guidelines that last year, but it hasn't changed, you see that you have 3 options for those patients. ADT plus external beam, ADT plus brachy plus external beam, or surgery followed by whatever you need in terms of adjuvant treatment or salvage. So what do we know about the surgery up front in those patients? Well, actually, we don't know much. And I'm sorry because I'll miss the talk of Professor de la Taille, but what we really know is that it's being used more and more. So if you look at patterns of care, it's being used. Surgery is in gray here, so it's clearly increasing over the year, and external beam is the light orange that was over 40%, and that's decreasing. So clearly, those patients receive more and more surgery and less external beam radiotherapy. So that's patterns of care. What we do know as well, and similar to what I've told you about intermediate risk patients before, is that these patients receive, a lot of these patients will require adjuvant treatment. So clearly, for locally advanced disease, we're not talking about surgery alone, we're talking about a combo, surgery plus some form of treatment. And if you see here in this publication by the multi-institutional team with Alberto Briganti and Firas Abdollah, you see that these patients, what they've grouped them in 5 groups, and the highest risk groups, 70% of those patients will require adjuvant treatment. And if you look at the grouping, you see that they're supposed to be high-risk patients. It's written in the title. But if you see the PSA, the cutoff for PSA is 10, you have Gleason 7, so it's not very high-risk patients. But you see if you have in one of the 3 groups with the highest risk, many of those patients will require adjuvant treatment. And again, if you look at the type of patients, many of those were just T2C. It's using the D-Amico classification. So D-Amico puts you high risk if you're T2C. It's not the NCCN where you need to be T3. So, so surgery alone in those patients is probably not an option. It's surgery plus something. Then the level of evidence was lots of databases study. That's a systematic review that was performed by Chris Wallis, who's a urologist from Canada. And he just looked at all those databases. You have to pay attention because those databases, they contain a lot of biases. The follow-up is usually short, so it's close to 5 years in many studies, and it's probably too short even for high-risk prostate cancer. There are lots of missing data. We don't know what type of external beam radiotherapy they have received, how long they've received, ADT, what dose they have received. But for surgery, we don't know if they've had pelvic lymph node dissection. There are lots of unknowns. But those studies are very large with thousands of patients. So it's very, it's striking. You see, if they have 10,000 patients, it must be true, but it's not. But if you just look, for example, at the age of the patient, of course, patients who undergo surgery are about 5 to 10 years younger in those studies than patients who undergo radiotherapy. There are big differences and biases. But what do they show? They show that all of them basically show that surgery leads to higher survival and higher cure of prostate cancer than radiotherapy. But you have to keep in mind those biases, and it's a very important point. There's one study, this one, that I always present when I'm giving those kind of talks. It's the public health team at MD Anderson who has done a study on SEER. So the SEER is a registry of cancer patients in the US. And they have looked at whether they could reproduce findings from randomized trials. And they also have looked for prostate cancer patients at survival, as has been reported, between patients who undergo surgery and who don't undergo surgery. So it's 30, 50,000 patients, like lots of patients. And what you can see here is that the patient who undergo radical prostatectomy is the blue line, is on top. So that's perfect. Radical prostatectomy leads to the highest survival. But what they have done in this study, that's interesting, is they have also put inside their model a group of patients who didn't have cancer. And what they show is that that line of patients who don't have cancer, and it's the red line here, they also do worse than the patient who undergo radical prostatectomy. And what we see here, so if that's true, I mean, there are lots of men in the room. There's also lots of surgeons. If that's true, then it means that giving you a prostatectomy will lead to higher survival, whatever you have, even if you don't have cancer. So maybe we should all male here undergo a prophylactic radical prostatectomy to increase our survival. So we all agree that it's ridiculous, but that's the same kind of things that are shown with those studies who reports higher survival. It's just bias. It's just bias. And when they looked at the reason of death and the comorbidity that those patients had, of course, the reason for death, here you see here, for patients who have had radical prostatectomy, they have a lower risk of dying from COPD, from dying from a stroke, myocardial infarction. So it's just not the same kind of patient. They're in better physical condition. And that's what explains the differences. Okay? It's very important to keep this in mind. Another team of researchers have tried to reproduce, using those big databases, the findings from randomized trials. And just to make a long story short, they failed. So they found an agreement in just 40% of those studies. So the databases, they are interesting to look at patterns of care. They are interesting to look at the way we treat patients in different countries, but not to do what we call comparative effectiveness research. To do so, you need randomized trials. So this one from Wallis, European Urology, very high impact, to the trash, okay? And all of those, to me, it's very important. You need to have honesty in the way you receive research, and that's very important to see the biases. Okay, what we do know from comparison between surgery and radiotherapy, unfortunately, we do not know in locally advanced prostate cancer, because the PROTECT trial that has randomized patients between surveillance, well, monitoring, not really active surveillance, but active monitoring, prostatectomy or radiotherapy plus 6 months of hormonal therapy, has shown no difference in survival, but that's very low-risk patients, so it's not that much interesting. But they have also shown the differences in quality of life of those patients. And here are the results that you were asking for, the results in terms of incontinence, and as you can see, patients who have received radiotherapy have basically the same rates of incontinence as patients who have not been treated. and of course, there is more incontinence in patients who undergo surgery. And here for erectile function, there is a drop initially because all those patients had hormonal therapy with radiotherapy, but then they go close to the group of patients that had not received treatment. So that we know in terms of difference of quality of life and side effects, that's from big trials. What we also know, and I've talked about it a little bit before, is that if you do multimodality treatment, you will do multimodality toxicity. Okay, so that's very important to know. If you look at this paper from European Neurology, they've looked at the CIR Medicare report database that linked the CIR, so the diagnosis of cancer, with the procedures that were done for toxicity. So it's the charges. Again, it's the surrogate for symptoms. I mean, it's not because you have LUTS that you will necessarily go to your urologist to get TURP. So here you just see the TURPs. You don't see the LUTS, okay? So that's the difference. But the red line that you see here on top is the line of the rates of procedures for toxicity, well, for procedures for patients who have received prostatectomy plus radiotherapy. The lower ones, I mean, surgery alone is the orange one, the second one. External beam plus brachy is the green one, so very close to surgery alone. So you can see here that the more you add treatment, the more you add toxicity. It's obvious, but it's important to keep this in mind. The other thing that's important is to look at the black line, and you see the black line is also going up. The black line is control patients. And also, some patients just aging have urologic problems. You all know that better than I do. And so all of this is not toxicity. Some part of it is toxicity, some part of it is aging. Okay, that is important to keep in mind. Maybe we will know in the future because SPCG, the Scandinavian group, has started a randomized trial, 1,200 patients, superiority trial, so aiming to demonstrate that using surgery upfront in locally advanced prostate cancer will lead to higher overall survival. So the endpoint, the primary endpoint is overall survival. It's patient lower than 70, T3, T4, operable T4, I'm not sure, but it says T3, T4, M0, N0, but using very flexible definition of N0, so you could still have lymph nodes provided you do a PLND. 600 patients are accrued so far, and we have applied for funding to open SPCG 15 in France with François Roset, a colleague from the Institut Montsouris. So we'll see if we get the funding at the end of the year. It could be our Christmas gift. But that's going to be a very important study that will definitely answer the question more than the databases. Okay, so now 3 questions about radiotherapy for those patients. So what is the optimal radiotherapy for locally advanced prostate cancer? So the 3 points that I want to discuss is ADT, again, use and duration, question mark. What type of technique of radiotherapy, and then very briefly, the open question. I will just mention a few ongoing randomized trials. So ADT, again, what has been shown, I told you ADT is absolutely mandatory in unfavorable intermediate risk prostate cancer patient, and it's the same for high risk prostate cancer patient when you give radiotherapy. And long-term ADT, 3 years, it's long, but it's been compared to short-term ADT. Here, 6 months in the New England Journal paper by, again, EORTC, Michel Bolla. And you see that, well, you have to trust me, but that long-term ADT improves overall survival and improves prostate cancer survival. The price to pay is, of course, longer side effects from ADT. I mean, if you get testosterone suppression for 3 years compared to 6 months, you will have longer hot flushes and impotency and stuff like that. But clearly, it improves survival. The colleagues from Australasia have done the same, compared 6 months and 18 months, and again showed a better cancer-specific survival, but as well as a better overall survival, lower distant rates of distant metastasis, lower local recurrences. So that's 6 months versus 18 months. And same problem with side effects. The Spanish group has compared 4 months with 28 months, so 2 more years. And they again have shown increased overall survival. What is important, why do I show you this one? It's because it's the only one that has used high dose of radiation. The other ones used 70 gray, and this one uses up to 82 gray. So clearly it's the modern radiation type. And you see that it improves survival, so long term, so it's all 2.5 years. It improves survival in the high risk and in the intermediate risk patients. So it's clearly important. So we need long-term hormonal therapy. Do we need 3 years? Maybe not exactly 3 years. Again, the patient from Michel Bola and the ORTC team were very advanced disease. Now it's the patient that we see with high-risk disease are less locally advanced. And here this trial by the Canadian group, Abdenour Nabid, reported 2 years ago, compared 18 months, which is already quite long, to 3 years. So it's a negative superiority trial, so it's not formally a non-inferiority trial, but you see that the curves are really overlapping. So many clinician radiation oncologists use this trial to say that maybe we don't need 3 years and maybe 1.5 years is enough, especially for those patients who are just like MRI T3, who are not like T3Bs or very high Gleason scores. So there is some flexibility here. So that's ADT. The duration, use and duration of ADT, yes, long term, possibly reduced to 18 months in selected patients. Okay? Now, what about the technique? And I'll briefly talk about brachy, and you understood that I love brachy and stereotactic radiotherapy. So just technical point, what needs to be done if you don't do brachy, if you don't do stereotactic is, as I said before, high dose, so more than 76 gray. In France, most people give 78 or 80 gray. Intensity modulated, image guided radiotherapy. So that's I would say the basis. And then the question is, if we give 3 years of ADT, does the dose still matter? And that's an important question. And the colleagues from the RADAR group that I've just presented to you from Australasia that have compared 6 months and 18 months of ADT, they have shown that there is a dose effect, as you can see here, if you give higher doses. So because in this trial it was a very pragmatic trial, you could give 66 gray, 70 gray, 74 gray, or you could give 46 gray plus a boost in brachytherapy. And here the red curve is the curve with brachy boost, where you see that you have less distant progression, that's top left, less local progression, that's top right, and better all-cause mortality. So clearly there's a dose effect that plays as well. So brachy could be the way to give the additional dose here. And do we have a randomized trial to demonstrate that? Yes, we do. There's one Canadian trial that has been reported already 4 years ago, and there's one French trial that unfortunately has not yet been reported, but that will be reported in the coming 1 or 2 years. And in this trial, we had patients with mostly high-risk disease. 70% had high-risk disease, NCCN, including 50% with 2 high-risk criteria, so like very high-risk patients. 30% were T3A or T3B. 20% had a PSA more than 20, Gleason 8-10 in 40% of the patients, so like real high intermediate and high risk patients. And what you see is that with the brachy boost, the biochemical control is much better than with external beam only. And the radiation oncology community has often been criticized because the urologists say that we don't use the same criteria for relapse. We use nadir +2 for relapse when you consider that a PSA above 0.2 means a relapse. And I agree with you that it's unfair. But that definition of nadir +2 was chosen because it predicts metastases. You don't just want to say that there's a relapse. You want to say that it's a relapse that's going to lead to clinical events for the patient. So in this trial, they also used the surgical definition of the patient, of relapse. And that's the panel to the right. And you see that if you give a brachy boost, at 10 years, 80% of the patients, high-risk patients, 80% of patients with high risk have not had a PSA that has gone above 0.2, compared to 30% of external beam patients. So clearly, giving a brachy boost improves PSA to levels that would be similar to the ones that you would achieve with surgery plus adjuvant treatments. Very important. The cost, unfortunately, is toxicity. So in this trial, they had what some people, non-brachytherapists in the radiation oncology community, consider unacceptable toxicity. So they had 18% of grade 3 urinary toxicity, meaning patients require a TURP, require catheterization, require treatment afterwards. Most of this toxicity then disappear with time, but still it's much more toxicity than you would get with external beam alone. And you see here, it's the rate of grade 3 toxicity when you have external beam alone and external beam plus brachy. Okay, so we can optimize brachy further, and we'll see the results of the French trial, but maybe it will show the similar kind of stuff. One other important and interesting stuff with external beam, with brachy, is that it has been looked at in terms of patients with very high Gleason score. And in this paper with close to 2,000 patients from multiple institutions in the US, they have compared patients receiving brachy, prostatectomy, and external beam alone. And what they have shown, and if we can look at the graph, it's going to be easier, is that the brachy group is the light blue one. And the patient receiving the brachy boost had a better overall survival, better prostate cancer specific survival, and lower rate of metastasis. When you compare patients receiving brachy to patients receiving external beam, that does not surprise me, because there are the same intrinsic bias between brachy and external beam that there were between surgery and external beam. Why? Because patients who require brachy, they need general anesthesia. So they need to be fit enough for the anesthesiologist to accept to do the GA. They will need to do a procedure. So clearly, we do the same kind of selection that you would do before surgery. But it doesn't explain the differences in metastases or in cancer-specific survival compared to the surgical patients. So that could be a bias. It's just a multi-institutional retrospective study, but clearly it emphasizes the power of brachytherapy as monotherapy for lower-risk patients and as a boost for those patients. So radiotherapy technique, I told you, high dose if you use an external beam only. And the role of brachy boost is quite clear in this population. Unfortunately, not very well used. And stereotactic radiotherapy has not been very well studied in patients at high risk. There are some series, but it's not been very well studied, especially because we believe that many of those patients require pelvic lymph node radiotherapy. So that's the first problem. And the second is that if you treat the prostate and the seminal vesicles, it's a big volume. And so many of us are afraid of the toxicity that you could have with the rectum or the bladder. Open question very briefly. I've listed them here. We don't know if pelvic nodal radiotherapy has any role. We know that those patients have a close to 35% risk of having occult pelvic disease, but we don't know if treating them well at the doses that we can do, close to 50 gray, provides any improvement to the patient. There have been randomized trials in the past, all negative. There are one US randomized trial has randomized 2,500 patients, and so we'll know in 10 years about this question. And we have one trial that I am running with Karim Fizazi, and that also investigates pelvic radiotherapy in patients with at least 2 out of 3 high-risk criteria of NCCN. So maybe we'll know. We have included 700 patients so far in this trial. This trial asks a secondary question about the use of chemotherapy in those very high-risk patients. Does neoadjuvant or adjuvant chemotherapy improve clinical outcome in the future? That could be, and again, the trial is still open for accrual. Second question, and that's probably easier than chemotherapy, and that will probably be more convincing, is the use of new generation hormonal therapy. That's the schema of the Atlas trial that studies the addition of apalutamide to standard chemoradiation in those patients. But there are also similar trials with enzalutamide or with darolutamide. So we'll clearly know in a few years if we can do double androgen blockade in these patients. We do not know yet, but I really believe that this will be the answer more than chemotherapy. So the take-home messages for locally advanced prostate cancer in radiotherapy is that I hope I have convinced you that there are no robust data supporting the superiority of surgery over radiotherapy. And there is one randomized trial, and what we should do is to help this randomized trial to accrue and answer this very important question. If the trial is positive, I will be very happy to send all those patients to the surgeon. If surgery is needed, remember multimodality is very likely, and that will increase toxicity. If it's important for the patient, we have to do it. But the patient has to be informed. I think patients should be informed and meet both with a urologist and a radiation oncologist prior to making their treatment decision. And that's probably the best way to avoid decision regret. They will be informed, and then they will make their own mind. They will have the time to ask the questions, and will see for themselves. And if radiotherapy is chosen, long-term ADT, at least 18 months, maybe more, high-dose radiotherapy and the role of brachytherapy, and follow the randomized trials for the open question regarding systemic treatment or pelvic radiotherapy. And I'm done. Thank you very much for your attention. If you have any questions.
Usually when you have a locally advanced prostate cancer, the patient have obstruction, urinary obstruction.
Mm-hmm.
So is it easier for you to do TURP before, or we keep it for after?
So I don't do TURP, but what I know it's a good question. What we don't want is patients to have urinary retention during radiotherapy. It's bad for the patient. They will need long-term catheterization before the urologist can do TURP. So if a patient has low urinary tract symptoms, potentially leading to retention during treatment, you should get TURP before radiotherapy, and wait at least 2 to 3 months before starting radiotherapy. So usually we do TURP and start the hormones at the same time, and we delay the start of radiotherapy. The good question in those patients is to really ask the surgeon again, can you do surgery, can you do prostatectomy for this patient? Because if they have low LUTS plus locally advanced disease, but they can be operated upon, maybe the best solution is to give them surgery up front. So that could be also a way for patients to choose their treatment. I mean, that's no, it's not easier for us to do TURP. It's just to prevent, in terms of dosimetry, for us it doesn't change. It's really for the patient symptoms. What can be done also in those patients is if you believe that the symptoms are not that severe, is to start hormonal treatment. And many of those patients, with the reduction of testosterone, the prostate will downsize, and some of the symptoms will go away. So that could be a way to test before, but it's always easier to do TURP before radiotherapy. And I'm not the surgeon, but I know we prefer to do it this way. So, favorable? No. Low risk and favorable, we don't. Unfavorable, we usually do. Awaiting for the PIS 2 randomized trial. It's not the same patient, but if it has no value in high risk patient, it probably has even less value in unfavorable intermediate risk patients. So, but currently we do. Our standard of care is to treat them. Just remember that there are countries and very important institutions that never treat lymph nodes with radiation. At MD Anderson, where I've spent 2 years, they never do prophylactic lymph node radiotherapy. They did not even enroll patients on the RTOG trial because they believed it was unnecessary to do it. So I mean, and they are not stupid people. So clearly, it's an open question, and we don't know the role of pelvic radiotherapy. But in France, most people would do it, I believe.
You think the ultra radiation or ultra radiotherapy will decrease the late complication of the radiotherapy for the rectum and the bladder?
The what?
The ultra radiotherapy.
What do you mean?
The radiotherapy, because we see a lot of complications, the late complication of the radiotherapy. So maybe the bladder and the rectum.
So
This is usually with the old generation. We see a lot of
there are two things. First, old generation, maybe also long follow-up. So maybe it's just too early to see the late side effects, the very late side effects for those patients, and can be very debilitating. When I talked with my urologist colleagues, I think we have not the same perception of those very late side effects for two reasons. First, because you take care of them, and thank you very much. And it's very difficult to take care of those patients with late cystitis, some of them requiring sometimes cystectomy. So that's, and those patients, they keep on your mind, and you because of those patients, you feel that radiotherapy is a provider of a lot of complication. What on our side, we see where we follow patients for 10 years, 15 years, we see very few of those patients are actually have those very severe long-term toxicity. So I believe it's very important, but it doesn't concern a lot of patients, and thankfully. And to me, the patients who have the most severe complications have always been, in terms of urinary complications, have always been patients who are post-op patients. And why is that? Because when we define the radiation fields for post-op patients, we treat basically where the prostate was. So we treat the prostatectomy bed. And what is in the prostatectomy bed now? The bladder, because you've pulled it. So we treat around the anastomosis being the most frequent site of relapse. So we willfully, I mean, voluntarily, consciently irradiate bladder when we treat post-op patients. And we know that treating bladder up to a large number of percent of the bladder up to 70 gray is not a good thing. So that's why we need to make sure that we don't treat too much, that we're careful when we select patients who need surgery, and depending if they will require post-op radiotherapy. The boost? So in the Paris area, just us, and it's been for 10 years like that, or even 12 years. In France, we have trained multiple centers, most of them in cancer centers, but I would say that there are probably at least 10 or 15 centers that do that. All of the mostly cancer centers, the CLCC, probably for reimbursement purposes as well, because the brachy is not reimbursed after external beam. You cannot reimburse, pay for 2 treatments for 1 patient. So a salvage. So that was not the question. Well, yes, you can. I mean, do you mean if the patient has had, for rectum, for example, for a rectal cancer? So we consider that we would treat them like salvage patients, depending on what was treated. If it's a lymphoma, usually it's just the lymph nodes and it's low doses and it's above the prostate, so that's not a problem. If it's the rectum, it's been clearly the prostate has been treated. We have performed probably 60 or 70 salvage brachy in patients like that, using high-dose rate brachytherapy with a very low toxicity, and so that clearly the treatment is well tolerated. Efficacy is not very good, probably because we're not able so far to select patients who have disease only in the prostate. Some of them also have lymph nodes, and even though they all had PET scans and stuff like that, we have about a 50% biochemical control at 2 years, which is a little bit disappointing. But with our technique and with what's been published, brachy either with seeds or with high-dose rate brachy leads to very acceptable rates of toxicity. So we do it routinely, I mean, for those patients.
Sorry. Do you think now the modern of the medicine now, of the robotic surgery, okay? As we know, the robotic surgery just very now it's very modern. Okay? There is less chance of erectile dysfunction, less chance of incontinence. Okay? After prostatectomy, that would affect the radiotherapy.
Well, I think the well, we see that the rate of patient receiving radiotherapy is decreasing, so there's clearly a difference there. I mean, so I'm not the surgeon, so I will not answer about side effects, but there was that big paper by the team from Memorial Sloan Kettering who have reported their rates of impotence and incontinence over the past 15 years, always using robots. And they have not shown any improvement in urinary control in their team using robots from 10 years ago or 15 years ago up to now. So I'm not sure we are making that many progresses, but that's going to be Professor de la Taille's discussion, and I clearly have not the expertise, but that's not my feeling from the patient. Clearly, surgery is easier, they go outside of the hospital faster, but in terms of impotence or incontinence, I'm not completely sure. I believe, my belief is that what matters is the surgeon and not the tool. And if you are a good surgeon, if you are a good laparoscopic surgeon or a good open surgeon, you will be better than a poor surgeon using a good robot. So that's what I believe. You need to find the right colleagues to send them the patients. And I clearly believe that collaboration between neurologists and us and medical oncology is key for patients. So, merci beaucoup.
So thank you, Pierre. So just before the coffee break, I'm going to destroy all the talk that you heard. I'm going to replace surgery at the right place. That means we have to do and we have to perform surgery for this locally advanced prostate cancer. So again, I start with a clinical case. It's a real case. Christian, who is 50 years old, he has no past history. In his family, his father died from prostate cancer at the age of 80. Okay, he asked his GP to perform a PSA in 3 years, so he started at the age of 47, but GP refused, following the national recommendation. No PSA screening before 50. At the age of 50, finally the GP accepted, and his PSA was 19. DRE, it's a T3 lesion, prostate biopsy, a Gleason 8 on 5 out of the 12 biopsies. The patient died 3 years after, despite all of what I did for him, unfortunately. So, which exam do you need for Christian? CT scan, bone scan, PET choline, or PET PSMA, CT and bone scan, or all, everything? I'm going to ask you. Which exam are you going to perform?
I'm PET choline.
PET choline?
Yeah.
Yes. Everybody is going to perform PET choline? No? PET PSMA from Lebanon? Because of course, in Lebanon, it's easier to have a PET PSMA compared to a PET choline. Can you imagine that? It's unbelievable, but it's true. Okay, so PET PSMA. Of course, there is an improvement in imaging, and we have now this PET PSMA with certainly the major imaging tool that we'll have to use in the future. It's a little bit difficult in France because the access is very limited for the moment to this technology, but it's going to come soon. And look at the specificity and sensitivity of the node-positive patient before surgery. You see when you have a positive source to the PSMA, you have a 66% of sensitivity and 100% of specificity compared to the choline with 50% sensitivity and specificity 92%. So clearly, in the near future, I hope we'll be able to perform a PET PSMA for all of our patients. So it was a couple of years ago, I was not able to have a PET PSMA. CT scan and bone scan were negative. What is for you the definition of a locally advanced prostate cancer? And I'm going to ask one of our young residents who just had this big exam. And then they had to learn, of course, prostate cancer. And of course, I'm sure you know what we call locally advanced prostate cancer.
It's a cancer that's in a high risk of D'Amico, but no metastasis.
Yes. No metastasis? Okay, in terms of clinical stage?
T1,
T2, T3?
T2C, T3.
T4?
Yes.
Yes. Can we include in this definition of locally advanced prostate cancer patients who have positive nodes in the pelvis?
Yes.
Yes, we can. Correct. So what we call locally advanced prostate cancer, based on the D'Amico classification, is patients with high risk and very high risk prostate cancer that include patients with T3, Gleason 8, 9, 10, PSA greater than 20, and also patients with T4 or N1 in the pelvis. So clearly, in the NICE or in NICE or EAU guideline, you see that locally advanced prostate cancer covers a spectrum of disease from a tumor that has spread through the capsule, T3, to large T4 cancer invading bladder or rectum or spread to the pelvic lymph nodes, so N1 disease. So what is the prognosis of this patient? Definitively, these patients are going to die from prostate cancer if we don't treat them correctly. And you see this is a group of patients with Gleason 8, 9, or 10. And looking at, for instance, patients who are less than 65 years old, you see that they are going to die in close to 80% of the case if we don't do anything. So we had a lot of possibilities: surgery, radiation therapy, deferred therapy, hormonal therapy. And the question is, what will be the best sequence of our patients? We had like a war. You are young, so you didn't have to see that, but we had really a war between radio-oncologists and surgeons for this group of patients for the first-line treatment. Do we have to go directly to radiation therapy? Do we have to go directly to surgery? And 10 years or 15 years ago, they won because they had a lot of prospective clinical trial looking at radiation therapy as a first-line treatment for this patient. And they conclude that hormonal therapy plus radiation therapy is a standard of care for locally advanced prostate cancer. But as he mentioned, there is no prospective randomized trial. They had prospective randomized trial looking at hormonal therapy plus radiation therapy versus radiation therapy, but we don't have prospective randomized trial comparing radiation therapy and surgery. So for this patient, he's young, he's healthy, he has a locally advanced prostate cancer. What will be your first-line treatment? Surgery, radiation therapy plus hormonal therapy alone, or everything, like a combo? Third? Third? Because you're a radio-oncologist? Tell us the truth. You are? Okay, so first choice, surgery, raise your hand. Okay. Radiation therapy alone, we know that it's not the correct approach. Radiation therapy plus hormonal therapy, 1, 2, 3, 4. Elliot, you cannot vote for both, okay? You have to decide. Just joking. Hormonal therapy alone, no, he's too young. Probably the correct answer is 5, okay? We'll see. So what do we have in the EAU guidelines concerning the treatment of this high-risk prostate cancer or very high-risk prostate cancer? You see that still surgery is here. And we will have to look at in detail to the recommendation. But we have radical prostatectomy and we have radiation therapy. So surgery. What do we have in the literature? We have a lot of paper looking at the T3 surgery, T3 disease treated by surgery. It's in most of the case and most of the study, it's a retrospective and monocentric study, unfortunately. And we don't have prospective randomized trial comparing surgery and radiation therapy plus hormonal therapy. When we go for surgery for this group of patients, there is two important things and two positive things to know. First, despite this locally advanced prostate cancer, you see that on the final pathology, around 1/3 of our patients will still have a T2 disease, so with a good prognosis. And probably this group of patients is going to be cured by the surgery. The second point, that the rate of positive margin is, I would call, a little bit high, between 30 and 60% of the case. And this we have to keep in mind when we are going to do the surgery, because we want to have the lowest rate of positive margin, especially in this group, and especially if we want to go for surgery. Because of course, when you will be at the tumor board the week after, radio-oncologists will love, haha, you perform a surgery, you have a lot of positive margin, you imagine the scenario, and everybody will say, oh, yes, of course, we have to send the patient to radio-oncology now, and we should do it before. What is the survival? Well, there is this very long-term evaluation of the clinical T3 coming from the Mayo Clinic. And you see that after surgery, the cancer-specific survival or the PSA progression-free survival at 15 years is not so bad, 79%, 67%. But it's true that 73% of the patients receive an adjuvant therapy with hormone or radiation or both, with a delay of 4 years. They had salvage in 73% of the case. Yeah. But 1 + 1 is better than 1 alone. You don't think so? That's true that I don't have prospective randomized trial to tell you that. But clearly in our daily practice, this is what we perform. This is an important point concerning the surgical technique. Of course, we have to perform an extended lymph node dissection. We have to do an enlarged radical prostatectomy. Usually, we don't have to preserve the nerves. And this is the prostate that you have in your hand at the end of this surgery. You see that you have the prostate, you have the neurovascular bundle, and you have fat around your prostate. So clearly, it's a very enlarged radical prostatectomy. So concerning the extended lymph node dissection, there is a lot of discussion concerning this point. Is really good for a patient. It's going to save some life. We know that, of course, when you do an extended lymph node dissection, you are going to reduce the risk of prostate cancer-specific mortality by 23% in patients who have a positive lymph node, and by 15% in patients who don't have a positive lymph node on pathological report. So what do we call an extended lymph node dissection? It's lymph node removal from these 3 areas: external iliac and obturator area, internal iliac area, presacral and pararectal area, common iliac area, pre-aorta or caval area. So usually you go to the bifurcation of the aorta. So it takes time, between 1 hour and 1 hour and 30 minutes. But this is part of the job, and we have to do it. So what EAU guideline tells us concerning surgery in high-risk prostate cancer group? Surgery is a reasonable option in selected patients with T3 less than 8, 9, 10, or PSA greater than 20. And you see also that it can be also an option in patients with clinical T3b, T4, and N1 in a context of multimodality approach. If you do surgery, you have to perform an extended lymph node dissection because the estimated risk of positive lymph nodes is between 15 and 40% of the case. What about neoadjuvant hormonal therapy before surgery? It's not recommended. We had a lot of paper concerning this point. We know that when you give hormone before surgery, you reduce the risk of positive margin. You reduce the tumor volume, but there is no impact in terms of PSA progression-free survival for now. Because you have to know that there is a prospective randomized trial looking at neoadjuvant hormonal therapy with LHRH agonist plus apalutamide versus LHRH agonist alone. And this is a neoadjuvant and also adjuvant treatment because after surgery, we continue the therapy for 6 months. This is a Proteus trial. And of course, it's Jensen & Jensen who launched, it's Jensen who have this protocol. And we'll have an answer in 2 or 3 years. Second point, concerning the nerve sparing surgery, usually we don't do it But for patients who have potency, who want to preserve, we have to discuss the fact that we can preserve the nerve, especially if on the MRI there is a large extension of the tumor on one side. But usually we don't go for nerve-sparing surgery. So Christian, well, he listened to Pierre on a web conference, and he has a question concerning the radiation therapy. Does radiation therapy will be associated with hormonal therapy, and what is the duration on it? And what is the dose of radiation therapy? So you know the answer because you listened to Pierre. You know that, of course, we have to associate hormonal therapy and radiation therapy. Duration, 3 years, can be 18 months in a selected case. What is the dose of radiation therapy? The highest, 74 at least, 76, in some cases 82. We saw that. So I will be a little bit faster concerning this radiotherapy part of the talk. So this is the result of the high-dose radiation therapy. We know that it's important to control the disease. You have to know also that you are going to induce and to increase the toxicity of the radiation therapy. Usually it's 74 gray in 37 fraction, and this is the standard, and this is what we have to recommend. Concerning the hormone therapy, you have to listen to the name of the radio-oncologist who did a lot of prospective randomized trial on this field. Is Bola. He's a French radio-oncologist in Lyon. He's now retired, but he launched a lot of prospective randomized trial on radiation therapy and hormonal therapy. This is the first one. Radiation therapy plus hormonal therapy versus radiation therapy alone. The duration of androgen depression was 3 years. And clearly, you see in terms of overall survival, this is the most important criteria, most important endpoint. In terms of overall survival, you see that at 10 years, we say, the difference is 17 points. So 62% versus 79%. Can we reduce the duration of hormonal therapy? Because 3 years, it's a lot. We are going to induce a lot of side effects. So there is, again, a prospective hormonal trial. We're looking at this possibility. But clearly, again, 3 years was better than 6 months. So there is another and a third prospective hormonal trial comparing 18 and 36 months. And you see that the RS ratio is very close, 1.1. So clearly, the benefit between 18 and 36 months is not very important. High-dose brachytherapy. I believe that Pierre insists on this point, at least in his institution. It combines both, and clearly there is an advantage compared to external beam radiation alone. Let's think about a patient who are not fit enough to go for surgery. Do we have to go directly to hormonal therapy, or can we wait before giving hormone therapy? There is, again, this study from Studer, published in GCO. They include patients who had T3 lesions and who were candidate to hormonal therapy. In the first group, they started immediately the hormonal therapy. In the second group, they defer the treatment. That means they start the treatment when patient had symptoms. When you look at the endpoint at 8 years, you see that the risk of dying from prostate cancer was the same in the two groups, 18%, 20%. So we are going to tell me, well, if I look at this data, I don't need to start immediately the hormonal therapy. I'm going to save and to preserve his quality of life because no side effect due to hormonal therapy. And I will see in the future if he really need to have hormonal therapy. But they make some subgroup analysis, and he found that if the PSA at baseline was greater than 50, and if the PSA doubling line is less than 12 months, there is clearly an advantage for starting immediately hormonal therapy. So keep in mind, PSA greater than 50, PSA doubling line less than 12 months, you have to start hormonal therapy, and this is a level 1 of evidence, and it's in the recommendation. So finally, Christian, he had surgery. You did not preserve the nerve. You are very happy with the R0, but he has a PT3B lesion with a N1 disease, Gleason 8. When you look at the pathology report, you saw that it's only one positive node out of 21 nodes that you removed. This is usually what you have when you do an extended lymph node dissection. You have between 15 to 25 lymph nodes. And at 6 weeks, you have a PSA of 0.1 nanogram per milliliter. So I ask you 3 questions. Does he need radiation therapy? Does he need radiation therapy and hormonal therapy? Does he need only hormonal therapy? Who wants to answer? The third one? The second one. Radiation and hormonal therapy. Okay? But he has an N1 disease. Does he need just hormonal therapy? You wait? Okay. Yeah. Yeah. And hormonal therapy. Are you happy with a PSA of 0.1? High risk. Are you happy with this level of PSA, 0.1? Yeah. Yeah, stabilization. Yeah. Not sure it can decrease, but 0.1 is you're happy, but you are not very confident for the future. You know that this patient is going to have a recurrence. Huh? After surgery, 6 weeks, 0.1, it's a little bit too high. So what do we have in the literature with surgery and radiation therapy? Again, there is a lot of paper, prospective randomized trial, because radio-oncologists, they love prospective randomized trial. So again, BOLA, Lancet paper journal. This study from the ORTC, they include patients with PT2, PT3 disease, and they randomize between 2 groups, radiation therapy versus wait and see. So that means we follow the PSA, and when the PSA increases, we do radiation therapy. So it's adjuvant radiation therapy versus salvage radiation therapy. And you see that in terms of biochemical progression-free survival, there is an advantage for patients who receive radiation therapy. In terms of clinical progression-free survival, again, there is an advantage. But in terms of overall survival, no advantage. So in the literature, we have these 3 major studies looking at the place of radiation therapy for pathologically advanced prostate cancer after surgery. There is SWOG, this is the ORTC that I just presented, and this is the ARROW study, a German study. In the SWOG, they found an improvement in terms of PSA control, metastatic-free survival, and overall survival. So we say, wow, this is very important. We have to give all of them radiation therapy. In the ORTC, improvement of PSA control, local failure, no difference in terms of overall survival, metastatic-free survival, or clinical progression-free survival. The ARROW study, improvement in terms of PSA, and there is not enough events to assess the impact on overall survival. So one tell you yes, the other one tell you no. So what do we have in the guidelines concerning this adjuvant radiation therapy? It has to be discussed with the patient as an option, because it can improve at least biochemical free survival. For patients with PT3 and 0M0 with undetectable PSA, we inform him about salvage radiation as an alternative to adjuvant external beam radiation when the PSA increases. Okay, so possibility to just wait and see. But our patient has an N1 disease. Does he need hormonal therapy? Well, if you look at, again, this important paper, Missing trial, I tell that for the young urologists that we have in the room, Missing he is still a urologist in US. And he compared 2 attitudes after surgery for patients who have N1 disease, immediate versus deferred hormonal therapy. And he prospectively includes the patient, and you see just after 3 years, there is a clear advantage for patients who receive immediate androgen deprivation. So when you look at the guideline, you see that for patients who have N+ disease, immediate androgen deprivation, prolonged progression-free survival, and even overall survival. But for this patient, you have an extended lymph node dissection. And in these few cases of patients who have only 1 or 2 positive lymph nodes with a microscopic involvement and a PSA less than 0.1 nanogram per milliliter, 6 weeks after surgery, we can go for the expedient management. So that means we just follow the PSA and see what happens. Okay? So this small difference for the N1 disease for patients who have an extended lymph node dissection and for who had only 2 positive nodes, we can just follow them. So conclusion concerning this locally advanced prostate cancer, definitively, especially for young patients, it's a multimodal approach. If you go for surgery, we have to go for extended lymph node dissection, and we have to discuss adjuvant radiation therapy and androgen deprivation. For patients who are going for radiation therapy or for high dose, standard of care usually 3 years of androgen deprivation, in some cases 18 months. And if the patient is unfit for local therapy, androgen deprivation for patients who have a PSA greater than 50 and a PSA doubling time of less than 12 months. Okay? Any question concerning this part? Say in French. Right? Lymph nodes. Positive lymph nodes? Yeah. Yes. No. The prostate? Yeah, disease. We're going to ask Pierre when he will be back. Okay, we're going to ask this discussion. Just after the coffee break, so I suggest we're going to make a coffee break for 30 minutes. We will be back in this room in 4:35, and we'll continue, okay? And we'll start with your question. Thank you. But are you going to do high-dose radiation therapy on the lymph nodes, on the positive lymph nodes, or only on the prostate? Yeah, yes, for the case of a guy who is 50 years old, Gleason 8.
So there are 2 different patients. The patients who we treat the lymph node prophylactically. Okay, if the lymph node, there are no positive lymph nodes, then, I'm sorry, I was not there. But if there is no positive lymph node, then we give an intermediate dose to the lymph nodes, usually around 50 gray, and then we give 80 or the boost in brachy or whatever to the prostate, and we give also an intermediate dose to the seminal vesicles that would be removed with surgery. We treat them with intermediate dose. If the seminal vesicles are involved, then we would give full dose to the seminal vesicles. If there is a lymph node, a macroscopic lymph node, then we would give a full dose to the lymph node, not 80 gray because it's difficult due to the proximity of the bowel. 70, you can do 70. You can do, but the big question that we have now is that we see more and more patients with lymph node metastasis that are detected on PET scan. And on PET CT, it's very small lymph nodes that are 5 millimeters, less than a centimeter. It's not the same thing if you have a 2 centimeter lymph node or if you have a 5 millimeter lymph node. And for a 5 millimeter lymph node, probably lower doses are enough. So probably treating, like what we usually do is give 66 gray in 30 fraction to the lymph node. And usually, but we have no idea whether the boost to the lymph node is useful or not. If you follow the literature, evidence-based patati patata, you should give ADT alone to those patients, no local treatment. The only randomized trial, Messing, years ago. So what we all do now is that we treat these patients with radical intent, and some of them are very, very long-term survivor. If you not giving a full dose to the lymph node is problematic to us. And what we always do is we treat in patients with positive lymph node, we always treat prophylactically the lymph node levels in the pelvis and not only the macroscopic lymph node. Clear? Okay.
Okay, so we are going to show to Pierre that urologists are able to do prospective randomized trial. I'm going to show you that, Pierre, because we know that radio-oncologists and oncology are the winner when you look at this competition, but you will see that also for surgery we are able to do prospective randomized trial. So we are going to look at surgery for prostate cancer and try to compare. Sure.
If you have a randomized trial, do you follow the results of the randomized trial?
Always. Well, there is bias. You explained to us. So we have to deal with the bias. Okay, so comparison of the different technique and the different approach for treating the prostate. We know that there is the open approach, laparoscopic approach, and robotic approach for removing the prostate. Is there any difference between these three approaches? And what do we have in the literature? So to compare these approaches, we have in the literature 4 levels of comparison. The first one is meta-analysis. So a compilation of all articles concerning this approach. Database, this is interesting because this is a real life practice. This is what we do, all of us, in the daily practice. And this data come from the national database, usually from the health insurance. We have comparison in a single institution, and we have also prospective randomized trial. So first slide, meta-analysis. So compilation of all paper, looking and to try to compare the different approach, open, laparoscopic, and robotic approach. What we can see? We can see that in terms of blood loss, there is an advantage for laparoscopic approach and robotic approach. Of course, transfusion rate drop from 20% to 1% when you use a robotic approach. Positive margin, the same. Continence rate, there is a trend in favor of robotic approach. For having a better continence after surgery. You see that for open approach it's 79%, 84% for lap, and 92% for robot. Erection, again, the same trend, 50% for open, 50% for lap, between 60 and 90% for the robot. So this is what we have in meta-analysis. Second analysis, of course we don't have a lot of criteria for comparing the 3 approach because it's coming from US database, from health institutions. We can have some interesting thing. Again, we found the same thing concerning the blood loss. You lost less blood when we were operated with the robot compared to the open approach. Transfusion rate, you see that again, same trend. Deaths after surgery. Reintervention, a little bit lower with the robot. Lymphocyte and stenosis, again, in favor of the robotic approach when you see at the percentage, less than 1% compared to 2 to 3% for the open approach. So when you look at meta-analysis, when you use a US database, you have a trend, at least, in favor of the robotic approach. What do we have in terms of prospective randomized trial? First one is was Porpiglia. Porpiglia is urologist in Italy. Who come from Italy? Yeah, you know this guy? Yes, very famous guy in Italy. He had a huge experience in laparoscopic approach, and then he bought a robot, and he started immediately a prospective randomized trial, comparing a laparoscopic approach and the robotic approach. And what he found, in terms of operative time, it was the same thing, 147 minutes versus 138 minutes. Blood loss was the same. Positive margin, it was the same. He also follows the patient, and what he found, that in terms of continence rate, so it's coming from the same surgeon with 2 approach, you have a higher risk, higher chance to recover continence after surgery. When you were operated with the robot, you see that at 12 months, the continence rate is close to 95% compared to 82% for patients who have a lap approach. So, again, an advantage for the robot. He looked also at erection after surgery, and he found the same thing. Advantage for patients who have a robotic approach compared to a laparoscopic approach, 80% at 12 months for patients who have erection with or without PDE5 inhibitors, compared to 55% for patients who have a laparoscopic approach. Another prospective randomized trial, published in Lancet 4 years ago, and they compare open approach and robotic approach. So in this study, it was not the same surgeon who performed both surgery. For the open surgeon, it was a surgeon with 15 years of experience. He did more than 1,500 procedures before the trial, and he compared in this study the robotic approach performed by a young surgeon, 2 years of experience, 200 procedures before the trial. And they look again at the same data: surgery, duration, recovery, blood loss, and continence rate and erection rate. And what he found is this is what we know. Again, in terms of blood loss, there is higher loss of blood on the open approach compared to a robotic approach. So 1.3 liter compared to 0.4 liter. In terms of intraoperative adverse events, 8% versus 2%, and it was statistically significant. In terms of operating room duration, it was almost close. So it was 280 minutes versus 240 minutes. So you save a little bit time with a robot. In terms of functional outcome, I'm not going to go through the detail, but there was no difference. So Pierre is going to tell me, yeah, you see, there is no difference. The robot is not improving the outcome of the patient. Yes, but we did not compare exactly the same thing. We compare a very experienced surgeon with this technique or a young surgeon with a robot. So that means, for me, the main conclusion for me of this publication is that the surgeon, the robot helps the surgeon to have a better experience, to perform a better surgery when he has a robot. So clearly, this surgery depends on the surgeon and also on the materials that we use. Third prospective randomized trial that was published a few months ago from Schlossenburg. It was a multi-center study. 700 patients, and they look at continence at 3 months, comparing laparoscopic approach and robotic approach. Again, it was not one surgeon. It's a lot of surgeons from Germany in different centers. And again, he found that when you use a robot, you had a higher chance to recover normal urinary function at 3 months compared to a laparoscopic approach.
As mentioned.
So, yes, it was for EAU, this slide, so I have to record my voice. So what do we have in the literature and in the recommendation? For now, the conclusion of the EU recommendation says that clearly there is no clear advantage for robotic approach, laparoscopic approach, or open approach. But with the 3 prospective randomized trials that I just mentioned, for sure it's going to change. They have to recognize that for the robotic approach, we have a higher chance to recover continence, erection, for the same cancer control. This is important too. And what Pierre said is totally true. It depends on the surgeon. It depends for the surgeon for the functional outcome. It depends on the surgeon also for the cancer control. And again, you have this nice publication who look at the biochemical recurrence-free survival at 5 years, comparing a surgeon who performed just 50 surgery to surgeons who perform more than 1,000 surgery. And you see that for the same group of patients, the biochemical recurrence-free survival is much better when you have an experienced surgeon. So in conclusion, and this is what I say in my office every day to the patient, it's not the robot who is going to do the surgery, it's a surgeon. And the most important is to have a surgeon who performs frequently this surgery. So for young urologists who are in this room, you will have to decide in your future what you will have to do. I mean, the general urologist will disappear. You will focus on 1 or 2 topics: functional urology, stone disease, oncology, and then you are going to do that in your entire life, and you will have less complication, better control of the disease, and better functional outcome. And of course, if you have a robot, you see that you will be a little bit better and you will, of course, help your patient to recover normal continence and normal erection after surgery. Okay? Do you have any question concerning this point? Yes.
I have one. So I completely agree with you. My question is, given what you said, how did you change your the training you give to residents to help them get this level of confidence and expertise? Because I feel that sometimes what we would call assistant professor in France, sometimes they're not. It's very difficult to become a good surgeon. So I clearly I know that's a very difficult job, and so how can you help them get that expertise without kind of making their progress on the first patient they treat?
So we are very lucky in France because I believe this is the best surgical school. We start to treat the patient, to see the patient very early in the program. And we start to see patients when we are medical students. And this is not the same thing in the other country. We start to perform surgery when we start our first year of residency. So clearly, in France, there is this advantage to be close to the patient and to start very early the surgery. Concerning the robotic approach, I have to tell you that 15 years ago when I started the program, well, I have the robot in one room and so my boss say, okay, you have the robot, you have to do surgery, help yourself, okay? So I started by myself. I didn't have video, I don't have a tutor, I don't have proctoring, I didn't have anybody. So I start, we'd say, directly on the patient, and this is not in 2020 acceptable. We are lucky because we have a lot of video or how to learn this surgery. We have, of course, some courses on pig, on cadaver. It can help. We have also simulator, and this is for me the future. This is really simulator with a very nice vision. This is exactly what we are going to do on patient for instance, for doing a suture, for dissecting the bladder neck, and so on. So there is this program, and I think it's really going to replace cadaver and pig experience. And we have also the chance to have compagnonnage, we said in France, so proctoring, so that means experienced surgeon come to the place where a young surgeon want to start, and so it's better for the surgeon, it's also, of course, better for the patients. Yeah. And in a daily practice, in our institution, we force the resident to start on the simulators, and then they have also some exercise to do outside the patient, and then they start, because we have a dual console, so it's like auto-école, it's very easy to switch from one console to the other, so we give him the scissors, and we can take the scissor again, and I'm sorry? No, it's fine, leave like this. So with the dual console, it's very easy to teach, to control the resident. Yeah. Okay? So we are done on this part. We will finish with some clinical case. So again, we'll have some interaction with you about the local treatment in patient with metastatic disease. This is what we call oligomet patient. Do we have to treat the prostate? Do we have to treat the entire disease? So that means to irradiate the prostate, to irradiate the met that we see on the different imaging tools that we have. And Pierre will discuss that with you. We know that, again, it's a new topic because a few years ago it was not possible, or we're not allowed to treat the prostate in a situation of oligomet, or of course in metastatic disease. But we have now some argument to say that we have to treat the prostate in metastatic disease, and it's in the recommendation now for patients who have oligometastasis to treat the prostate. And Pierre is going to discuss that.
Merci. Can we start? Yes. So a few cases. So on oligometastatic patients. So the first one, born in 1938, so he had brachy at an outside institution in 2003, so he was 65 for low-risk prostate cancer, and he had a nadir of 0.4, which is not great for brachy. 4 years after the procedure, and he recurred 4 years again after that, so it was 2011 with a PSA of 2.15. So we are in 2011 now, and so first one question, do you know how we define recurrence after radiotherapy? We've discussed a little bit the topic, and I'm not asking radiation oncologists, I'm asking surgeons. So in theory, he has a PSA of 2.15. He has not recurred. Okay, theory. But he had a PSA that was slowly rising, and in 2011, he had a PET scan. I'm sorry, we don't have the image fusion. So he had a negative PET, CT and bone scan, and then a Colline PET CT. In 2011, and there was a single nodal hyperfixation, and on the MRI we see very clearly the node. You see the node here very clearly. Okay, and there was nothing outside of this. So we are 8 years after treatment, and he has a PSA that rises very slowly, with a doubling time around 18 months. Okay, so you see So at that time, the question was, what should we give as treatment? So he has a metastatic nodal relapse. So what should we do? ADT, surgery, ADT plus chemo, plus ABI, ENZA, or radiation. So what would you do, surgeons? 8 years after, with a low PSA, no hormones, low PSA, with a doubling time of 18 months. So, and now it's 2011, so he's 73 or something like that. Okay, so but very good, very good general condition. Hormones.
Raise your hand for androgen deprivation at all. Okay, lymph node dissection.
You're very shy, okay? Plus chemo. No, ADT plus ABI or ENZA or fancy stuff. Okay? And radiation. Okay, so many of you would not just treat the patient. You would come to your office and say, oh no, I'm not interested in your case. Go back, see Professor de la Taille because he's a very good guy. So, it could be just wait and see. So that's so who would just do wait and see and do nothing? Very healthy, good performance status. Actually I think it's a very good comment, because potentially this patient has a doubling time of 18 months, so his PSA will be below 10 for years. So maybe he would not require anything, but he's 73, very good physical condition, so he has probably 20 more years to live. So we wanted to do something. So some form of local treatment. Yeah? Okay.
You want me to discuss the lymph node dissection?
Sure.
Yes, we are very enthusiastic with this approach a couple of years ago to perform an lymph node dissection. To perform an excellent lymph node dissection, especially in this case, we have one positive node. It was on Colline PET CT. We and others perform a lot of this procedure. It's not so difficult because we are outside the irradiation area. But it's a little bit disappointed. When we look at the data, 2/3 of the patients after surgery have an undetectable PSA. That means we remove everything. In 1/3 of the case, that means we leave somewhere in the body some prostate cancer cell, despite this nice imaging that we have. Second point, when we follow this 2/3 of patients who have a negative PSA after surgery, they re-increase their PSA in more than half of the case. So we can, with this procedure, with this lymph node dissection, salvage lymph node dissection, at least defer the use of other medication, hormonal therapy, chemotherapy, and so on. This is the best case. Or we can cure some of them, but very few. Probably because the imaging is better than before, but not excellent.
And it's very important, I think, to remember that by surgery or by radiation alone, many of those patients will not be cured. So the patient had, at that point, we were beginning stereotactic radiotherapy, and we were enthusiastic by the fact that this patient had a very slow recurrence. So we were quite confident that maybe the disease was just there. And we've done something that we don't really do anymore. So he had just radiotherapy just to the lymph node. And we don't do it anymore because, as Professor Delatay told you, many of those patients relapse. And we know that when we see one lymph node, there are microscopic cells in the chain. So now, if we had to treat that patient again, we would definitely treat the whole pelvis with more dose to the positive lymph node. And not everyone would do, but I would add ADT as well to potentialize the radiation. So, but he was treated only to the lymph node, and his PSA went down to less than 0.2, and it's been 8 years or something like that. So, but it clearly, I think it's a case just to discuss. Probably it's a special biology, and I don't want you to remember that you have only to treat the gross disease. You need also to treat the potential microscopic disease by ADT and or an extended lymph node dissection or multimodality treatment, radiation plus hormone. So just to start, what's the definition of an oligometastatic disease? So it's there's a belief that there's a continuum between localized disease and widespread systemic disease. And you start by having some metastasis, and that in some patients, that oligometastatic state will last for a long time. So what do we know now? We'll see with another case. So that's a gentleman who was born in 1950, and he had in 2012 high dose 80 gray radiation plus 3 years of hormonal therapy for a high risk prostate cancer, T3B, clinical T3B, Gleason 8, PSA 16, quite a bad tumor. And he recurred in 2016, so 1 year after the end of hormonal therapy, so that's quite quick. He had one injection of goserelin, but just one for 3 months, and then he decided he wanted to stop with a good PSA response. And then 1 year later, again, the PSA was at 1.26 in December, and 3 months later, 13.4. So he went from 1 to 13, so 10 times more PSA. 10 months later. So he had a PSMA PET-CT, 2 years, that was 2 years ago, a little more than that. And they found a single bone hyperfixation that you can see here in the right ischion. So you don't see very much the hyperfixation, but you also see the density of the bone. And so we agree that it's a completely different, although it's just one metastasis, so it's a completely different presentation than the patient before, okay? So would we do anything more in terms of diagnostic procedure? Would you add something? Would you, or is it enough to have the PET-CT and the PSA in this patient? Would someone add anything? No is an answer. I mean, you can say no, okay? So you would not add much, and how would you treat the guy? So would you do, who would do ADT alone? So we start again on hormonal treatment because he's metastatic. Nobody? Hormones? Nobody. Radiation? Okay. To the bone? To the bone lesion. So he's asymptomatic. No, it's just pure imaging finding. Okay, so radiation. ADT plus something else. Now that's something that could be discussed, right? Some form of IR, cryo, or whatever you want. Chemo. Or surgery. Chemo, okay. Or surgery. Probably not. Okay, nobody would do surgery. So we discussed with the patient, and of course I'm a radiation oncologist, and so that I'm very biased, and I present cases that I've treated, and he asked for he asked for it, although we clearly from the very start told him that maybe the treatment was not going to do anything. So he had stereotactic radiotherapy on the ischion, and as you can see, we are able to provide very high doses on a very focused region, and it's important to see that here is the rectum. We didn't want to re-irradiate the rectum in a patient that had received radiotherapy previously, so you can see that's the line of 10 gray, and the rectum receives like less than 5, maybe 3 grays. So that's very like negligible, and all the high dose is within the ischion. So he had a good quality treatment. Only the bone met received a significant dose, and he had also ADT at the same time, because we told him radiation alone is not an option for you. You have a biological profile that clearly needs some form of systemic treatment. So the PSA declined very quickly after that, and then increased 12 months after the end of ADT. So basically, he responded to ADT, but probably did not respond to the radiotherapy that we've performed. What pushes us also to do this form of radiation is that it's almost asymptomatic in those patients. We can do that treatment, and that has no side effects, especially in bones like that. I wouldn't say the same for all the bones, but here he had absolutely no side effect, and he was put then on continuous ADT. So what I want to emphasize here is that we, when considering oligometastatic patients, we need to consider the way you diagnose the oligometastatic disease. So initially it was a CT scan and or PET CT and bone scan, and then it became choline PET CT, whether 18F or 11C choline, and then PSMA. And we see that with PSMA you have more positivity than with PET choline, meaning that you detect more lesions with PSMA than with PET choline, and even more than with CT and bone scan. So what we need to be aware of is that one patient that could be stage oligometastatic with PET choline could be stage diffusely metastatic with PSMA PET CT, and could also be staged M0 with CT and bone scan. And so it's important when looking at papers to really look at how they have diagnosed, made the diagnosis of oligometastatic disease. And that with these advanced imaging, the incidence of oligometastatic disease will likely increase, and we will see what's called a stage migration. So if you just 2 minutes on stage migration, probably you know all. Who doesn't know Will Rogers? Who knows Will Rogers? Well, okay, so nobody. Okay, so 2 minutes. So what we call the Will Rogers phenomenon is a statistical paradox, and Will Rogers was a comedian in the US back during the crisis in the 1929 in the 30s in the US, and when there was the gold rush and everybody were rushing to California to look for gold. He said when the Okies, so the people from Oklahoma, left Oklahoma and moved to California, they raised the average intelligence level in both states. Okay? What does it mean? It means that if you have the most stupid person from Oklahoma that go to another state, but there they find themselves as the most intelligent people, you will lose the worst one in one state, and they will become the best in the other one. So the mean of IQ, QI, will increase in both states, although overall it's the same population. Okay, so that's the meaning of that's where it all comes from. Will Rogers, and it's been looked at very elegantly in prostate cancer. You know that the way we stage the pathology stage the Gleason score has changed, and so. The team from Albertsen and colleague, they've restaged prostate biopsy, or I think it's biopsy. I'm not sure if it's biopsy or prostatectomy specimen, but they restaged using the contemporary criteria. And you see here in light gray the previous Gleason score and what it then became with the new staging, okay? And so you see a big change in distribution, but meaning that the patient that were stage Gleason 2, 3, 4, 5, all became 6, and so there's a shift of the population because it's the same patients, okay? Same patients. And so then they have presented the survival curves. And so you see here the survival curves in each Gleason group. So that's the Gleason sum 8, Gleason sum 9, Gleason sum 10. And that's the old staging and the new staging. And you see that in all of these categories, the new patients, they do better than the previous one. And what you see in the end is the adjusted survival curve. So it's the same population, the same 1,000 patients, but it's an survival curve that is adjusted based on the Gleason sum. And you see that there's a survival advantage for the contemporary Gleason compared to the previous one, although it's the same population. So it's a complete artifact of a statistical artifact. If they had not adjusted based on Gleason score, you would have exactly two superimposed curves, okay? So that's a clear example of Will Rogers. It's what we call stage migration. And in prostate cancer, we have the same with MRI, for example. I told you earlier that the studies from Michel Bolla were what he said digital T3s, so like big T3s, and what we now call T3s are small T3s that could be T1C on DRE. The PSA screening also has brought us patients that are less advanced. And the PET scan, the use of PET-CT, will do the same for metastatic patients. So we have to keep that in mind. We are not getting better. We are not treating the same patients. So the standard of care for this patient would have been lifelong hormonal therapy, maybe intensified therapy because he's metastatic, so he could receive, and he's hormone sensitive, so he could have received chemotherapy, he could have received abiraterone, now enzalutamide. And the question is, in those patients, is there a role for the local treatment of the primary? Not in this guy because he had he had been already treated in the prostate. And if we look at the benefit of local treatment in metastatic prostate cancer, that's a systematic review that we had done years ago, and that was submitted but actually never published. There were lots of database studies, and all of them had those biases. So all of them showed that treating the primary led to better outcome for the patients. But what we know, same as we've discussed earlier, is that the patient to whom we discussed to offer surgery or radiotherapy, if he's metastatic, it's the best patient. He has just one metastasis, he's in very good physical condition, and so on and so forth. And so all those studies could not help really guide treatment decision. And there were randomized trials. There one big randomized trial in France called PIS1, who has completed accrual almost 2 years ago, and so results will be known quite soon. But there were randomized trials ongoing at that time. And a few were presented. The HORAD trial was presented at the AUA 2 years ago and then was published last year or in European Urology. And in the HORAD trial, so it's from the Netherlands, patients were with de novo metastatic disease were randomized between ADT alone or ADT plus radiotherapy. And you see here the overall survival curves completely superimposed. What they have done in the HORAD trial, that they had pre-specified to do an analysis based on the tumor burden. So you had low metastatic burden or high metastatic burden based on the charted definition. We are not going to go into the details, but they had patients with lots of mets and few mets. And in the patients who had a few metastases, the hazard ratio was 0.68. It's not written here, it's in the paper, 0.68, and was not significant because it was only 400 patients here, so probably 200 in the subgroup. But the trial was the first one to be reported and was considered negative. And then a few months later, the Stampede team, you all know Stampede, but you will hear a lot about Stampede tomorrow morning. Stampede is an absolutely fabulous clinical trial adventure that's ongoing in the UK. And they have done the same, but Stampede-wise. So the same, but with 2,000 patients and not 400. And so here you have the overall survival. No difference between the two groups with ADT alone or ADT plus radiotherapy. And here is the failure-free survival. Failure-free survival also includes a PSA failure. So as Alexandre told you, if you treat those patients, you will decrease PSA, but maybe you will not lead to an improved survival here. But they had pre-specified, knowing the HORAD results, they had pre-specified before the analysis that they would also analyze the patients according to tumor volume. And so they have reported in the Lancet the patients with low metastatic burden and high metastatic burden. And as you see here in patients with lots of mets, no benefits in the treatment of the primary, but you see here in the upper left corner, in low metastatic patients, you have a benefit of the local treatment, local radiotherapy to the disease with hazard ratio of 0.68. So it's exactly the same as in HORAD. The difference being that here you have 800 patients, and so it's significant. So since the presentation of this trial, we consider that it is a standard of care to do radiotherapy, to give radiotherapy to those patients if they have a low metastatic burden. Not everyone agrees, and there are ongoing trials in the UK, in the US, to keep asking this question. And I would say that the people that are most against this are surgeons. And why is that? Maybe a bit of conflict of interest, because there is a big randomized trial ongoing in the US called SWOG 1802 that started in 2018. Stampede was reported late 2018, so that's a big problem for them. But that will investigate the role of surgery in this setting. That would be very interesting. In the UK, Prasanna Surya Kuranam, I don't remember exactly the name, but also has performed a phase 2 called Trombone, and they were about to roll out to a phase 3 of surgery, because it might be that surgery would work in this setting as well. In this setting as well, it's going to be difficult in the UK because now radiotherapy is standard of care in the NICE guideline, but we'll see. In terms of type of treatment, because there are a few radiation oncologists, but that might have implication for surgeons, here we would treat only the gross disease, so only the prostate. Only the prostate or the prostate plus SV in patients who are T3B, but we don't treat prophylactic regions, so only the prostate. And if you were to do surgery on those patients, probably it would not be relevant to do prophylactic lymph node dissection, because what you want to do, what improves, to my understanding, the prognosis of those patients is to remove the bulk of disease, most of the tumor cells. But you're not going to remove everything. We're not going to cure them with radiation here. We're just reducing the number of tumor cells, so we are delaying resistance to treatment, we're delaying the appearance of other metastases, and that's what improves the prognostic of the patient. So you want to, and then you want to provide as little toxicity as you can to a population of patients who are in palliative conditions. So that's the philosophy of treatment. I don't know if you want to comment. So reduce tumor burden, prolong hormonal sensitivity, delay the introduction of hormonal therapy, and that would be the goals of the treatment of the oligometastasis. So now we're shifting to, okay, we agree we have to treat the primary disease. Do we need to treat the mets? We need to treat the Mets. The goal could be to cure metastatic patients. I mean, we could. I mean, one can hope. So that's a third patient, born in 1943. He had a prostatectomy when he was 64. PT2A, no positive lymph node out of 2. That was back in the days when only a limited lymph node dissection was performed, and you had 1 node on each side. And we all know that it's something that should not be performed anymore. You do the lymph node dissection extended, or you don't do it. You correct me if I'm wrong. R0. So, and he was he had a biochemical recurrence in 2015, but had no treatment. And I met him in 2 years ago, January 2018, and his PSA was 3.5. So with that level of PSA, we always suspect that the patient has not only a few cells in the bed of the prostatectomy, but he might have metastasis. And he had a choline PET-CT in 2017. He had a single bone hyperfixation and 2 pelvic lymph nodes. He underwent, there's no question here, so he underwent, we discussed with the guy what he wanted to do. The standard of care would have been systemic treatment alone. Completely agree. But we were in the process of starting a randomized trial that I will tell you, and so we also offered him to be treated like he would have been on the randomized trial. And so he had ADT, because he has metastatic disease. He had radiation to the lymph nodes. So I've written 2, but here you see there are probably 3 nodes. So he had radiation to the lymph nodes and a prophylactic treatment to the nodal basin. And he also had stereotactic body radiotherapy on the vertebrae. He was okay. He lives in Nice, in the south of France. So it's one of my colleagues in Nice who sees him and he sends me news. So he's okay so far. Now he has stopped hormonal therapy. His testosterone is normal. And the PSA has not recurred, but it might recur in the future. It's been just 2 or 2.5 years. So what do we know about ablative treatment in the oligometastatic setting? There are some retrospective data, and I will not spend too much time on that. Basically, what they show is that if you just give treatment to the oligometastatic disease, you can delay the introduction of hormonal therapy by a little bit less than 2 years, but all those patients will recur. So if you just give them local treatment, radiation, IR, surgery, they will all recur. And so there was a randomized trial by Belgian colleagues. It's called the STOMP trial, published by Piet Oost and updated this year. It's a randomized phase 2 study with 62 patients, something like that. I don't remember. 60, so few patients who had recurrence after local treatment based on PET choline and usually a slowly rising PSA, which meant that they could offer the patients to be randomized between surveillance, so no treatment for metastatic disease, just watchful waiting, and local treatment. The local treatment could have been surgery or stereotactic body radiotherapy. Those patients were mostly nodal recurrences. So 50% of the patients had only nodal recurrence, either in the pelvis or in the retroperitoneum as well. And the follow-up was short. And what they show, and we can go to the curve immediately, what they showed is the primary endpoint was ADT-free survival. So the time before you start ADT. And you can see here that with metastasis-directed therapy, ADT was delayed a little bit compared to standard treatments. That's the intent to treat curve. Here is the per protocol curve, because some of the patients randomized to surveillance actually had metastasis-directed treatment. And you see that there's a little bit more of distance between the two curves. It's still not significant, but it's 62 patients, so probably not enough patients. ADT is a very soft endpoint. ADT-free survival, because it's very subjective. When you decide to start ADT, you can wait 3 more months. Okay, he had radiotherapy, we can give him 3 more months before we start ADT, so it's a very soft endpoint. But the indications for starting ADT were actually quite clear, and in more than half of the patients, it was due to polymetastatic progression. So quite obvious reason to start ADT. But again, soft endpoint. What's interesting and not completely clear to me is that when they've done this subgroup analysis, the patients that appear to benefit the most from local treatment were the ones that had a PSA doubling time of less than 3 months. Although intuitively, those patients with very rapid doubling time, you would suspect that they would have lots of mets that would appear very quickly. But that's the way it was performed. It can just be a false positive subgroup analysis. Let's not get too excited. There's another one that's now been published in JAMA Oncol, I believe. That's called ORIOL, and that also randomized patients between surveillance and stereotactic body radiotherapy. Very small trial, 54 patients, and it showed also that if you treat the Mets, you have a better control of the PSA. That's not very surprising, but they had the p-value of 0.049, so just below 0.05, very happy. And of course, that doesn't make standard of care, but that gives you indication that there might be some role there. I believe that currently we are not being too smart enough, and we are just defining oligometastasis based on the count of the metastases, number of metastases. And of course, that's very naive, and we know that some patients with just 1 MET can have a very rapidly progressive disease, and other ones with same number of metastases can have a slow-growing disease. And that's the first case that we've discussed, to the first 2 cases that we've discussed today. Those 2 guys had only 1 MET each. So what's being used more and more, and as Alexandre discussed earlier, is the use of genomic signatures. They are not available in France for reimbursement purposes, but clearly they can complement the clinical staging for favorable disease, for localized disease, and they will be used to define which patient should receive local treatment for metastatic disease. Currently, we just count, and we count up to 5 because we have 5 fingers in one hand. But we don't. Why 5? Why 3? Why 5? We don't know. So we have started a randomized trial. So I'm the PI of this trial. It's called Presto. It got funded in 2016. It just started now in 2020, so 4 years later. So it's not very presto, but it's okay. And those patients need to be hormone sensitive, metastatic, either de novo or after local treatment, so surgery or radiotherapy and recurrence afterwards, up to 5 metastatic lesions, including 1 bone met. Why is that? Because the uro-oncology community felt that patients who had only nodal disease, they do better than the other ones, and they would need a local treatment of the Mets. So that can be discussed, but okay, at least 1 bone met. And they are randomized to standard of care. The schema has changed a little bit. So standard of care, which is ADT plus another systemic treatment, chemo, new hormones, and radiotherapy to the prostate in de novo metastatic patients. And what is randomized is the stereotactic body radiotherapy to all the metastatic sites. And we'll see if that makes any difference. The endpoint is survival without castration resistance. So it's a surrogate for survival, for overall survival. Because even with that kind of endpoint, we needed a sample size of 350 patients, which is already a lot for such patients. The trial now is open, and we have included 5 or 6 patients so far. So it's starting quite nicely. I would like to say. But with this trial, we will know more. The Canadians are doing the same trial, very, very similar trial. And the major competition will come from the Stampede team, who is doing also the same trial. but with 2,000 patients, Stampede-like. And the other difference with Stampede that will be very interesting is that the Canadian and us, we define oligometastatic disease on PET-CT. The UK, they define oligometastatic disease on bone met and CT. So they will have patients with bigger mets. And maybe they will be the winners. Why is that? Because I believe that if radiotherapy to the prostate works, it's because there are lots of cancer cells in the prostate, and so you remove, you destroy a big amount of cancer. With PET, PSMA, or even with choline PET, the mets that you see are very small. So maybe you will not see, you will not decrease the tumor burden by a lot. So that's maybe the difference in survival. I don't know if I'm clear, but clearly it's not, will not be the same population of patients. What we can achieve that they will likely not, especially if we use PSMA to stage those patients, is we could cure some patients. If some patients actually only have disease in a few lymph nodes and one bone met and we destroy everything, then maybe we could cure the patient. If you define oligomets on bone scan and you destroy that, there's likely cells outside of just what you see. So they exist, but we know the oligometastases exist. We've met them, but we've met them just based on the count of our fingers. So we don't know exactly how to define them. We need RCTs, and as you can see, I had prepared this slide in 2018. So I was hopefully Presto will open in fall 2018. So it was 2 years later actually, but now it's open. So let's cross fingers. Merci. Any questions on oligometastatic disease or the way we should treat them or not treat them? So in the STOMP trial, some of those patients, it's probably written, some of those patients had surgery, like 5 or 6 patients, and there were 6 toxicities for the local treatment, and including 4 in the 6 patients that were surgically treated. I believe it's not only lymph node dissections. One of them had a wedge resection of a lung tumor, and so they were pretty aggressive. But I would say that we have to adapt to the type of procedure because we don't want too much risk of complication in patients who are metastatic and would likely die from their disease. So side effects is important, but local control is also important. So in some patients with bone met that can have cause problems, then bone surgery could also be discussed. So So I mean, in the Presto, it's only radiotherapy, but it's because it was developed like that. But in the future, I think we need multimodal also treatment of the mets, interventional radiology as well, and not only radiotherapy. We just need to be mindful that those patients are metastatic and we don't want to cause too much side effects.
My question is the case number 3. There is bone metastasis and lymph node
Mm-hmm.
My question is why you treat prophylactic is metastatic?
To the lymph node.
Prophylactic radiotherapy to the pelvis. Why not just sterile vaccine is metastatic?
Yes, it's so no good answer. So in the design of the Presto trial, we've tried to prepare all those cases, and clearly in the radiation oncology community, some want always to treat prophylactically because we see 3, but there are likely 5 or 6, and that's the way they do it. That's also probably the way it's going to be written in the trial. Currently, it's not very clear, so people can do whatever they want. If you believe that the effect is based only on the dose to the gross disease, then you don't need to treat prophylactic. I agree. If you want to cure some patients, then you would need to do also the prophylaxis around that. That's the way we've done it. I think we don't really know. We don't really know.
Thank you very much.
You're welcome.
I believe that you had a lot of data today, a lot of studies, a lot of new things, new concept. I think we are going to stop now the session. I have to tell you that you have to be at 7:30 at the lobby, and we are going to take the bus to go to a nice boat on the Seine River, and we'll have a nice evening there. Okay? I hope you enjoy the session. Have a break, and we see you all, of course, for the dinner. Thank you.